Good morning. Today is 20th of August 2016 in this beautiful hotel at Sinclairs Tourist Resort, Burdwan. It is my extreme privilege to welcome you all for the CME inauguration of the 29th Annual State Conference of Indian Psychiatric Society, West Bengal, and the 10th Annual State Conference of the Indian Association of Private Psychiatry, West Bengal. Jointly, we named it Psychiatric Conference 2016. The theme this year is
And on this note, I would like to say a few words about thanking our teachers. They have given us the knowledge and the help to encourage each young and growing mind. May we have faith that is evident in all of us, and may we today learn from each other in this next 2 days that we spend together as fellow colleagues. It is time now to inaugurate the CM inauguration, and for that, I will welcome two most eminent psychiatrists with us who are here today. Dr. Devi Prasad De, welcome sir. Dr. De has been a retired ex-professor and head of the department of Burdwan Medical College and has an extreme wealth of academic accolades, and we are indeed privileged to have you with us today, sir. May I also invite Dr. Shomir Chandra Nag, a very eminent and an extremely senior psychiatrist of Burdwan, who has initially worked with Burdwan Medical College and has been in full-time private practice since then. We welcome you, sir, at the inauguration of our CME. Bouquets will now be presented by Dr. Shurcha Roy to Dr. De and Dr. Nag. May I call upon the stage the State President of Indian Psychiatric Society, Dr. R. Brahmo. May I call upon Dr. R. R. Ghosh Roy, President of West Bengal IAPP. Bouquet and a memento will be presented to Dr. Ghosh Roy. May I call upon the stage Dr. Nilanjana Paul, State General Secretary of Indian Psychiatric Society. Dr. Paul, please. And may I also call upon the stage Dr. Hina Borat Roy, State General Secretary of Indian Association of Private Psychiatry. Dr. Devashish Chanyal, please may we ask you to join the dignitaries of the stage as the chairperson of the CME, and the two most important people whom we all know at this conference, who's put their heart and soul along with a host of other colleagues locally working here. Dr. Devashish Konar, the organizing chairperson of this conference, and Dr. Devjani Bandyopadhyay, the organizing secretary of this conference. Please join us on the stage. Thank you. Mementos and souvenir bouquets will be presented to all of them. Okay. Once all the bouquets have been given to our dignitaries, and a very, very warm welcome to everyone on stage. May I request Dr. Roy to present to Dr. Shomir Nag a memento from the organizing committee of the conference. And also to Dr. D.P. Day, and to Dr. Shomirnag, please. Thank you. Mementos are now being presented on behalf of the organizing committee to our inaugurators for this conference. May we have a loud round of applause, please. It's been a fantastic morning. Everyone's here. It takes a great effort to come. So please, thank you very much. Now that we're having a few people more trickling in, before I formally invite Dr. Konar to deliver the welcome address as the organizing chairperson, I would like to introduce myself. I'm Dr. Rajeshri Ray, and I'll be your master of ceremony and anchor for the whole day. Thank you. Dr. Konar, for your welcome address, please, sir.
Thank you. A very good morning to our invited guests, seniors, friends, and junior colleagues. It feels good to meet all familiar faces in our own place, Burdwan. In line with the theme of conference, Psychiatrist as Physician, Emerging Perspectives, we are here for continuing medical education program. CMEs are planned to benefit the juniors and PGTs most, but also help the seniors to keep themselves abreast with newer developments. Who is himself a great academician, has designed the CME in such a way that all medical areas where the psychiatrist needs to have good acumen will be covered well during the day. You also have credit points for attending CME. Hope you benefit from the presentations made by the team. Warm welcome to CME hosted by IPS and AIPP West Bengal branch in green heartland of Bengal, Burdwan. Have a wonderful day ahead. Thank you so much.
Sir, may I now request our inaugurators and our most distinguished guests, Dr. Shomirnag and Dr. D.P. Day, along with Dr. Debashish Sanyal, to light the lamp and formally inaugurate the CME of the Psychiatric Conference 2016. Please, all dignitaries also join on the stage to light the lamp. Dr. Paul, Dr. Mollik, Dr. O.P. Singh, sirs, please, Dr. Mollik, please come and join on stage to formally inaugurate the CME and give your blessings to this whole audience who will be with us for the next 2 days. A round of applause, please. And may this conference receive all the blessings and have a great start, great going, and a great finish tomorrow evening. Thank you. On a funny note, on a very auspicious occasion, I just want to share Fred Allen's words, who said, "A conference is a gathering of important people who singly can do nothing, but together can decide that nothing can be done." Do we agree? But I'm sure we will all agree to have a fantastic time at this CME and share the knowledge amongst each other. Okay. May I now request Dr. Sanyal to deliver the inaugural speech of this conference.
Good morning to everyone. Well, as a chairman of this academic session that we are going to see today for these next two days, well, I extend my warm welcome to all of you. It's an honor to have senior people amongst us who are there to guide us and, well, guide us towards future, a better future, obviously. Now, this CME program has been devised basically to try to bridge the gap between practice and academics possibly. It is often said by practitioners that whatever is discussed in the conferences are very much theoretical. That doesn't help people in their practice. After all, practice sometimes means innovating, modifying, and that often is left out. Much of theoretical discussions is held, and many practitioners do not find CMEs to be useful. Our endeavor has been to try to bridge this gap. In this endeavor, I have been very lucky to get help of a lot of people, my colleagues and seniors, who has been of great help to try to formulate the program, try to select the speakers, and so that a clear-cut mix of academics and what is required for a practitioner, that gap can be bridged to some extent. I believe the program will be useful to everyone. That includes postgraduate trainees, busy practitioners, and others. So, with this, I would like you all to be present for this conference, try to enjoy the sessions, not only enrich yourself, also enrich all of us with your own experiences, and thus make this CME a success. Thank you very much.
Thank you, Dr. Shanyal. And finally, may I now call upon the stage the organizing secretary of this conference to deliver the vote of thanks, Dr. Debjani Bandyopadhyay, please.
Thank you. Respected dignitaries on dais, the guest invitees, my senior and junior colleagues, and my very dear friends. It's my privilege to propose the vote of thanks for the inauguration of the CME of the 29th Annual State Conference of the Indian Psychiatric Society, West Bengal branch, and the 10th Annual State Conference of the Indian Association of Private Psychiatry, as West Bengal, jointly as Psychiatric Conference 2016, which is taking place today at the Sinclairs Tourist Resort, Burdwan. And the theme we all know is the Psychiatrist as Physicians, Emerging Perspectives. I, on behalf of the organizing committee, present my most sincere thanks to our most distinguished inaugurator, Dr. D.P. Dey and Dr. Shomi Chandranag, for being our teacher and guide in the truest sense, and by honoring us by inaugurating the CME. At this point, I can't help but mourn the demise of Dr. Ashit Baran Patro, whom we all loved, and we all miss him today dearly. A big thank you to Dr. Debashish Sanyal, the Chairperson Scientific Committee, and his advisors, Dr. Abir Mukherjee, Dr. Nilanjana Paul, and Dr. Shayantan Patro, for putting together such a wonderful academic feast that we shall be attending today. My heartiest thanks to Dr. R.K. Brahmo, President, Indian Psychiatric Society, West Bengal branch, Dr. R.R. Ghosh Roy, President, IAPP, West Bengal branch, Dr. Nilanjana Paul, Secretary, IPS, West Bengal branch, and Dr. Hena Bharat Roy, Honorary Secretary, IAPP, West Bengal branch, for helping us in every step of the way in organizing this CME. Thank you, sir. I take this opportunity to extend our most sincere thanks to all our guest invitees who have come from different destinations for their support and cooperation. I wish to express my gratitude to Dr. Debashish Konar, the organizing chairman, for his minute-to-minute guidance and support, and for providing encouragement at every point of time in organizing this event. An event of this dimension cannot happen overnight. It requires meticulous planning and execution and an eye for details. I cannot thank enough everyone in the organizing committee for involvement they have shown and the willingness they have expressed to take on this completion of this task, which is actually beyond many of their comfort zones. Many of them are very busy practitioners. My most sincere thanks to all the delegates who have given us their time to come to Burdwan to attend this conference. If not for you, this conference wouldn't be successful. Heartiest thanks to Dr. Joydev Tudu and Dr. Rajushree Roy for organizing this inaugural program. And my most sincere thanks to all our sponsors who have helped us immensely. We thank you for being with us today. Thank you so much.
Thank you, Debjani. With this, we come to the close of the inauguration of the CME of the Psychiatric Conference 2016. And I would like to finish this with a huge round of applause for each and every member of this room. Thank you. 2 minutes past 10 o'clock, so we're on time. The next 1.5 hours will be our first CME session. With the good news first for the audience, so that we are all awake, even after a lovely breakfast and a cup of coffee, that there will be a Best Question Award. A Best Question Award that will be given to the best question from the audience, and that will be decided by the individual chairpersons for the sessions. So please try and participate heartily in this conference, because as we know, education is a movement from darkness to light, so we are all here together to enlighten each other. Now, as we are setting this stage for the first session to start, I would like to say that this next 1.5 hours is divided into 3, with 3 speakers on 3 different on these presentations. And for the first session, I would like to invite Dr. Parthapratim Roy, Dr. Ashim Kumar Mollik, who Dr. Mollik needs really no introduction. We know that he's held very senior posts at the national level at the Indian Psychiatric Society, including being the Honorary Secretary, sir. So may we invite you on stage to chair the next...
Today now the very first session of the today's CME, joint CME of IPS and IIPP, annual CME. The first, my co-chairperson is coming, joining with me. Before that I am starting. The first topic of this session is the tobacco cessation. All of you know that the tobacco smoking is a great problem to our society. It causes so many difficulties among the who smokes it and who do not smoke also. Mainly the 3-4 material on tobacco can be taken by smoking form or without smoking form, chewable form. In both cases, it harms the people. Mainly the 2-3 products are mainly responsible for that. Number 1 is the nicotine. Though nicotine is not so much harmful, but other than nicotine, in smoking there was a tar, carbon monoxide, aldehyde. These causes mainly problem to the smokers also, and the passively who are outside the smoking zone. Tar is responsible for the lung cancer, and carbon monoxide is also responsible for the cardiac disease. So it is the main cause of death who are smoking, and it also passively harm for the other people also. Today, Dr. Aurobindo Bommo will discuss about the tobacco cessation. All of you know that Aurobindo Bommo is a known face, all of you, because he served IPS as a secretary, he served IAPP also as a secretary for a long time. Now he is the direct council member of the Indian Psychiatric Society, All India body. Now Aurobindo is working as a consultant psychiatrist at Uma Nolini Clinic and Research Institute, Salt Lake, and Kolkata Police Hospital, and honorary lecturer in Indian Psychoanalytic Society, Kolkata. He did his post-graduation from the Institute of Psychiatry, IPGMER, Kolkata. He has received various zonal and national level awards of IAPP and IPS, including prestigious Bhagbat Award in 2008 and Marfatia Award in 2014. He has published more than 50 papers in different national and international journals. Currently, he is the direct council member of the Indian Psychiatric Society, East Zone, and East Zone representative of the Executive Council of the Indian Association of the Private Psychiatry. He is also the chairman membership committee of the IPS, Eastern Zonal Branch, and Assistant Secretary of IMA, Bengal Branch. He is the immediate past secretary of the West Bengal State Branch of the Indian Psychiatric Society and Indian Association of the Private Psychiatry. Before inviting Aurobindo, my co-chairperson Parthoda has also joined. I ask Parthoda to speak one or two lines and invite Aurobindo for his speech.
Thanks the organizer for allowing me to chair this session. Without spending much time, I am directly requesting Dr. Aurobindo Brahmo to speak on tobacco cessation.
Hello, the organizer has requested the time is 25 minutes. So I request the speaker to keep time.
The organizing secretary and Dr. Devashish Kona, the organizing chairman, for allowing me to speak on this opening session of this joint state conference of IPS and IFB 2016 here at Burdwan. So my topic is tobacco cessation. We know to assist people to lead a meaningful life, mental health providers need to promote behavior that lead to a good mental and physical health. And we know individuals with mental illness must be recovered from their illnesses, and tobacco use is potentially the most modifiable risk factor for decreasing excess mortality and morbidity. Now, tobacco cessation is a key component of many individuals' recovery, and it is a priority issue for every health provider. And different studies also shown that people with mental illnesses want to quit smoking, contrary to the popular belief, and they want information about cessation services and resources. So why to address this particular issue? Because people with mental illness can successfully quit using tobacco. There is significant evidence that shows that smoking cessation strategies do work. An individual with mental illnesses, they deserve accurate information regarding tobacco use and option for quitting, because this is a patient's rights issue. Now, persons with mental illnesses are disproportionately affected by tobacco use, and they are not receiving adequate information and cessation services in most parts of the world. They are a real and perceived barrier to providing smoking cessation options in mental health and substance use setting. Now, it is unfortunate that many clinicians, they do not view tobacco cessation as a part of their scope of practice. They feel tobacco cessation could be detrimental to the treatment plan, and that tobacco use is not a treatment priority to them, and that tobacco cessation strategy would be too time consuming. Now, if you look into the Indian scenario, there are approximately 120 million smokers in India, and according to WHO, India is home to 12% of the world's smokers. And approximately 1 million people die every year in India due to smoking. So you can think of the magnitude of the problem. And cigarette and bidi smoking causes about 5% of all death in women and 20% of all death in men aged between 30 to 70 years. Now, this is a US study, because in India we don't have this type of prevalence study. This is a US study that shows prevalence of smoking among people with mental illness is quite high. Like in major depression, about 36 to 80%, in bipolar affective disorder, about 50 to 70%, schizophrenia, 60 to 90%, anxiety disorder, 30 to 60%, alcohol abuse, 34 to 93%, and other drug abuse, 49 to as high as 98%. So people with mental illness and substance abuse disorders are nicotine dependent at a rate that are 2 to 3 times higher than the general population. And because people with mental illness use tobacco at a greater rate, they suffer greater smoking related medical illnesses and mortality. Therefore, smoking cessation is a key component of consumer driven individualized treatment planning. Now, if you consider the mentally ill patients, so people with mental illness, they use tobacco at a higher rate. They are less likely to succeed at cessation attempt. They access general medical services and other community resources relatively infrequently than the general population. They struggle with stigma on several levels, and they generally experience a greater burden of morbidity and mortality than the overall population. Now, why do they smoke? Why do the mentally ill persons smoke more? Researchers believe that a combination of biological, psychological, and social factors that contribute to increased tobacco use among persons with mental illness. Now, if you consider the biological factors, persons with mental illness, they have unique neurobiological features that may increase their tendency to use nicotine, make it more difficult to quit, and complicate the withdrawal symptoms. Now, nicotine affects the action of neurotransmitters like dopamine. Like people with schizophrenia who use tobacco may experience less negative symptoms or less auditory hallucination, you know. And nicotine, on the other hand, enhances concentration, information processing, and learning. And this is particularly important for persons with psychotic disorder for whom cognitive dysfunction is a part of their illness or a side effect of the antipsychotic medication. Now, if you consider the psychological factor, tobacco use may temporarily leave feeling of tension and anxiety in them. They often use to cope up with the stressful situation, and people develop a daily routine of smoking. If you consider the social factors, people may smoke to feel they are part of a group, a smokers group, and smoking is often associated with different social activities. So, person with mental illness may not have a lot of activities to keep them busy, we all know that. So, when they are bored, they may smoke more. Now, if you come to the individual psychiatric illnesses and smoking, among patients seeking smoking cessation treatment, about 25 to 40% have a history of major depression, and many have minor dysthymic symptoms. Here, the cognitive behavioral therapy for depression and antidepressant has been found to improve the smoking cessation rate in those with a history of depression or symptoms of depression. In case of schizophrenia, persons with schizophrenia who smoke may be less interested in tobacco cessation, making strategies to enhance motivation to quit especially important for them. When patients with schizophrenia do try to stop, many are unsuccessful. Therefore, intensive treatment are appropriate even with early attempts. And the high prevalence of alcohol and illicit drug abuse in patients with schizophrenia, that can interfere with the smoking cessation process. We know blood level of some antipsychotic can increase dramatically with smoking cessation, and nicotine withdrawal sometimes mimic akathisia, depression, difficulty concentrating, and insomnia in patients with schizophrenia. Now, if you consider the co-occurring substance abuses, tobacco use is strongly correlated with development of other substance use disorders with more severe substance use disorder. And tobacco appears to affect the same neural pathway, that is the mesolimbic dopamine system, as alcohol, opioid, cocaine, marijuana, they all share. And the concurrent use of alcohol and or other drugs is a negative predictor of smoking cessation outcome during smoking cessation treatment. So we should remember that when a person with mental illness make an attempt to quit, they should be followed closely to monitor for more severe nicotine withdrawal, exacerbation of their psychiatric disorders, and the possible side effects due to cessation-induced increases in medication levels. Now come to the assessment part. The stages of change model, which is popularly known as the trans-theoretical model, that is useful in recognizing the nicotine dependence, is a chronic relapsing disorder with most tobacco users in the general population requiring multiple attempts before they finally quit for good. So we should consider this tobacco cessation as a process rather than an event. Now, what is this stages of change? The first stage is a pre-contemplation, that is the individual is not considering quitting. In the contemplation stage, they intend to do so in the next 6 months. In the preparation stage, the individual is actively considering quitting in the immediate future or within the next month. In the action stage, the individual is making overt attempt to quit. However, the quitting is not effective for longer than 6 months. And finally, the maintenance stage, where the individual has quit for longer than 6 months. Now, the US Public Health Service Clinical Practice Guideline treating tobacco use and dependence, they recommend 5 A's. That is, they recommend that all people entering a healthcare setting should be asked about their tobacco use status. The providers should advise all tobacco users to quit. They should assess their willingness to make a quit attempt. Persons who are ready to make a quit attempt should be assisted in the effort, and follow-up should be arranged to determine the success of quit attempt. They also recommended 5 Rs, that is relevance, risk, reward, roadblock, and repetition, that is designed to motivate smokers who are unwilling to quit at the present time. Why the smokers are unwilling to quit? Because of misinformation, concern about the effect of quitting, and the demoralization because of unsuccessful quit attempt. This is very common, we know, in our day-to-day clinical setting. So in the relevant stage, the healthcare provider should encourage the individual to indicate the quitting is personally relevant as specifically as possible for that particular patient. The motivational information has the greatest impact if it is relevant to a patient's medical status or risk, family or social situation like having children in the home, health concern, or other important patient characteristics like prior quitting experience, personal barrier to cessation, etc. Risk. We should ask the individual to identify potential negative consequences of tobacco use, and we should suggest and highlight those that seem most relevant to the patient. And we should also emphasize that smoking low-tar or low-nicotine cigarette or e-cigarette nowadays, you know, or other form of tobacco like smokeless tobacco, cigarette, pipe, that will not eliminate this risk. So there are 3 stages of risk. First is the acute risk, that is the shortness of breath, exacerbation of asthma, harm to pregnancy, impotency, infertility, we all know that. And the long-term use like heart attack, stroke, lung and other cancers, COPD. There are certain environmental risks also like increased risk of lung cancer and heart disease in spouse, higher rate of smoking in children of tobacco users, increased risk for low birth weight babies, sudden infant death syndrome, etc. Now, what are the rewards if a person quit smoking? That should be also emphasized. That is improved health, food taste better, improved sense of smell, money saved, better self-image, no more worrying about quitting, set a good example for the children, feel better physically, perform better in physical activities and all this. But there are certain roadblocks. And the typical barriers include the withdrawal symptom, the nicotine withdrawal symptoms, fear of failure, weight gain, lack of support, especially the social support system, depression and enjoyment of tobacco, which is one of the most important factors. And in the repetition stage, we should repeat motivational intervention every time an unmotivated patient visits the clinic setting. And tobacco users who have failed in previous quit attempts should be told that most people make repeated quit attempts before they are successful. That is very important. Now come to the last part of my treatment discussion, that is the smoking cessation treatment. Smoking cessation model for persons with mental illness, they generally combine nicotine replacement therapy or other medications with cognitive behavior therapy that particularly focuses on changing dysfunctional thoughts, emotions, and behavior. And the group CBT program that produced the most successful quit rate for mental health population that generally have a group of approximately 8 to 10 individuals, and they meet once a week for 7 to 10 weeks. Now come to the different drugs that is available in the market. We all know bupropion. To start with 150 milligram daily, then after 3 days we should increase this 150 milligram twice daily for 7 to 12 weeks. And the common side effects are insomnia and dry mouth. Nicotine gum, that is also available. If a person smokes more than 24 cigarettes, less than 24 cigarettes a day, then 2 milligram gum to start with. And if it is more than 24 cigarettes per day, then 4 milligram gum to start with, up to 24 pieces per day for about 12 weeks. And the common side effects are mouth soreness, dyspepsia, and hiccups. Nicotine lozenge is also available. Here we start in the first 6 weeks, 1 lozenge every 1 to 2 hours, gradually tapering, then week 7 to 9, lozenge every 2 to 4 hours, week 10 to 12, 1 lozenge every 4 to 8 hours. And here also the duration of treatment is 12 weeks, and the common side effects are mouth and throat soreness and dyspepsia. Nicotine patch is also available in India, and here the common side effects are local skin reaction, insomnia, vivid dreams. To start with, for the first 4 weeks, 21 milligram patch for 24 hours, followed by 14 milligram in the 24 hours, and followed by 7 milligrams in a day. So the total duration of treatment is 8 weeks. There are other substitution therapy available like nicotine inhaler. I don't think it is available in India, nicotine inhaler. Here also the duration of treatment is up to 6 months, and the common side effects are local irritation of mouth and throat. Nicotine nasal spray is also available. Here also the duration of treatment is 3 to 6 months, and the common side effects are nasal irritation and change in sense of smell or taste. Varnish clean, we know it is available to start with. We should start vernicillin 1 week before quit date with a dose of 0.5 milligram a day for 3 days, followed by 0.5 milligram twice daily for next 4 days, and then increase to 1 milligram twice a day for 3 months. And here maintenance can be done up to 6 months. And the common side effects are nausea, trouble sleeping, abnormal dream, and constipation. Some author also recommend clonidine at a dose of 0.15 to 0.75 milligram per day, or 1 patch per week for 3 to 10 weeks, or nortriptyline even. That is at a dose of 75 to 100 milligram per day for 12 weeks. And here the common side effects are sedation, dry mouth, constipation, and dizziness. So the take-home message is, tobacco epidemic is one of the biggest public health threat that world has ever faced. Tobacco use is a major preventable cause of death and disease, and it is responsible for 1 in 10 deaths among adults worldwide. Mass media campaign, graphic warning, now you can see in the cigarette pouch, there is graphic warning. And another very important issue is alternative crop option for tobacco growers. That can help stop or reduce tobacco-related deaths globally. So timely intervention can support individuals' overall wellness. Thank you. Thank you for your patience hearing.
Thank you, Dr. Aurobindo Brahmo, for this very nice presentation. Tobacco smoking is still a serious problem and is associated with so many major psychiatric illness. But the problem is that very few of them come for help. Now it is open to the audience for question.
Ortho. Pichone mic.
Thank you, Chairman and Dr. Aurobindo Brahmo for a very relevant and very good topic you have selected for this conference in the beginning. And it is really a problem today. But one thing what I want to ask you, actually in our practice we find that, or in our experience daily life, many people smoke cigarettes or bidi like that. Village people use bidi, and also city dwellers also use bidi, and cigarette is also very common. But not, my question is in every case there is a association with mental disorder? Because many people habitually smoke bidi or cigarette, and they don't seem to be they are not suffering from associated mental problem. And this is one thing. And what to do about this problem? Because we practitioners feel very helpless, because they are advised. They first of all do not come for help, for advice. It is their habit, and they can use that as a routine, like a food, they are taking that. But what to do about that? You have spoken a lot of things, very good discussion, that from the public health point of view, by propaganda, by mass media, all those things. But still it is a burning problem, and we have those chewing gums and all those things we know. But how to motivate them? You told about cognitive behavior therapy, very good things. But it is still a burning problem. And we practitioners feel very helpless. We think nothing can be done. And in general, for any substance abuse, we say they sometimes quit, we put them to rehabs, and when they go back to the community, they again take that. we people feel very helpless. Not only for cigarette or any bidi, but also for any substance, alcohol or anything. So can you highlight on this very important issue?
Thank you, Partha, for this question. Very relevant from the clinical point of view. Basically, you are right, absolutely right. That is, we know a person, whether he smokes or drinks, the basic idea is he or she is getting pleasure out of this. That's why most of the people in the world, they have any kind of substance abuse problem, what you are highlighting. Not only the mentally ill patients, definitely they are among the mentally ill population, the co-occurring substance abuse prevalence is definitely high. However, in the normal population also, it is quite high. But only problem is that unless and until the family members or the patient comes to us for help, we cannot help, number one. Number two is, because the person is getting just pleasure out of this, nothing else. Any substance abuse means the person is getting pleasure out of this. So, if the person is not at all motivated properly, it is very difficult. It is almost impossible, and that we face every day. We try different methods. We ask them to go for counseling and go for cognitive behavior therapy, all this. But if the person is not motivated, at least till date we cannot help. But you know, this nicotine patch, recently I got good result with some people when they are using this nicotine patch, and the person is slightly motivated. We are getting some good result. And there is other nicotine replacement therapies, you know, this nicotine gum or nicotine lozenge. But basically we found that person is smoking, at the same time he is taking nicotine gum or nicotine lozenge. So overall nicotine consumption is going high. That is the problem. So motivation of the particular person or the patient, I think that is the most important issue here.
Your name please.
Doctor, আমি একটা সত্যি ঘটনা বলছি। হ্যাঁ, রিগার্ডিং স্মোকিং অনেকগুলো হয়েছে। আমি একদিন ট্রেনে করে যাচ্ছি, তো
you asked a specific question, not your.
আপনি আমাদের শুনুন, বেসিক প্রশ্ন দিয়ে কাজ হবে না, আমরা সবাই এগিয়ে আসতে হবে, পার্টিকুলারলি পলিটিশিয়ান এগিয়ে আসতে হবে। আমরা দুই একজন কিছু করতে পারবো না, নিকোটিনগুলো কেউ নেবে না। আমাদেরকে সবাই এগিয়ে আসতে হবে, ইনক্লুডিং পলিটিশিয়ান, না হলে কোনো কাজ হবে না। একটা শুধু উদাহরণ দিয়ে দিচ্ছি, আমি এসএসকেএম হসপিটাল চাকরি করি। একদিন আমি ট্রেনে করে যাচ্ছি, একটা ভদ্রলোক লিলুয়া ছেড়েছে, বিড়ি ধরেছে। আমি বললাম, বড়বাবু বিড়ি খেলে না খেলে নয়, নিচে যেয়ে খাবেন। হ্যাঁ, বলে রেগে গিয়ে কিছু বললো না। আমি প্ল্যাটফর্মে নামলাম, সে আমাকে বারবার দু চারবার পা দিয়ে ফেলার চেষ্টা করলো। জাস্ট আমি আগে ফুটবল খেলেছিলাম বলে ম্যানেজ করলাম। সাবওয়ে নামলাম, কলার ধরে আমাকে উঁচু করে বলে, সালা মেরে ফেলে দেবো তুই যদি এরপরে যদি কিছু করিস। সুপারে যাচ্ছিলাম। তারপর আমি থানায় গেলাম, থানায় বলতে এটা আমাদের এখতিয়ার মধ্যে নয়। আরপিএফকে লিখলাম, ইয়েকে জিএমের কাছে চিঠি লিখলাম। জিএম আমাকে একটা আরপিএফ ইন্সপেক্টর আমার এসএসকেএম হসপিটালে পাঠিয়ে দিল, আমার সঙ্গে মিটিং করে অনেক লেখালেখি করে চলে গেল। দিস ইজ দ্য ফ্যাক্ট। আমাদের এভাবে নিকোটিন ফিন্টুন দিতে হবে না, পলিটিশিয়ান এগিয়ে আসতে হবে, আমাকে এগিয়ে আসতে হবে। কারণ আমি এই ফিগার নিয়ে যদি বললাম, এই ফিগার নিয়ে বললাম আমাকে কদিন মেরে দেবে, শহীদের রক্ত হবে না কেউ, হয়তো আমাকে একদিন মেরে দেবে। তো সবাইকে এগিয়ে আসতে হবে, নিকোটিন প্যাচ দিয়ে কিচ্ছু হবে না।
তো হোয়াট ইজ ইউর সাজেশন?
সবাইকে এগিয়ে আসতে হবে, দিস ইজ দ্য সাজেশন। আমি শুধু একা বললে হবে না, সবাইকে।
ব্যাস, সবাই আমরা এগিয়ে আসবো।
থ্যাংক ইউ। ডক্টর দেবাশিস কুমার।
I have a question. Sayantan.
I'm Dr. Sayantan Patro. The question I have is that the treatments that you have recommended, which of them have FDA approval? And what are the percentage of efficacy that we can expect from these treatments? Like 30% or 50% of people are going to cease smoking. And second question is that in view of the whole thing, as we know, harm reduction, other than total cessation, total abstinence, harm reduction is also a very important concept. People who are having problem in totally ceasing smoking, so how can we actually take them to the path of harm reduction so that they take minimum amount of cigarettes? Is there any treatment modalities guided towards these things?
Actually, bupropion or vernicillin, that is approved, but nowadays people are talking most about e-cigarette, which is not FDA approved till date, and we don't know how much it is safe or the harm reduction, how much it will help in the harm reduction procedure, because we need more studies about e-cigarettes. But vernicillin and bupropion can be used, and we also use this particular thing. And for that part, for your second part, I think that this nicotine patch is very effective, or the particular person is very much motivated, then we can go for nicotine gum or nicotine lozenge.
I have a question. Before allowing Devasis, I ask one question.
Sure.
You have suggested for smoking withdrawal, nicotine patch with cognitive behavior therapy, motivational therapy. In some cases, there are problem without smoking, like gutka, khaini. In that cases, they actually chewable, and that nicotine will be absorbed very slowly in the blood, and the nicotine persists in the body for a long time. In that case, what is your suggestion for the treatment purpose?
Now this nicotine gum or nicotine lozenge, now this is available in different flavor. Like for smokers, if you chew that gum or lozenge, you will feel the same taste what you feel after smoking a cigarette. Or a person, there is gutka flavor nicotine gum or lozenge also. So the person who is taking gutka, he will feel the same taste in his mouth. So that is the alternative.
Now, do they create addiction? এগুলো কি অ্যাডিকশন করে?
হ্যাঁ, ডেফিনেটলি, যেটা বললাম যে আলটিমেটলি দুটোই
we are discussing a tobacco situation.
So that is smokeless tobacco. Smokeless tobacco part.
And now Devasis.
Last question, Dr. Devasis Kola.
This is the last question.
Okay. Thank you. When I got my training in CIP, my professors used to say that smoking is a personal choice, and as an advocate of human rights, you should and you have to allow patients to smoke, whoever wants to smoke. So that was deep in my mind that yes, if it is a personal choice, it should not be, I don't have the right to disturb that. Then I allowed it in my nursing home. Those who are smokers, they do smoke. Then I got admitted to a cardiac unit sometime for my own illness, and I found that smoking is not allowed. And then I inquired, in any of the good hospitals, no department allows smoking. Smoking is not allowed inside hospital. So why this exception for psychiatric diseases? Like, why psychiatrists think so much of human rights when other clinicians, other medical people, they don't think? So I decided to stop smoking in our nursing home hospital. And average stay is 2 weeks. We don't allow smoking. Gives us some trouble with some patients. We give them nicotine chewing gums, and mostly, I'd say 90% cases, it is not a major problem at present, and that prevents fire and all those issues. Sometimes with the smoking, you may have some patient burning the bed seat, and all those issues do come, and staff also start smoking. So it gives a bad environment and a bad message that smoking is all right with us. So I have seen that this is a good decision in my case. I don't know how the others react to it. And the other thing is that smoking is a medium for cannabis also. Many of the patients get admitted for cannabis abuse. If you allow smoking, they go and smoke outside and then immediately start cannabis. It gives them at least a 2 weeks time when they can think about smoking. They can change their habits. At least it decreases smoking in many cases. So I find this useful. What is your reaction?
That is a very practical choice you have taken for your hospital, for your setup. And basically, we psychiatrists usually don't interfere with the smoking habit of most of our patients, unless and until the family members ask for help, that the person is smoking more than 15, 20, 25 cigarettes a day, so can you help us? So I think only in that particular cases we help. Otherwise, most of us we don't, we usually ignore that particular issue of smoking in our psychiatric patients.
No, but when they are with you.
But sir, in most of the indoors I know, including the government setups, they allow smoking. They allow smoking, officially or unofficially. Because when I was a PGT in Institute of Psychiatry, I know if you give some money, the ward boys will give you the cigarette. And in private setting, usually they don't bother. The doctor don't bother whether the person is smoking or not.
But no general hospital.
No general hospital is allowing. Yeah. Because in cardiac or diabetic unit, you will not get it. Yeah. You will not get it. Yeah.
Thank you, and thank you, Aurobindo, for your nice presentation. And I conclude this session with the permission of my co-chairman. Best question, actually, mainly the comments are come. I think the best question goes to Sayantan Patra.
There is actually a prize for the best question award. We're just getting it organized. So what we'll do it, not to waste any till the end of the second session, if you can bear with us. And I'd like to request our chairpersons to give a souvenir memento to our distinguished speaker, please. Speaker with him. May I also call upon stage Dr. Prabir Paul to give the souvenir from the organizing committee to Dr. Roy, and also may I call Dr. Hina Bharat Roy to give the souvenir to our chairpersons, please. Thank you. With a fantastic round of applause, may we bring this session, the first session of the first CME, to a close, and thank you to all.
Best question? Best question? Sayantan ke dibe na? Okay, Sayantan will get a prize.
There is a prize, we'll tag it onto it. The second, Dr. Sayantan Patra. The best question from the audience, as you know, we've got a prize for the best question for each session, and that has been with Dr. Sayantan Patra for the very first session. The second, we could now start the second session of the first CME. May I now invite on stage our distinguished chairpersons, Dr. Prabir Paul. So please come on stage with us. He's been the previous president of the East Zone Indian Psychiatric Society and has organized numerous national conferences to an extreme high standard, and we all look forward to a fantastic time at Kalimpong, which also serves organizing this, is the organizing chairperson this time. May I also invite on stage Dr. Hina Bharat Roy, who is the President Honorary Secretary of the IAPP, and we've just had a small change in the presentations as we're waiting for Dr. Sakal to arrive. So Dr. Rajarshi Chakraborty will be doing the next talk on psychotropics in the heart, but I will request Dr. Paul to introduce him, please. Thank you.
Good morning, everybody. We are on the second session of the program, and the speaker is Dr. Rajarshi Chakraborty. He will be speaking on psychotropics and the heart. And to introduce Dr. Rajarshi Chakraborty, he has graduated from Medical College, Kolkata. He has done his post-graduation from Burdwan Medical College. His current designation is Clinical Tutor Psychiatry, College of Medicine at Sagar Datta Hospital. His areas of interest is obsessive compulsive disorder and organic psychiatry. His achievements include he was the first runner-up in TISA 2011 as in the national round. So he will be speaking on psychotropics and the heart. And we know that all the common, the presently available typical or the non-typical antipsychotics, they are causal factor for the metabolic syndrome, which includes the cardiac pathology also. So it will be, Rajoshi will be more specific on the side effects on the heart. So over to my co-chairperson, Dr. Hena Boratray.
Good morning, my respected seniors, colleagues and juniors. I want to thank the West Bengal State IPH branch for giving me this wonderful opportunity to discuss about such a pertinent topic. I am going to discuss about the psychotropics and heart under the following headings. I will first give an introduction and then why we need psychotropics and antidepressants in heart patients, effect of the individual drugs, some relevant drug interactions, a bit about the psychotropic overdose and how it affects the cardiovascular system, and finally some take-home points which will be helpful in the future. Now to introduce, we know that coronary artery disease is a leading cause of morbidity and mortality. Depression is a significant cause of morbidity. Indians are among the most depressed countries with a daily rate of 1400 per 1 lakh, which is the fifth. There is a relation between these two. This is a bidirectional relationship. That is, coronary disease causes depression and depression exacerbates coronary disease. Virtually any psychiatric disease can interfere with motivation and associated with substance abuse, which can directly or indirectly affect the cardiovascular diseases by causing failure of the diet regime, weight reduction programs, or smoking cessation. Now, why we should treat depression? It has been seen in studies that up to 66% of patients of myocardial infarction have some depression or anxiety, and 27% of patients following the coronary artery bypass graft surgery develop depression within 6 months. So any untreated depression can cause lack of motivation and failure to adherence of the strict regimes that are imposed on these patients. Untreated depression basically goes the CVS mechanisms to go kaput and cause alteration in the mean blood pressure, heart rate variability, platelet aggregation, and thus it predisposes to severe catastrophic illness of the cardiovascular system. Depression can also bring about ischemic CVA if it is left untreated. And because of all of these factors, untreated depression can adversely affect the outcome of the CVS patients. This is a picture, this shows that how depression alters the hypothalamo-pituitary adrenal axis as well as the immune system and cause altered sympathetic activity and ultimately it affects the heart. Now psychotropics, basically I have divided in 3 broad groups: the antidepressants, antipsychotics and the mood stabilizers. Coming to the antidepressants, we all know about the major classes. The MAO inhibitors are now rarely used, but they were notorious for causing the cheese reactions. The TCAs were and till now are very commonly used, but the problematic side effect of blocking of ion channels and resultant QTC prolongation and arrhythmia is there. Because of this, we have gone to the SSRIs, which are the current favorites nowadays. It has got no action on the ion channels, but it can inhibit certain enzymes. And now the new antidepressants like the SNRIs, mirtazapine, bupropion and filazoron, they are coming out. They are mostly safe in these aspects. Now for some basic considerations, neurotransmitters. The serotonergic neurotransmitters are affected by almost all the drugs. The 5-HT2B subtype is sometimes associated with valvular heart disease. 5-HT2C is important for the antipsychotics because blocking of these receptors can cause weight gain and impaired glycemic control. Now at the adrenergic system, blockade, alpha-1 blockade, we all know can causes dizziness and postural hypotension, which is problematic in the elderly. And beta-1 stimulation can cause heart rate, which may manifest as palpitation. Muscarinic receptors, mainly due to the side effect, it can also cause tachycardia via the M1 blockade. And the histaminic receptors, which can cause weight gain and increased appetite, which again indirectly affects the CVS by impaired glycemic control. Now the most important in the CVS aspect is the blocking of the voltage sensitive channels that are done by the tricyclics. They act as the class 1A antiarrhythmics, particularly in higher doses, and it also causes direct suppression of the myocardial contraction. So in patients who have bad ejection fraction, poor ejection fraction, this may be significant. Now about the changes in the CVS parameters, the ECG changes most frequently caused by the tricyclics are the T-wave inversion, ST depression, and prolonged PR and QT intervals. However, the effects can be broadly divided in the following head: heart rate, blood pressure, QTC, conduction disturbance, post-MI patients, and glucose tolerance. This is a picture which we fear the most, that is the onset of Torsades points in a patient of tricyclics. Now coming to the SSRIs, this is a chart showing the individual SSRIs. We will see that most of them have limited or no effect on the parameters of CVS except citalopram, which in higher doses can cause Torsades. Now the TCS, as I mentioned, it causes postural hypotension, and in overdose it can cause significant arrhythmia and prolonged QT interval, and also delays conduction by blocking the sodium channel. So they are particularly contraindicated in the post-AMI patients. Mirtazapine has again less effect. The SNRIs, venlafaxine and duloxetine can cause dose-dependent rise in blood pressure. So you have to be cautious in using these patients who have poor control over the hypertension. Bupropion is moderately well tolerated and is particularly helpful for patients of CVS who commonly smoke along with their problem. Trazodone is contraindicated, rivoxetine is also best avoided. Agomelatine is a new drug, and so we have limited experience regarding its use, likely to be safe. Now we have to keep in mind the other risk factors that can prolong QT. The cardiac risk factors like congenital syndromes, ischemic heart disease, myocarditis, some metabolic diseases like hypokalemia, hypocalcemia, some non-specific factors like stress, exhaustion. Anorexia nervosa is important because TCAs are contraindicated that may precipitate arrhythmia in these patients. Now regarding drugs, the well-known antibiotics like erythromycin can prolong QTC. Antimalarials like quinine and chloroquine have itself got antiarrhythmic properties. Cyclosporin, amantadine and tamoxifen are the other drugs which can alter the QT interval. Now regarding the glucose tolerance, comorbid depressive symptoms have been observed in up to 60% of the depressed patients, and the presence of depression has a negative impact on the metabolic control, and likewise poor metabolic control can impart a negative feeling and that can jeopardize the depressive symptoms control. SSRIs are mainly beneficial in this regard. They lower the HbA1c and thus reduce the insulin requirement in these patients. Duloxetine, as we all know, is FDA approved for diabetic neuropathy. However, long-term use of any drugs can theoretically at least increase the risk for impaired glucose tolerance. Mirtazapine is notorious for its weight gain. Up to 17% of patients have experienced weight gain, but it does not seem to impair the glucose tolerance. Now in the select cardiovascular populations in post-AMIs, as I have said, the SSRIs are safe, TCAs are contraindicated. Now in arrhythmic patients also, better to use the SSRIs and the SNRIs. In heart failure patients, sertraline and the other SSRIs are the drug of choice. In post-CVA, there is trial with escitalopram and nortriptyline. They are quite safe. Now, regarding the antipsychotics, the next group, this is the ECG which shows the ST depression in the V3 lead, T-wave inversion in the V3 lead that has occurred with a typical antipsychotic, and that goes away after stopping the drug. And we all know that the major two groups are there. The typical ones, they block the D2 receptors. The problem is that low potency drugs have the additional alpha-1 blocking properties that can create problems. Atypicals mainly block the 5-HT2 receptors, and they have unique side effects because they have structurally so much difference. And the metabolic side effects are such a burning issue as regards those drugs. Now coming to the typicals, we see that the less potent typicals have got the significant H1 and alpha-1 blocking properties, and that causes the anticholinergics and the weight gain. Because of structures similarity to the tricyclics, they also have got some membrane stabilizing actions by blocking the sodium and the potassium channels, and that thereby can cause arrhythmia like the class 1 antiarrhythmics. Pimozide and thioridazine are the two notorious tricyclics in this respect. Now regarding the atypicals, we see the receptor profile, and the problematic receptors are identified in the lowermost picture, the 5-HT2C, M1, M3 and the H1 receptors. Now one important thing is blockade of the M3 receptor, which severely interferes with the insulin release and can precipitate ketoacidosis. Clozapine among the atypicals have unique cardiotoxicity. Again, we can study in the direct effects, that is the blood pressure and QT prolongation and arrhythmia, indirect weight gain and diabetes and dyslipidemia. In case of antipsychotics, the indirects seem to be much more than the direct effects. Two types of hypertension are generally seen. The slow steady rise is associated with the weight gain and the metabolic issues, and the unpredictable rise which starts on the starting the drug and is due to the alpha-2 receptor blocking action. This is commonly seen with clozapine and olanzapine. One thing of note is that co-administered SSRIs can augment this hypertensive effect. Can be managed by the ACE inhibitors. Now the QTC prolongation, the problems regarding QTC is it is not done in every center and is difficult to estimate. And there are some physiological variations according to the gender, time of day, alcohol intake, which lead is taken, etc. Other ECG changes are atrial fibrillation, STT changes and heart block. We have to consider the other risk factors that I have mentioned for QT, and we have to be mindful when we are combining two or more antipsychotics, as they greatly increase this QTC interval. This is the normal QT interval and how it looks when the QT interval is prolonged. Now this is again a chart that shows the safer drugs. Aripiprazole and lurasidone are the safest as regards QTC, while asenapine, olanzapine, risperidone have lesser risk. Quetiapine and ziprasidone have moderate risk, while any IV antipsychotics, pimozide, etc. are known to cause QTC prolongation. Now another important issue is weight gain caused by various mechanisms like H1 blocking, 5-HT2 blocking, increased leptin, also due to increased appetite and reduced activity in the patients. Some genetic factors are present as well. Now high weight gain is high amount of weight gain seen with clozapine, olanzapine. Risperidone and quetiapine produces moderate weight gain, and amisulpride, aripiprazole and asenapine are quite safe as regards obese patients. Glucose tolerance, schizophrenia itself causes impaired glucose tolerance even in treatment-naive patients because of inactivity and all those things. And the mechanisms are similar to weight gain and also dyslipidemia. Regarding the typicals, the aliphatic low-potency phenothiazines are more prone to cause glucose intolerance. As regards atypicals, they are more likely compared to the typicals to cause weight gain. Now coming to the individual drugs, clozapine we all know is very notorious, can cause diabetes early even after 1 month of use. It is independent of weight as well as family history and is particularly common in the young. So before starting clozapine on any young patient, we have to screen for diabetes. Olanzapine carries a lesser risk. Risperidone and quetiapine substantially less risk. Quetiapine can ameliorate clozapine-induced diabetes if used in conjunction with it. Amisulpride and aripiprazole are again safe as regards glucose tolerance. Dyslipidemia, again phenothiazines are more notorious than the more potent typicals. Olanzapine among the atypicals have the highest risk of hypertriglyceridemia. Risperidone can reverse olanzapine-induced hypertriglyceridemia in these patients. Aripiprazole again appears to be the most lipid-friendly. Now, how to manage these effects? The best is to prevent by regular screening of weight and BMI, baseline, then monthly, then 6 monthly. BP also to be measured baseline and regularly for clozapine and olanzapine. Fasting blood sugar again for clozapine and olanzapine monthly for 6 months and then yearly. Fasting lipid profile 3 monthly for a year, then annually. And QTC to be estimated yearly. Now coming to the definitive therapy for weight gain, we can switch to the safer drugs, or if it is not tolerated or the patient is not improved, we can add aripiprazole. We can impose certain calorie restriction and low glycemic diet, exercise regimes, and when all this fails, we can go for drugs. Metformin is a common use drug which can reverse olanzapine associated weight gain. Topiramate is another drug, but the problem is the side effects in higher doses. Amantadine can also reverse the weight gain, but it can worsen psychosis, so have to be used with caution. Now regarding the QTC, unless the QT prolongation is less than 470, QTC is less than 470, we have to take no action. If it gets more than that, we can refer to the cardiologist, and if it is more than 500, we should immediately stop the drug and consult the cardiologist immediately. Now, how to manage triglyceridemia? We can switch to ibuprozole, use low-fat diet, fish oils, statins, and fenofibrate in particularly resistant patients. Now, clozapine-induced myocarditis is a unique problem. It occurs early in the treatment regime and has about 10% mortality, so it's a significant side effect. Symptoms present, the patients present with fever, flu-like symptoms, dyspnea, and the signs are eosinophilia, cardiomegaly, and ST depression. Treatment is to stop the drug and use AC inhibitors and beta blockers. Be careful in re-challenge because it can recur. Now to summarize, most of the effects of the antipsychotics used nowadays are indirect. Lifestyle, dietary advice, switching to the friendly drugs, lipid-friendly drugs are treatment options. Be careful for using fluvoxamine, particularly with the antipsychotics, because it can raise the level of the antipsychotic. Mood stabilizers, few words. We know ECG is mandatory in case of lithium to rule out the sinus bradycardia, as well as the renal function to be monitored, because chronic renal failure can precipitate cardiovascular disease. Drug interaction is very important, as we know the NSAIDs and the diuretics, particularly the thiazide diuretics, which can reduce the clearance of lithium and cause lithium toxicity. We should take care of the hydration as well as avoid using thiazide diuretics as far as possible. Another way to measure the serum lithium regularly. The ECG changes in lithium toxicity is like hypokalemia with flattened T waves. Carbamazepine, the problem is mainly the enzyme induction part, and combination with SSRI, it can produce increased chances of hyponatremia. Valproate mainly causes weight gain, and thus combination with atypicals can severely impair the glucose tolerance. Now regarding in special populations, the child psychiatry, the mainly needed for the attention deficit hyperactive disorders, the stimulant, atomoxetine, tricyclics, and the clonidine, guanfacine drugs, which require the baseline and serial monitoring of the pulse and BP. ECG has to be done if stimulants or TCA used and there is a family history of any arrhythmia. These drugs, particularly the stimulant and TCAs, are contraindicated. We have to be careful about the accidental overdose in this population, as well as sudden discontinuation of clonidine, which can precipitate the hypertensive crisis, and some deaths have been reported. Now in the demented patients, the drug in question or the culprit drug is donepezil, which has got vagotonic action. Particularly it is better avoided in sick sinus syndrome or in AV blocks. It is also notorious for causing syncopes, particularly in combination with digoxin, beta blockers, or due to SSRIs. So baseline ECG is advised, but it is not compulsory, and it is not to be used in the mild cognitive impairment because it can cause catastrophic events. Cardiac side effects are less with rivastigmine. Now drug interactions, we know the two types, pharmacokinetic and pharmacodynamic, where the two drugs having similar actions potentiate one's action on the other. Most of the antidepressants are metabolized by the CYP450 system, and some factors are there which modulates the drug interaction. We have to also keep in mind the patient-specific factors, that is the pharmacogenetics. CYP3A4 is the most well-known.
Rishi, you have 2 minutes more.
The inhibitors of this system is the fluoxetine, CYP2D6, again the fluoxetine and sartretin are the inhibitors, CYP2C19, fluoxetine and fluvoxamine, CYP1A2, that is the fluvoxamine, and fluvoxamine, as we see, is the most potent inhibitor and can impair the metabolism of co-administered warfarin and cause thrombotic episodes. Now, pharmacodynamic in serotonin syndrome, the bleeding episodes which mostly are due to the GI bleeds, hyponatremia which can cause delirium. We have to stop the SSRIs if the sodium is less than 125 milliequivalents per liter. Arrhythmia, cheese reaction. Now in overdose, mostly we have to see the ECG, the prolonged QRS and the appearance of Brugada pattern. Correction by the normal saline, vasopressor like noradrenaline, acidosis by bicarbonate, arrhythmia, lignocaine. Avoid class 1A, 1C drugs. Fibrillation by magnesium sulfate and defibrillation. Similarly, in antipsychotic overdose, the same symptoms and treatment is more or less the same. Now, take-home points, depression and CVS have a bidirectional relationship. SSRIs are the most safe drugs, followed by the SNRIs. We have to serially monitor the ECG in case of TCA use and polypharmacy. Atypicals can cause significant metabolic side effects. We have to watch, monitor, and address these issues. Be mindful of SSRI, particularly fluvoxamine, and other psychiatric psychotropics combinations, particularly in higher doses and in OCD. These are my references, and thank you for kindly listening.
Thank you, Dr. Chakraborty. You have concised a vast subject within few minutes. It is not possible to describe all the things elaborately. Still, you have tried it. It is very much, this subject is very much important for us for day-to-day practice. Now, any question from the audience?
Questions from the audience, please. There is a Best Question Award from the audience. There is a lovely, lovely mentor, a prize. So please, go ahead. Best question, please. So any questions from the audience?
Dr. Konar.
You said nortriptyline is safe for cardiac amongst tricyclics?
No, I don't say it. Low dose nortriptyline has been used in the severe patients, but it is not safe because it has got very narrow therapeutic index. But sometimes we have to give nortriptyline because the anticholinergic side effects are less compared to the other tricyclic antidepressants. But it has got a very narrow therapeutic index.
Yes, I also believe that these are the concepts that are pre-SSRI concepts. We used to use nortriptyline as a cardiac safe drugs before SSRI did not come. But after SSRI, the question of TCA doesn't come in cardiac patients anymore. Thank you.
Dr. Mukherjee, Dr. Abel Mukherjee.
Thank you, Rajarshi. I was distracted, so I didn't hear the whole of your lecture. I don't know whether you have covered it, but if you have, please pardon me. In terms of lurasidone, what about the QTC prolongation? Because why I ask this question is that in UK there is a kind of like a clozapine warning in terms of the, before you start using it, you have to kind of register and then start using lurasidone. But sort of going through the literature, I haven't found that much of a risk with lurasidone. So what are your comments about that?
Sir, lurasidone, as far as I have concerned, detailed studies are lacking, but as regards QTC, you said, sir? As far as I have seen, the data have still not come regarding the QTC prolongation. They are given data up to iloperidone. Lurasidone data is still not present.
Yeah, I'm puzzled because of that, because it, Stahl says that it's a low risk.
Yes, yes.
But why is this, in the Western countries, why is this kind of restriction in terms of doing an ECG, mandatory ECG before starting lurasidone? As if like in quetiapine or haloperidol or something, or combining two antipsychotics. Anyway.
Dr. Ashish Acharya. Yes.
Good morning. You said QT prolongation is very much for depressidone, but as per the latest psychopharmacology of Stephen Stahl, she has ruled out that quetiapine prolonged QT level is not justified. And I have serially done at least 100 patients above 50 ECG taking using depressidone, which doesn't cause any endocrine side effect, and no QT prolongation I have found. It is as per Stephen Stahl's book goes, it is not justified. It is safe for cardiac patients.
Yes, sir.
So I want to add this only one point with depressidone.
The last question, yeah.
Last.
Very nice presentation, Rajesh, indeed. Talking about QT prolongation and QTC. In a bedside, we do actually QT interval followed by divided by under root RR interval. So it's a very simple strategy. So QTC prolongation and its further the malignant part, polymorphic ventricular tachycardia. These are two primary concerns. So you have mentioned about lurasidone. How many patients in lurasidone have polymorphic ventricular tachycardia? Because still the literature are available. There are only few handful cases of QTC prolongation, so definitely there, but there is no polymorphic ventricular tachycardia has been observed. Your pick up on that.
Thank you. Okay, this is the last question. Be specific, huh?
Specific. When we prescribe antibiotic like amoxicillin clavulanic acid, we tell the patient and patient party that there may be side effect or diarrhea. If you side effect, please stop or you call me. Any psychiatric drugs like clonazepam, etc. Can we say this type of there is maybe arise of side effect?
Specific.
Sir, can you,
that's not specific.
any psychiatric drug which can?
May arise to side effect like QT prolongation and such and such. Can we say, we should say there will be side effect? You inform us.
Particularly in those patients which we think that these drugs can cause problems, such as those with poor post-CVS patients or young patients or pediatric patients, we will definitely inform the caregiver. And those patients who turn up alone, in those patients we must be specific about the risk. But in young patients who are otherwise have no problems, serious problems as such, or some substance use, then we need not mention every cases, and especially if you use the lower doses of the drugs.
One question, please. There is any role of trianeptine in case of post-myocardial depression or anxiety?
Trianeptine, madam, I have not got any data about the cardiac safety, but it is an effective in case of substance abuse also, comorbid substance abuse. So there is some possibility of its effect.
Okay, thank you, Dr. Rajesh, for covering the aspect with a very comprehensive lecture. So, we have a pleasant task to do, to hand over the memento. I request Dr. Hena Bharatrai to hand over the memento to the speaker.
Dr. Bharatrai will be handing over the speaker's memento to Dr. Rajesh.
And the best question award goes to Dr. Abhi Mukherjee.
Dr. Rabin Mukherjee to receive the Best Question Award from the audience for this session. Round loud of applause, please, ladies and gentlemen. Thank you. Okay, may I now request Dr. Amarnath Mollik to hand over the chairperson's memento to Dr. Hena Bharat Roy. Is Professor Pradeep Shah here, please? Professor Shah? Asche? Okay. May I now request our Dr. Brahmo to hand over the chairperson's memento to Dr. Praveer Paul, please. Thank you, sir. And thank you, sir. From the previous session, we've had Dr. Shantan Patra winning the Best Question Award from the audience. A big round of applause for him. The prizes hadn't arrived by then. So I will request Henadi to hand over the Best Question Award for the previous session to Shantan, please. Thank you. With this, we bring the second session to close. We are literally running 10-15 minutes short, sort of behind. We will try to make up for it, but the presentations have been so interesting. It's a shame to cut short, so please bear with us if lunch is a little late. The third session starts off by, it's going to be a psychiatric aspects of irritable bowel syndrome by Dr. Sujit Sakal. The chairpersons, sir, next one, okay. The chairpersons for this session are Dr. Sorry, okay, I do have to announce a very important, the voting has started at Crystal Room ground floor from 11 a.m. to 2 p.m. for spot votings. For people who have sent their ballots through postal and the ballots have received the IPS office by the 16th, their names are actually outside the voting room. So please do check if your name is there to confirm that your voting has been received. If not, you can do your spot voting today. So please all, between now and 2 p.m., do sort of go to Crystal Room and make sure you have casted your votes. Thank you. The third session is, may I now invite the chairpersons, Dr. Moinak Mukherjee. Welcome to this conference, sir. Dr. Moinak Mukherjee is a very, very senior psychiatrist in Burdwan and has held the post of the Secretary for West Bengal IPS. And may I also request Dr. Dinen Banerjee to join this session. Thank you, sir. Dr. Banerjee is one of the very senior most, very well-reputed senior colleagues of ours and has been the past president of IPS West Bengal branch. Thank you, sir.
Very good morning. As Rajeshri told, that we are running late for 10 to 15 minutes. I will not waste time. I just introduced Sujit Sakal, the next speaker. He is now Assistant Professor of Institute of Psychiatry. He passed from Central Institute of Psychiatry, Ranchi. Now he is the editor of West Bengal branch of Indian Psychiatric Society. He is chairman of the Publishing Committee of Eastern Zonal Branch. He is the convener of Task Force of Suicidal Prevention of Indian Institute of Psychiatry. More than 60 publications in national and international journals. Paper titled in American Psychiatric Society Association Guidelines for OCD. Now I am handing over to Dr. Moinak Mukherjee, my co-chairperson, to say something.
Thank you, Dr. Banerjee. I now welcome Dr. Sakal to start his presentation.
Thank you, everyone. My presentation is psychiatric aspects of irritable bowel syndrome. So what I will do is basically discuss briefly about the recent emergent concepts about the brain-gut axis and how it influences the manifestations of both the bowel and the psychological manifestations of irritable bowel syndrome. So basically, as we know, the best way to a man's brain is through his stomach, and it seems that from an aphorism or from a saying, it seems that there is more increasing evidence which actually hints at some scientific basis of this saying. So there is more and more evidence is coming up for a relationship or a bidirectional relationship between the brain and the gut. And a mention must be made of this person, Michael Gershon. His publication, The Second Brain, in 1998, actually highlighted all the studies which are actually pointing to the fact that there is a bidirectional relationship between the bowel movements, how it influences the psyche or the brain, and how the changes in the brain influences in turn the bowel movements. So basically they are interrelated, and comes along with these bidirectional forces, there is a third important force, and that is the gut microbes, which influence both the CNS and the gut expression of the manifestations of irritable bowel syndrome. So this path-breaking work reignited the role of the gut brain or the second brain, and the misunderstanding between the two brains, the first brain and the second brain, leads to chaos in the gut and misery in the head, as depicted in the film Piku so nicely. According to developmental biologists, earlier organisms had only abdominal neural systems, and as the organisms evolved, the brain or the CNS, as we all know, developed subsequently. However, the two brains remained connected with each other through vagus nerve. So vagus remains an important communicating bridge between the CNS and the gut brain or the second brain. So what constitutes the brain-gut axis? The brain, the spinal cord, the autonomic and nervous system, the enteric nervous system, which is an entity in itself, and the hypothalamo-pituitary-adrenal axis, which plays an important role in modulating the responses. As you can see in this picture, the lower level control is by enteric nervous system. It is being influenced by both the sympathetic and parasympathetic outflow, which in turn is controlled by the higher brain centers. What is not given in this diagram is that the control is actually not unidirectional, rather it's bidirectional. Afferent fibers originating in the dorsal root of the T1 to T10 ganglia. This is the first step, projecting to integrative cortical areas. This is the afferent output. Then to posterior cingulate, insulate and amygdalar cortices. These are some of the important areas which influence the manifestations of the irritable bowel symptoms. Basically the cingulate, the amygdala and the insular cortex. Afferent fibers originate in nuclei within the brainstem as well as S2 and S4 spinal levels and in the thoracolumbar outflow, both the sympathetic and the parasympathetic. Spinothalamic tracts are the main pain signaling pathways of brain-gut axis. So we have the afferent input and the afferent output. In physiological conditions, signals from the GI tract influence the brain, which in turn can exert changes in motility, secretion and immune function. So these are the three most important components influencing the expression of functional bowel disorder or irritable bowel syndrome. Motility, secretion and immune function, and all three are influenced by signals from the GI tract as well as the brain. The axis is therefore an important communicating link between the two. Now, while investigating the neurobiological underpinnings of irritable bowel syndrome, whether it is purely functional, whether there is some biological basis, so the patients were subjected to neuroanatomical studies, and some of the consistent findings are basically the people with visceral hypersensitivity, those whose rectal motility was much more than the normal controls, they were subjected to neuroimaging functional, and it was seen that thinning in the anterior mid-cingulate and insular cortex, that is one, increased gray matter density in the hypothalamus and heightened activation of the anterior cingulate cortex. as I have mentioned, this cingulate cortex is one of the main pain mediating pathways of the brain, and as we all know that pain is one of the main manifestations of IBS. So cingulate has been implicated as expected in IBS patients. Similarly, when cognitive behavior therapy is done for improvement in and leads to improvement in IBS symptoms, it leads to lowered activation of the anterior cingulate cortex. This further justifies the role of it. Patients with IBS have also been found to have white matter abnormalities of the insula and anterior cingulate. Now, this is the structural abnormalities. Now we come to the abnormalities in the pathways relating to the stress. Substantial activation of the hypothalamus and amygdala related to regulation of emotional behavior as well as fear and anxiety. This has been found. Higher activation of the hypothalamus and amygdala. Similarly, decreased activity of periaqueductal gray matter. Periaqueductal gray matter is directly responsible for reduction in the pain sensation. So decreased activity in periaqueductal gray is one of the causalities of IBS that has been found. Similarly, abnormalities in autonomic nervous system and HPA axis, decreased parasympathetic and increased sympathetic activity, as we all know, very often increased sympathetic activity or tension leads to the manifestations of increased bowel motility. Increased HPA axis responses in IBS compared to controls, and intravenous injection of CRF induced exaggerated motility of the colon and increased visceral pain sensitivity compared to controls. So these are some of the findings related to abnormalities in HPA axis. There is also a prominent role of the central nucleus of the amygdala in activating the HPA axis. And the hippocampus may also be involved in several aspects relevant to IBS, mainly pain, anxiety and stress. As we all know, hippocampus has memories related to past incidents, trauma, and we shall be discussing later that these traumatic events are responsible for worsening of symptoms of IBS. So probably hippocampus has an important role to play in the etiopathogenesis. Now coming to the psychosocial factors, which would be one of the main crux of today's topic. You see, it has been discussed much before that, as we see in clinical experience also, that patients with irritable bowel syndrome or functional bowel disease in general have higher prevalence of psychiatric disorders, especially the neurotic spectrum disorders, anxiety, depression and all. Similarly, in patients of anxiety disorders, IBS has been found to be of higher prevalence than the normal controls. So this has been a known fact. Now there are two possibilities. One possibility is that the abdominal symptoms itself can lead to psychiatric or neurotic manifestations. This is the bottom-up model. And another is, as we know mostly, that psychological factors like increased depression and anxiety can lead to bowel manifestations, increased motility. So this is the top-down model. And there is also significant evidence of early life stressors like maternal separation as well as sexual abuse. IBS has been found to occur in higher incidence in these particular groups of population. IBS patients with history of abuse have been found to have lower pain and arch thresholds. And as I was telling, that the higher prevalence of all psychiatric disorders, mostly the non-psychotic group, have been found in IBS patients. Depression, somatization, GAD, panic and phobic disorders. Approximately 70% of IBS patients in tertiary care have comorbid anxiety or depression. So, with this evidence in mind, we would like to see what the current meta-analysis or the current studies point to. We have the background information that higher amount of neurotic spectrum disorders are found in IBS patients. So this is probably consistently found in most of the literature. However, there is some pointer also to the IBS subtypes having relation to neurotic disorders. Just to recall briefly, irritable bowel syndrome has majorly 3 subtypes. One is the diarrhea predominant irritable bowel syndrome, another is the constipation predominant irritable bowel syndrome, and another is the mixed variety which has alternating episodes of or alternating periods of constipation and diarrhea. And it has been suggested in some studies that constipation predominant IBS has higher elements or prevalence of anxiety and depression compared to the other subtypes. So Font et al., they collected all the studies, carried out a meta-analysis which they published in the European Archives 2014. And what did they find out? They concluded that the levels of anxiety and depression were significantly higher in IBS patients in comparison to controls. They also found that the association between IBS subtypes and psychiatric symptoms seems possible, but they could not give a conclusive evidence because more studies need to be carried out. But the million-dollar question remained that whether it was just an association or whether there is causation. The usual step where things stop. There have been 2 cohort studies which have been carried out on a longitudinal basis, and both the studies have actually shown that psychiatric symptoms preceded the onset of IBS symptoms in both the cohorts. So probably there is a pointer that the psychiatric symptoms seem to be preceding or having a causative relation with the manifestations of irritable bowel syndrome. But this needs to be researched further. Coming to the other psychosocial factors, stressful life events have also been found to cause low level of inflammation and mast cell infiltration. Increased prevalence of atopic diseases has been found in IBS patients, and also elevated blood concentration of pro-inflammatory cytokines. So these are some of the important and adverse life events I have already mentioned. Just 2 slides about the role of the enteric microbes, which has been discussion of late. Nearly 95% of the human microbiota is present in the GI tract, and they seem to have an important role in influencing the manifestations of functional bowel disease. So the 2 more prominent phyla are firmicutes and bacteroids, accounting for almost 3/4 of the microbes, and they interact locally with intestinal cells as well as enteric nervous system and directly with CNS through neuroendocrine and metabolic pathways. So there is evidence of role of microbiota. What are the evidences? Improvement in patients of hepatic encephalopathy after administration of oral antibiotics. Post-infectious IBS. There is a group of patients who initially developed a GI infection, and subsequently, even after the infection is eradicated, the IBS symptoms persist. So this post-infectious variety is an indirect pointer to the fact that probably microbes have a role in the manifestation. Dysbiosis in autism, again the alteration of gut microbes in autism, role of probiotics, that is a separate topic, but this is come for discussion, and role of microbiota in influencing anxiety and depressive like behaviors. So scientists have shown that the brain levels of serotonin, the happy hormone, are regulated by the amount of bacteria in the gut during early life, and normal adult brain function depends on the presence of gut microbes during development. Suffice to say that most of these studies have been carried out by sterilizing the gut of experimental animals, and those with the sterilized gut have been found to have malformations or ill-developed CNS. So this is some of the pointers to the fact that gut microbes are essential for the normal development of the CNS. Finally, the role of psychotropics in current treatment options, we all know, so not much to be discussed, except that in mild IBS there is diet and lifestyle modifications, which is basically what we prescribe to most of the patients. So there is a link with psychiatry. In moderate IBS, medications which act on the gut and peripheral serotonergic and anticholinergic agents. As we all know, agents like nortriptyline and amitriptyline, at the same time also SSRIs are found to be helpful in treating IBS. And in case of severe IBS, often comorbid psychiatric symptoms need to be treated. especially severe anxiety and depression. CBT, better coping skills and problem solving techniques have also been found to be important. So to conclude, there is striking evidence of a crucial involvement of the brain-gut axis in the development of IBS and IBS-like symptoms. There is significant association of IBS with anxiety and depression. Whether the association is causal is yet to be determined, although there are some pointers to psychiatric disorders preceding the gut manifestations. Future research needs to identify at which level pharmacological treatment may be beneficial to patients with IBS. With that, I come to the conclusion of my talk. Thank you.
Now we will be going to the question answer session. The first question will be put by Dr. Debashish Konar.
We all know that both gastroenterologists and psychiatrists treat IBS. So in your opinion, who is what would you advise a patient whom to go to? If I am a patient, I am asking you, whom should I go to for my treatment, whether to a gastroenterologist or to psychiatrist?
Sir, going by the recent spate of research, it seems that both seems to be the right answer, because in fact I have dealt with many patients where we actually do it on a collaborative basis with the gastro department. The reason being that the advent in research relating to the role of microbes, especially gut antibiotics, they use Rifaguard, probiotics. So this has actually increased the role of gastroenterologists in treatment, and along with it the CBT as well as psychotropic drugs makes the role of a psychiatrist undeniable. So probably it has to be both. It is these days it is difficult to say that one can treat.
Collaboration is fine. Collaboration is a diplomatic answer. My question is, who should be my first contact?
Sir, first contact ideally should be a gastroenterologist, because a gamut of conditions have to be ruled out before branding it irritable bowel syndrome. So probably a gastroenterological consultation, at least in the initial phase, is mandatory.
Thank you very much. That answers my question.
Thank you, Dr. Konar. May I now request Dr. Prosenjit Rai for his question.
A number of patients who attend our outdoor with diagnosis of IBS, they have a tendency to explain everything with the concept of gas. So much so that recently there have been talks whether this should amount to culture-bound syndrome. So after this presentation, are we going back? Are we going to take them a bit more seriously and take out this thing from like that? I mean. Their emphasis is usually on the physical side. I mean, gastroenterologist and all this. But with the ongoing concept, we have a tendency to keep him or her morely to our side, like therapy and psychiatric treatment, psychiatric OPD, all these things. So after this presentation, is it like we are going to change our attitude towards them?
You mean to say taking their complaints seriously?
No. The other side is, if we go this way, will they ever come back to psychiatry? Because their primary concern is this is nothing to do with psychiatry and it's totally physical. So my question is how to deal this problem? I mean, collaboration, as Dr. Konar was saying, is necessary. So keeping in mind the proper treatment through collaboration, and at the same time not encouraging him to go back totally to the physical side, deserting this side. So how this is going to achieve?
So probably we would have to address the distress associated with the GI symptoms, the core psychological distress which these patients often identify. If they are pure somatizer variety, I think it would be very difficult to retain those patients anyway. But as you have correctly pointed out, the biological part of the explanation of the symptoms cannot be entirely negated, especially after a spate of research over the last 20 years. And as I don't know whether we have experienced it, I know many people who have functional bowel symptoms but generally report a good or dramatic improvement after a typical course of antibiotics which persists for a few days. So that pointer has always been there, and now routinely the GI gastroenterologists, they prescribe Rifagat, and some of them prescribe probiotics also. So you cannot just negate the role of but for those with psychiatric comorbidities, genuine comorbidities, probably the distress associated with the chronicity of the condition has to be addressed, and that is the only way we can retain them in follow-up.
Now, I have a minor observation in this connection to the gas phenomenon. I don't think most of the people who refer to their complaint as arising out of gas don't really mean flatulence. They attribute anything to gas. Suppose there is a pain in the lower limb, or there is a headache, or there is a restlessness, or there is insomnia, they attribute it to gas. Now, what is the history? How do they reach to this conclusion that they are having gas? Now, after studying through the physician's response to psychiatric illness for many years, I think that whenever the physicians are reluctant to be open about the possible psychiatric reason for some symptoms, they attribute it that it is arising out of gas, because gas is very easily acceptable to the patient as a reason for the symptom. So now, the Prosenjit, as you were asking whether this gas phenomenon is culture bound, I think it is actually generated by the physician unknowingly. Anyway, we are continuing with the session. Dr. Abir Mukherjee.
Thank you, Sujit. It was a good overview. With regards to the microbiome, and with regards to rifaximin, and with regards to prebiotics and probiotics, I think if we leave it to the gastroenterologists, it's too simplistic because they don't have an answer as well. And with regards to the prebiotics or the probiotics we have, we are not sure whether it is pre, whether it is pro. How do we take the decision? I mean, it's not, we can't just randomly put someone on rifaximin. We can't just randomly put in the bottoms-up approach that you mentioned. We can't just randomly put someone on a prebiotic. So how do we decide to whom what medication to be given with regards to your axis of the bottom-up, the bottom-up axis which you mentioned?
Basically,
Thank you very much.
Whatever I have gathered from the presentation or while making the presentation and from the experiences, basically they divide it into the subtypes. As I was saying, one is mild, moderate and severe, and another approach is diarrhea predominant and constipation predominant. So in cases of constipation predominant, it is primarily the prokinetics, levosulpiride, and recently there is a spate of some other molecules also which I do not remember. And regarding the role of psychotropics in diarrhea predominant, it has been classically the tricyclic antidepressants. What they are saying is, if there is constipation predominant IBS, there is a good amount of role of SSRIs in mediating the symptoms, probably by mediating serotonergic pathways. So it is not just only depression, but SSRIs, low dose SSRIs in general, which you would find recommended even in the gastroenterology textbooks, by mediating role in serotonin through pain pathways basically. That is one possibility. Regarding when and where to start probiotics, it is difficult, but what I have gathered, mostly popular in cases of diarrhea predominant IBS. It is one molecule is available, one brand, it's called VSL3. It is, a very costly one. That is one popular probiotic, I think.
No, but what I gathered from what I have, I was a moderator once, so I think the prebiotic approach is more of a preventative approach. Like you give a prebiotic if someone is kind of prone to IBS, and secondarily, with regards to being prone to IBS and then developing anxiety depressive symptoms, there you consider prebiotics. Unfortunately, as you mentioned, there are good probiotics, but there aren't many prebiotics at the moment. So I think, that is also a learning curve for us with regards to what prebiotics is, what probiotics is, and when do we give rifaximin. Rifaximin is more for the encephalopathy pathway, when there is collection of ammonia, or the CRF pathway, which leads to the toxicities in the gut. So that's what my understanding was.
Okay, thank you. And Dr. Sujit, what about the rifaximin?
Yeah, Rifagut is usually prescribed by gastroenterologists, mostly in cases of what I have gathered, diarrhea predominant irritable bowel syndrome as a gut antibiotic. Although I am not an authority on this, this is what I have gathered.
No, sorry.
Thank you.
It was the last question. Partho, I am sorry. No, Sajjan Singh, wait. Just a minute, we are running late, so we cannot continue, really.
Sorry, Indroda. So I think we have come to the conclusion of the presentation. It was a nice presentation by Dr. Sujit Sarkale.
May I now request the chairpersons to hand over the souvenir to Dr. Sujit Sarkale, please, for an excellent presentation this morning. Thank you. Round of applause, please. And then the best question award from the audience, sir.
I think Dr. Abir Mukherjee again. The second best is Devashish Kona.
Many congratulations. May I now request Dr. Indrajit Gupta to come and hand over the memento to our chairperson, please, to Dr. Dinan Banerjee. May I also request Dr. Chaudhary to hand over the memento to our chairperson, Dr. Monak Mukherjee, please. Thank you. That brings us to the end of this first CME, and we await for the most important presidential address. Before that, to remind you, the elections, the voting, the spot voting is continuing at the Crystal Room on the ground floor till 2 p.m. So please carry on. Just make sure if you posted by ballot, it has been accepted. If not, you can post, cast your vote now. Thank you, everyone. We now move on to the presidential address session. And for this, I would like to invite our two chairpersons, Dr. Sajjan Singh, who needs really no introduction and has been a very senior psychiatrist practicing in Asansol, and also Dr. Ain Chaudhary, who has been a very senior and reputed psychiatrist known to all of us. Sir, please come on stage. Dr. Chaudhary. And those of you who do not know me, I'm Dr. Rajeshri Ray. I'm your Master of Ceremony for the rest of this afternoon and for the evening as well. Thank you.
It is only Dr. Rupen Kumar Brahma's presidential address. Please, no paper in this session, only he delivered the presidential address. Presidential address, Robert, please. But
আমাদের স্যারের প্রেজেন্টেশনটা আছে এটা হ্যাঁ
Freud's life and work related to psychiatry. Good morning. So we are starting this session. This session is specially dedicated to the presidential address by Dr. Rupendra Kumar Brahma. You know Rupendra very well, but just as a formality, I must say he is one of the brilliant academics of Bengal Psychiatry rather, having a long list of academic degrees starting from DPM, then MRCP, then MRC Psych, naturally FRCP, FRC Psych and FRSM. He is the senior registrar to Professor Sir Desmond Pond at the Academic Department of London Hospital, and he is the first non-white overseas graduate appointed consultant and later head of the Department of Psychiatry, Whipps Cross Hospital, London. He was also honorary lecturer in the University College Hospital, London, and he spent almost over 35 years in United Kingdom, and after gaining all his address. And just to remind you, there is no question answer session after his presidential address. Yes, I think. After his completion, you will give some comments.
Good morning, audience, and thanks to organizer. Hello, good morning, audience, and thanks to organizers that I am on this chair. Thank you very much. Very senior person, a professor, Dr. Brahma, is going to give a lecture which would not invite any questions, and he is taking us to the era of psychoanalysis. The father of psychoanalysis, Dr. Freud, he actually introduced analysis. What is the meaning of all these problems, all in psychoanalytic terms? And I remember 60s and 70s, it was the psychoanalysis, psychotherapy, which was more common than pharmacotherapy. Now we are depending on pharmacotherapy, but previously it was psychotherapy, psychoanalysis. My professor was a psychoanalytic, Dr. Sashike Pandey. He never used to prescribe a single tablet. He used to do only psychoanalysis, and he taught me a lot of things about psychoanalysis. Now we will listen here from Dr. Brahma about the Freud's life and contribution. Dr. Brahma, please.
Welcome all, and a very good morning to you all. This is a difficult task. I know it is presidential address, so I thank you again for giving me this opportunity and privilege of presiding this society. Now, here is a minnow going to talk about a multifaceted, gigantic genius named Freud. So, without further delay, I shall proceed with describing this multifaceted genius first, and then his work. Take it. His scientific contributions can be divided largely in 4 headings. In short, that is anatomy of nervous system and neurology, achieved between 1883 to 1897. His studies on hypnotism and hysteria in 1886 to 1895. Demonstration and study on unconscious phenomena and development of psychoanalytic methods of treatment from 1895 to 1920. Systematic inquiries include human personalities and structure of society made between 1920 and 1939. However, it will be wrong to compartmentalize Freud's work in different fields because they overlap one over the other. Early psychological discoveries and concepts in brain physiology could not be established. His tremendous effort to relate his novel contribution in psychology, the anatomical and physiological orientation reflects the big influence of his teacher Brooke and Maynard. Incidentally, one of his very ardent supporters and disciples, that is Ernest Jones, described why Freud took on psychology, medicine, psychiatry, whatever you call. Because Jones stated, being a Viennese Jew, he did not have many options. Either business and industry or law and medicine. So he did it by elimination because he could not accept business and industry which did not tally with his intellect. So he went into medicine, but not with great enthusiasm. Even in his later years as a practicing physician, he said, I do this, but not with enthusiasm. I was directed towards medicine because of my curiosity towards human concerns than towards natural objects. Always considered curiosity about human nature was most fundamental and a triumph in his life. Ernest Brooke in 1890 to 92 had the greatest influence on Freud's intellectual development. Freud thoroughly assimilated the strictly scientific attitude put forward by Hermann Holz and never deviated from it. In Brooke's laboratory, he acquired thorough knowledge of methods of histology, attended the lectures of Franz Bentano. Look at this multifarious nature of this man. He was doing neuroanatomy and neuropathology and attended lectures on philosophy by Professor Bentano, who was the professor of philosophy at Vienna University and also translated a book by English philosopher John Stuart Mill. In 1881, he obtained his first medical diploma, preparing himself for an academic career. As per Brooke's advice, he abandoned that idea because he realized that academic career will not give him enough sustenance to run his family. So he went into practice. Assistant professor under Hermann Northanger, a famous professor of internal medicine. So see, neuropathology, histology, anatomy, then philosophy. Now he is assistant professor of internal medicine. A famous professor, that is Hermann Northanger, was the chief there. And then he progressed further to Maynard's Psychiatric Institute as assistant professor. At the advice of Brooke, Maynard and Northanger, that is his father figures, he started a career in medical practice. At Maynard's Institute of Neuropathology, and also learned about Harbert's dynamic psychological concepts. Harbert recognized the existence of unconscious mental processes. Of conscious thinking competing for attention. In 1885 and 86, while he was doing the work in psychology and internal medicine, he published papers on neuroanatomy and a book on infantile paralysis, that is cerebral paralysis, CP, and another book on aphasia. Studies in hypnotism and hysteria. We go next stage. He worked in neurology overlaps, his first psychopathological work on hypnotism and hysteria. He first went to Paris on a traveling fellowship and went first to Arbs, electrical treatment of hysteria by galvanic currents, which did not impress him much, and then he went to the citadel of neurology, that is under Charcot, who was at the zenith of his career. Soon his longing for an omniscient father transferred from Buch and Maynard to Charcot. He was tremendously impressed by Charcot's courage of accepting hysterical symptoms as real, as opposed to the then practice of dismissing them as, imaginary. And also the courage to accept that hysteria does occur in males, which is totally opposed to the concept at the time. Charcot successfully treated hysterical patients by using hypnotic trance caused by hypnotic trance. And his thesis was, this was caused by basic weakness of nervous system. Though he then went on to produce hysterical symptoms and treat them with psychological methods. Now, it is very interesting to observe that this reaffirmed the psychogenic theory of hysteria propounded by Sydenham some 200 years before. Freud became a militant champion of Charcot's ideas about hypnosis and its relationship to hysteria. Joseph Breuer was a very respected senior physician in Vienna, and he took keen interest in Freud's work. However, Maynard, his previous mentor, hardly acknowledged Freud's paper on male hysteria. Now, Freud became increasingly isolated from the Viennese medical community, and particularly from his previous mentor, Maynard. Again, Ernest Jones observed, this may be due to the fact that Maynard was jealous because of Freud's superiority in brain anatomy. Breuer was not only his father figure, providing emotional support, or to cut a long story short, he became Vidyasagar Mosai to Freud what Vidyasagar was to our Michael Madhusudan Datta. That is, he provided emotional support, financial support, and practical advice. But to top it all, he actually collaborated in the treatment of a very famous patient named Anna O. She presented with hysteria, so Freud and Breuer treated Anna O jointly. When Anna induced hypnosis in herself, she related in great details the circumstances surrounding the development of her symptoms. Breuer treated her systematically with hypnosis and encouraged in these trances to speak about the experiences patient called talking therapy and talking cure. After these, she called talking cure, but Breuer and Freud termed abreaction. Under hypnosis, she could bring back the circumstances that had led to her symptoms, strong feelings of resentment towards her father for being ill. Phenomena of transference, the respected senior physician Breuer could not cope with, so he quit the case. But Breuer and Freud wrote up her case in great details and described the treatment as catharsis. From 1886 to 1889, Freud and Breuer continued their work on cathartic hypnosis, but some patients, they observed, could not be hypnotized at all, and others were not permanently relieved. So Freud made his second visit to France, to Nancy, where hypnosis was being used extensively by Ambrose and also by Hippolyte Mary Bernheim. And Bernheim was doing post-hypnotic suggestions. And according to Freud, this post-hypnotic suggestion was the foundation of hypnosis. Freud translated some of the works of Charcot and Bernheim and turned more and more to psychological phenomena. Remember, he started with neuroanatomy, neuropathology, neurophysiology, internal medicine. Now he almost exclusively put his mind to psychological phenomena. With Breuer on cathartic hypnosis, dynamic unconscious, and repression of unacceptable ideas. In 1895, Breuer and Freud published studies on hysteria. Hysterical patients suffer from repressed memory. All these are important because these terms at different times, which came up and Freud described. So here comes the repressed memory of upsetting traumatic events, could not be faced at the time when they occurred. Treatment was to give these pent-up emotions a free expression. He wanted Breuer so badly, as a matter of fact, he credited him with the discovery of psychoanalysis. Breuer could not still face the phenomenon of transference, that is, patient falling in love with a physician. With the understanding of, wait a second, but Freud did systematic and objective studies through this transference process, and understanding of transference was the psychoanalysis as therapeutic approach became established. Foundation of psychoanalysis, that is, hypnosis only circumvents the resistance of the conscious personality to repressed material, led to Freud's discovery of free association. Free association takes advantage of the self-betraying tendency of unconscious materials that seek to express but is inhibited by repressing counterforces extended over a sufficiently long period of time, led the patient back to forgotten events that he not only remembered but also relived emotionally. The emotional reaction in free association is essentially similar to emotional discharge experienced during hypnosis. Is not sudden, but it is not as sudden or explosive. Occurs when patient is fully conscious. The conscious ego is enabled to cope with the emotions, that is, by gradually, use the word working through, again Freud's term, the underlying conflict. This was the procedure Freud termed as working through in analysis. Translation of symbolism, that is, this expression of emotions did not come straight but through symbols and allegory, etc. Translation of these symbols into everyday language through which his patient expressed this hidden material, Freud called interpretation. Symbols which fitted the dream interpretation in 1900, dream expressed ego-alien wishes in distorted form. The distortions are defenses, again the term, Freud's term, defenses against the internal conflict that would arise if the ego-alien tendencies appeared openly. Greatly preoccupied with demonstration of dynamic unconscious during the first decade of the century, he also described the paper Everyday Life, Psychopathology of Everyday Life, with slip of tongue, use of words, and forgetting things. He then went on, initially through dream interpretation, led to Oedipus complex, theory of sexuality, libidinal theory, stages of personality development, that is oral, anal, pregenital and genital phases, and also the two terms he used, fixation and regression. Fixation for neurosis, regression for psychosis. Now, to cut a long story short, Freud's dissertations can be described, as Putman put it, as pragmatism, revolt against formalism. Now, to paraphrase and quote again from Putman, our conception of rationality casts a net far wider than all that can be scientized, logicized, mathematized, and in short, formalized. The horror of what cannot be methodized is nothing but method fetishism. Now, how I'm doing for time. So I shall finish here, but I cannot resist the temptation of quoting a scientist. He says, intuition is a divine gift. Science only follows it like a slave. The tragedy of our time is we follow the slave, leaving aside the divine. Albert Einstein. And here I stop by saying, all those people who challenge, is this scientific? Is this scientific? So here is your answer about science and the divinity. I hope I have only aroused an interest in knowing this great man and his work, because this is part of the CME, and I wish this conference a very grand success as the president of the association.
Big clap.
Thank you.
Okay. Thank you. Thank you, sir.
Professor Brahmo, your lecture enlightened us about something which we now do not read at all. You have taken us back to the history, 18th century, 19th century. I really congratulate very much. Thank you very much, Professor Brahmo.
Thank you.
May I now request?
So we are ending this session as because we are running a little bit late. And please announce
May I now
the next
request our chairpersons to hand over our speaker's souvenir, and thank you, sir, to Professor Brahmo, please. Thank you. May I also call upon on stage Dr. Debashish Chatterjee to hand over the souvenir to our chairpersons, and also Dr. Hogg, please. Dr. Hogg, please come on stage. Thank you. May we have a fantastic round of applause for the presidential address of the Psychiatric Conference 2016. And as we know, alone we are smart, but together we are brilliant. So after this session, sir, we all hope to be brilliant all together following the Psychiatric Conference. Thank you. Okay. This session is going to be for 1.5 hours, and following this there will be lunch. But may I also remind you, please make sure you've either checked that your postal ballot has been received by the IPS office, and you have also casted your vote. So it's at Crystal Room, ground floor, the elections till 2 p.m. Okay? For the third session for the CME, may I now request our chairpersons, Dr. Maulay Kumar Koshal, who is Professor of Psychiatry, Kolkata Medical College, and Dr. Shubhamay Chatterjee, who's a very senior physician of Burdwan and specializes in critical medicine, to chair this session on Psychiatrist in Intensive Care Unit. And as they take the stage, I will just like to say that there's a beautiful quote I was coming through. It says, "No one can help you, but if you're determined to learn, no one can stop you." And I hope this can become the theme for our conference as we proceed to the next session, which will be chaired by Drs. Koshal and Dr. Chatterjee. And may I also request to come on stage Dr. Abir Mukherjee as the moderator for this session. Thank you. Dr. Abir Mukherjee is a very senior psychiatrist from medical and holds many important posts in IPS, and of course needs no introduction further. Thank you, Abida.
তাকে শুরু করে দেবো না ঠিক আপনি শুরু করবেন না করে দিন আপনি শুরু করে দিন আগে না আগে ইমান দিয়ে শুরু হবে হ্যাঁ ম্যানেজমেন্ট অফ এক্সটার্নাল বিহেভিয়ার তিনজন স্পিকারের মধ্যে একটাই
না একটা কোশ্চেন হবে এটা কি এটা আছে
Very good morning to the audience and my sincere greetings to the organizers. May I request Okay. First thing is today's focus CME. 3 sessions are there: Psychiatrist in intensive care unit, and all the sessions will be moderated by Dr. Abir Mukherjee. So he will speak about the moderation.
Before actually the session starts, I introduce the first speaker, actually Dr. Iman Pal, who is the Assistant Professor of Department of Psychiatry, IQCT Medical College, Durgapur, and formerly he was in Assistant Professor in ABMC and H and Pondicherry, and area of interest is obsessive compulsive disorder, geriatric psychiatry and perinatal psychiatry. And I know Iman personally that he is one of the most brilliant students of psychiatry, and he has got almost all the honors and all the medals in different examination, starting from MBBS to DPM to MD. Before he starts his session, I request Dr. Abir Mukherjee to speak a few words.
Thank you, chairpersons. Just to briefly introduce the session. So it has got 3 topics. The role of the psychiatrists in intensive care unit. So what we propose to do is we follow a kind of continuum. To start with, Iman, she would discuss about management of externalizing behaviors in ICU. She will set the ball rolling, and it will be followed by 2 lectures on 2 specific issues. We have to handle a lot of alcohol withdrawal in ICU settings. So Dr. Kaustubh Chakraborty will speak about a specific area of alcohol withdrawal, because we have discussed a lot about alcohol withdrawal. So a specific area would be about Wernicke's encephalopathy. And then finally, Bapaditto will conclude with a discussion on clinical implications of raised CPK. So with Iman, I mean, with regards to delirium, if you don't mind, I'll just take about 2-3 minutes. So basically delirium, I mean, delirium is the sine qua non of an acute confusional state or externalizing behavior in ICU. So delirium is to acute confusional state. And so it is acute, which will develop over hours or days. Then it will be confusion, which is a behavior state of reduced comprehension, coherence, capacity to reason, along with behavior manifestations like hallucinations and delusions. And it is a state. So the hallmarks would be a kind of development of cognitive deterioration along with behavioral symptoms, and in an acute setting. And there can be a background. Like, for example, if someone has a background of dementia, the whole presentation will change. Even gender specific, it can be gender specific. So these are the issues I hope that you would be able to cover. And then we can kind of, after you finish your lecture, we can have some points on that. Thank you.
So thank you, Abida, for the very relevant introduction. Welcome to today's topic, management of externalizing behaviors in the ICU. So before I go on to the topic proper, I would like to share a few case scenarios, the kind of cases that we receive referrals for that we all are familiar with. So case 1, Mr. D, a 70-year-old male with severe COPD is in the MICU on ventilator for respiratory failure. Initially, he needed high levels of sedation, but now propofol has been decreased. He is awake but agitated, grimacing, thrashing, and trying to sit up in bed. He makes eye contact, but he won't follow commands. So is he delirious? How do we assess? In the second scenario, Mr. M, an 80-year-old male, a known case of Parkinson's disease, admitted with fractured right neck of femur. He was agitated, in pain, and had hyponatremia. Electrolyte imbalance was being corrected. He was operated, but he remains confused, disoriented, agitated, and has hallucinatory behavior. So how do we manage this person? So I would hope to bring out issues relevant to that. So externalizing behaviors in ICU, these are problem behaviors directed towards the external environment, like disruptive behaviors, hyperactivity, agitation, or aggressive behavior. These can occur individually or they can be part of delirium. So here we need to keep in mind about the concept of the ICU triad: pain, agitation and delirium, which are inextricably linked, and the management has to focus on managing all three together. So the older terminology regarding encephalopathy or ICU psychosis, they effectively denote delirium. So agitation, it is a psychomotor disturbance characterized by marked increase in motor and psychological activities, accompanied by loss of control of action, disorganization of thought. Anxiety in ICU, it is normal to some extent because of the ICU environment, because of the disease itself. It becomes pathological when there is severe dysautonomia or loss of self-control and the patient cannot be treated effectively. So if we come to delirium proper, most of the studies focus on the DSM-4 criteria of delirium. That is a disturbance of consciousness with inattention, change in cognition or development of perceptual imbalance, the disturbance developing over a short period of time and tending to fluctuate, with evidence that it is secondary to a general medical condition. On the other hand, DSM-5 is a bit more restrictive. Its focus is more on inattention, and it specifically excludes coma from being labeled as delirium. So if we come to the motoric subtypes of delirium, it is hyperactive type. I'm sorry, the slide doesn't seem to be. So there is the hyperactive type, the hypoactive type and the mixed type. The hyperactive type is the rarest and it has the best prognosis. The hypoactive type is more difficult to pick up and it might be labeled as depression, or the patient apparently appears to be calm. And the commonest is the mixed type, where both hypo as well as hyperactive symptoms are present. So the pathophysiology of delirium, basically there is a acetylcholine depleted state, dopamine is increased. Serotonin can go either ways and GABA is also usually increased. So why is it important, the epidemiology? How common is it? It occurs in almost 80% of ventilated patients. In 50 to 70% of non-ventilated patients. More worryingly, it is not diagnosed in almost 70% of cases. So what we pick up might actually be the tip of the iceberg. It is an independent predictor of prolonged ICU and hospital length of stay. It has a higher 6-month rate of mortality, higher costs, higher rate of cognitive dysfunction. So this is delirium as a predictor of mortality. The risk factors associated with it can be grouped into predisposing factors as well as precipitating factors. Among the predisposing factors, age, history of cognitive impairment, alcohol use, hypertension, and among the precipitating factors, the severity of illness, benzodiazepines and cholinergic use, these are more significantly associated with developing delirium. So if we come to the management proper, the first step is assessment. Assessment using validated tools. So we need to assess for sedation, agitation, pain, and finally delirium. Sedation and agitation, they usually have common scales. Most commonly used is the RASS, Richmond Agitation Sedation Scale, where -5 refers to an arousable patient, and on the other end of the spectrum is a combative, +4 score. The sedation agitation scale is a similar scale. For pain, best is if the patient is able to self-report, then scales like self-report measures like the pain assessment tool, the visual analog scale. If the patient is not able to self-report, then 2 scales are used most commonly, functional scales, the critical care pain observation tool and the behavioral pain scale. So the assessment of delirium, 2 tools have been validated most commonly. One is the ICDC, the Intensive Care Delirium Screening Checklist, and the CAM-ICU, the Confusion Assessment Method in ICU. Both have similar sensitivity and specificity. So CAM-ICU, first step is assess the sedation. If the patient is very sedated, we cannot assess for delirium, so stop and reassess later. If the RASS score is above -4, then go on to assessment. The first step is to assess whether there is an acute onset or a fluctuating course. if it is not present, then stop, there is no delirium. If it is present, then test for inattention. If there are less than 3 errors, stop, no delirium is there. Greater than 3 errors, assess for altered level of consciousness. If altered level of consciousness is there, patient is delirious. If it is not there, the patient appears to be alert and calm, then we need to assess for disorganized thinking. If there are more than 2 errors, then the patient is delirious. The ICDSC is also a similar scale. So if we come to the differential diagnosis, how to differentiate delirium from acute functional psychosis or from dementia. In acute functional psychosis, the delusions are more systematized. It arises in clear consciousness, whereas in dementia, usually the consciousness is clear initially, and it has a relatively stable course. We come to the investigations. We need to remember that dementia is only a symptom. We need to treat the underlying cause. So whatever investigation is pertinent to rule out the underlying cause has to be done. Routine investigations like complete blood count, chest X-ray, imaging, CT, MRI, urine screening, ABG, all of these need to be done as appropriate. So we come to the treatment proper part. This is the algorithm for treatment. I will go into it in details. So focusing on pain, agitation, and finally delirium. Sedation, unless there is specific indication for sedation like status epilepticus or intracranial hypertension, try to achieve the sedation target via a analgesia-based approach. So the broad guidelines for pain management, opioids are the #1 choice for treatment of pain. Non-opioids are recommended so that the total dose of opioids can be reduced. Carbamazepine or gabapentin can be given for neuropathic pain. And as I said earlier, focus on achieving the sedation target only via an analgesia-based approach. We come to the management of agitation. Standard sedation techniques like using benzodiazepines, which is very commonly used, IV anesthetic agents, central alpha agonists, and high-dose opioids, haloperidol, all of these can be used. Benzodiazepines, though it is very commonly used, the problem is benzodiazepines, especially lorazepam, has been associated with a high risk of developing, it is an independent predictor for developing delirium. So unless specifically indicated, for example, for alcohol withdrawal, we do not give benzodiazepines. Propofol, if we have to use propofol, the use of propofol infusion syndrome has to be kept in mind. Nowadays, more study is focusing on dexmedetomidine. Dexmed, it is a selective alpha-2 agonist, attenuates CNS excitation. There is no respiratory depression or hemodynamic instability associated with this. It is useful for cooperative sedation, that is for ICU sedation, for perioperative use, for outpatient procedural sedation, in neurosurgery patients specifically. The adverse effects are hypotension at lower doses, hypertension at higher doses, nausea, bradycardia, and dry mouth. So the recommendations are maintain light levels of sedation in patients. It improves the clinical outcomes in terms of shorter duration of mechanical ventilation, shorter ICU length of stay. Sedation strategies using non-benzodiazepines, either propofol or dexmed, is preferred over sedation with benzodiazepines. For rapid sedation, or if there is active seizures or alcohol withdrawal, midazolam can be used. When rapid awakening is desired, propofol can be used. Midazolam recommended only for short-term use. For propofol, if it is being used, then triglyceride levels have to be monitored. Sedation use is also, it is advised that sedation has to be interrupted daily. It is associated with better clinical outcomes. And spontaneous awakening trials to be coupled with spontaneous breathing trials. Also, in cases of prolonged sedative use, the risk of sedative dependence, withdrawal to opioids, benzodiazepine withdrawal, these need to be kept in mind. Now, coming to the management of ICU delirium, so look for it. Communicate to the nursing staff, to the other treating members that there is the risk of delirium. First, treat the underlying cause if it is diagnosed. That itself takes care of the delirium in most cases. Correct the electrolyte imbalance, particularly hyponatremia is extremely common, especially in elderly. We need to be careful about it. Then the non-pharmacological measures, and finally, if all of these do not work, only then pharmacological interventions are to be used. So these are the risk factors that can be modified. Sepsis, hypoxemia, metabolic imbalance, these need to be corrected. Anticholinergics, and these need to be withdrawn. These are deliriogenic. ICU environment is to be manipulated. So assess every 12 hours. It is not a one-time assessment process. Try the non-pharmacological methods. Reduce exposure to deliriogenic medications like the commonly implicated benzodiazepines, Pacitin. The non-pharmacological interventions include position patient such that the discomfort minimizes, use of therapeutic touch, minimize stimulation, minimize tethers, provide set rest periods, provide intense nursing care, maximize bowel comfort, maximize rest and sleep periods, take conversations away from bedside, provide frequent calm reassurance and reorientation, make sure the patient is wearing his glasses or hearing aids, keep familiar objects in his line of sight, play familiar music, use family support, establish and maintain a clear day-night pattern, ask questions that can be answered with a yes or no, either verbally or non-verbally, establish a consistent approach, provide cognitively stimulating activities several times a day, and early mobilization. So the pharmacological approach, there is actually very little evidence. The first is haloperidol. It was earlier recommended, but now there is insufficient evidence. Atypical antipsychotics have limited evidence. Rivastigmine is contraindicated. Use of Dexmed is to be preferred when there is benzodiazepine, over benzodiazepines or haloperidol. This was a study comparing olanzapine and haloperidol, and they had similar efficacy. It was useful in a subset of population only. Quetiapine versus haloperidol. Quetiapine, when added to haloperidol, provided faster delirium resolution, less agitation, and a greater rate of transfer to home or rehabilitation. These were some of the clinical trials evaluating, as we can see, all the studies had methodological problems and small sample size. So very little pharmacological guideline as such. So the timeline, we need to keep in mind that it develops within first 2 days and can last up to 2 weeks or longer. So we need to be patient. One of the algorithms is SPR, where S is for screening, P for prevention of brain dysfunction, using the ABCDE bundle, where A is for awakening, B for breathing coordination, C for choice of sedative, D for delirium management, E for early mobilization, and R for restoration strategies. So now if we revisit the case vignettes that I earlier mentioned, the case 1, his first step, there is an acute change from baseline. He's inattentive, his level of consciousness is altered, so he is delirious. The same patient on the next day appears to be alert and calm, but there was a history that overnight he received several doses of lorazepam for agitation. Is he delirious now? He apparently appears to be RAS score is 0, but it fluctuated within last 24 hours. He still remains inattentive, and though he appears alert and calm, his disorganized thinking score is positive, so he is still delirious. In case 2,
1 minute more.
The case of Parkinson's disease. Here, if we revisit the case on reviewing the treatment record, he was found to be on high dose of THP. So the first step, remove THP, continue monitoring serum electrolytes, initiate non-pharmacological interventions, and reassess. So to summarize, it is a serious adverse effect and can be missed. Management is multidisciplinary. So we need to focus on maintaining a light level of sedation, use of non-benzodiazepine strategies wherever required, and non-pharmacological interventions are to be used regularly. Thank you.
Thank you, Iman. Sorry to rush you. It was so. What came out of your presentation? I mean, before starting the question answer, because we have, with the permission of the chairs, we have kind of organized it in a way that I'll summarize what Iman has said, and then invite questions, because it's a symposium. It's not a lecture. It would be about for 10 minutes, and then we'll go to the next speaker. So what I could gather, like Iman mentioned about the issue of underdiagnosis as well as subtypes. I want to combine the two together, because I think the externalizing behaviors are not necessarily underdiagnosed. It might be misdiagnosed, but not underdiagnosed. But the problem is with the hypoactive type. So whether there is a rationale of having a hyperactive or hypoactive delirium, simply because if we know that there is a hypoactive delirium entity, then we won't miss out on the diagnosis. And because the hypoactive delirium is missed, so the mortality rate is increased in hypoactive delirium. The rate of mortality in hypoactive delirium is more than hyperactive delirium. The other issues is regards to predisposing factors, which I was alluding to before you started. In terms of previous cognitive function and age, these are the two subtypes which modify how the delirium would present and how the externalizing behavior would present, and whether we need to be mindful of that. Medication as cause, you did mention a multiple amount of times. So what necessarily happens is that among the other, there are lots of theories, but in clinical practice, decreased acetylcholine and increased dopamine. These are the two sine qua non features. So whether the person is on anti-Parkinsonian medications, whether the person is on steroids, whether anticholinergic medications, I think medication is perhaps 1/3 of the cause of delirium in an ICU setting. So medication needs to be kept in mind. Role of pain, which is very new. Thank you, Iman, about discussing about pain. So what is the role of pain and how does it influence delirium? Role of scales. Do we necessarily use scales? Because we all know that delirium is a clinical diagnosis. So what would be the role of scales? As she mentioned in the first case presentation, the scales did come into use with regards to management. So role of scales. Investigations. What investigations? We have to understand that delirium is like fever. It is a symptom or a syndrome which has multiple causes. So that needs to be kept into mind. The use of benzodiazepines and atypical antipsychotics, the pros and cons of it. And finally, the newer medication, the alpha-2 agonists. Are we aware of newer medications? If so, then what is the use of newer medications vis-a-vis the older ones? Thank you.
I want to add a small thing with the synopsis, that the role of vasoactive agents also should be considered, because cholinergic and dopaminergic pathways are involved. And there are a lot of vasoactive agents in circulatory failure and ventilator patent. There is. That's why it should be considered also.
Questions?
Questions from the audience, please.
In managing delirium, it's necessary to make the patient oriented. But in most of the ICU setups we see over here, it's very difficult to make it, because the day-night distinction is almost blurred. It's totally blurred, not almost, inside the ICU. So how to work upon this thing, like orienting the patient towards time, the time of the day. So any idea about this?
Yeah, so we can keep a big clock. Okay, some reorientation strategies, these focus on frequently telling the patient about the date, about the time, use of a family member if permitted, and also establishing a clear day-night pattern. This is very strongly recommended. So at night time, dim the lights, dim the bedside monitor lights also. So those things are recommended. We do not do it usually in ICU settings, but maybe with a little bit of sensitization, we can make it a routine clinical practice. So it would be helpful.
Thank you.
Actually, in your day-to-day practice, in a private multi-speciality hospital where I practice, I find a number of such delirious patients. This work wonders, and in course of time, sometimes we use chlordiazepoxide if benzodiazepine is a necessity. But my question to you, what is the rationality of using multivitamins? Is there any vitamin deficiency in delirious states? What we find that in our practice, that it is very effective. But could you please enlighten or tell us what is the rationality of using such multivitamins?
Yes, sir. So that's a very relevant question. Actually, the role of, for example, vitamin D deficiency and psychosis is very well established. There is a lot of literature regarding that. Especially in our country, in elderly, if we do a routine study, there will be vitamin D deficiency in like a huge number of patients. So if we actually correct the vitamin imbalance, the deliriogenic state is corrected to some extent, because delirium, as Dr. Abhi said, it is only the manifestation. There might be an underlying symptomatology. So the more number of causes we are able to correct, the better it will be, sir. So I gave you an example about vitamin D deficiency and psychosis. Similarly, like vitamin D deficiencies are associated. So that has to be taken in care of.
But does any of the vitamin deficiency cause an acute condition like a delirium? Vitamin deficiencies usually cause chronic condition. So, his question was very specific. How does multivitamins help in correcting a delirium? That is an acute
Sir, it might be associated with a lot of other conditions also. So it might be just an ongoing insult is there, and on top of that, the patients in general, there is vitamin deficiency or nutrition deficiency. So that needs to be corrected, sir. It's not.
Any more questions? Next speaker, post-op.
So we are concluding this session.
Thank you.
And next speaker.
Post-op. For prevention of one-X encephalopathy.
So our next speaker is Dr. Kaustubh Chakraborty. He is a MD, PGI Chandigarh, DNB and MNAMS. Attachment, Assistant Professor, College of Medicine and JNM Hospital, Kollani, West Bengal. Awards, Bronze Medal in MD, Final Examination in Psychiatry. Dr. Sharoda Menon, Gold Medal in Psychiatry in DNB Final Examination, Fellowship Award by the Japanese Society of Psychiatry and Neurology, JSPN, in the 107th Annual Meeting, Tokyo. Professional affiliations, life member of Indian Psychiatric Society, membership Indian Eastern Zonal Branch, Indian Psychiatric Society, and State Branch, Indian Association of Child and Adolescent Mental Health, member of Indian Medical Association, National Academy of Medical Sciences, Life Associated of Indian Association of Social Psychiatry. Total publications in various national and international journals are 48. And his topic of discussion will be prevention of vernix encephalopathy in alcohol withdrawal.
I'll introduce and then. So if I can take it from the last question of the last session with regards to multivitamin use, as well as I think one of the areas where multivitamin is used for acute delirious state or acute confusion is alcohol vernix encephalopathy. And I think to begin with, we have to understand that vernix encephalopathy and alcohol are not synonymous. I mean, although the commonest cause of vernix encephalopathy would be alcohol induced, but it is not synonymous. There might be several other causes like malnutrition and like various other issues which Kaustubh will detail. So the core issues would be in terms of discussion about vernix encephalopathy, as the topic says, whether it is preventable or not. Is it exclusively alcohol related? What improves with treatment? Are there any specific markers of response? We have read from our textbook times and everything that about the classical triad of symptoms. So is it as simplistic as the classical triad of symptoms? So if we say that the classical triad of symptoms are ophthalmoplegia, ataxia and confusion, is there any clinical marker about what improves first? And how can we say that if we give a thiamine, what would improve first that would lead us to the assumption that it is vernix encephalopathy? And the Maudsley guidelines and other books, and I've seen Kaustubh's presentation as well about Pabrinix. What exactly is Pabrinix? Is it available in India? If not, should it be available? Because Pabrinix is not only thiamine. it also involves a lot of other vitamins. So I hope that Kaustav would be able to allude on these issues. And Kaustav, I welcome you.
20 minutes time.
5 minutes.
Very good afternoon to all the delegates present over here. I must thank the organizing secretary and the CME committee of IPS West Bengal State Branch for giving me the opportunity to speak in this forum. In keeping with the theme of this CME, in keeping with the theme of this conference, psychiatrists as physicians, I would like to present this very pertinent topic of prevention of Wernicke's encephalopathy in alcohol withdrawal. So it is needless to say that alcohol influences more than 60 general medical conditions. It contributes to almost 4% of the global burden of disease, almost equal to hypertension and smoking. Heavy drinking, even if episodic, causes a multitude of health problems. Now, what is Wernicke's encephalopathy? We all know that it is an acute neuropsychiatric emergency due to an initially reversible biochemical lesion caused by overwhelming metabolic demands on brain cells, that is due to depleted intracellular vitamin B1 or thiamine level. Now the prevalence wise, if we see in autopsy patients, the prevalence of Wernicke's encephalopathy is around between 0.4 to 2.8%, whereas in alcohol dependent individuals, it goes up to as high as 12.5%. Kane gave an operational criteria for diagnosis of Wernicke's encephalopathy in 1997 based on retrospective analysis of cases of Wernicke's encephalopathy that were verified at autopsy. And any two from the following four would be present. These are dietary deficiencies, oculomotor abnormalities in the form of ophthalmoplegia, cerebral dysfunction, and altered mentation or mild memory impairment. However, the classical triad in seen only 16 to 20% of the patient, and rest 70 to 80% patients are missed out. The other clinical features of Wernicke's encephalopathy that helps in the diagnosis are autonomic instability characterized by tachycardia, hypotension, hypo or hypothermia, irritability, hearing loss, seizures, spastic paraparesis, delirium, coma, acute psychosis, eye abnormalities like miosis, anisocoria, papilledema, and retinal hemorrhages. Now let us look at the etiology of Wernicke's encephalopathy. Alcohol dependence or withdrawal is not the sole cause of Wernicke's encephalopathy, as Abida has already said. The other causes are malnutrition. Any cause which contributes to malnutrition can cause Wernicke's encephalopathy. Deficiency of folic acid, which hampers thiamine absorption. Genetic alteration in the thiamine transporter protein, that THTR1, may lead to diminished capability to transport thiamine across brain cells. Chronic diarrhea and persistent vomiting. Hepatic diseases, diuretic use, magnesium deficiency, GI carcinoma, which impedes absorption, thiamine absorption, AIDS, anorexia, and multiple organ failure. There are other causes which have been highlighted, like cerebral energy dysfunction, accumulation of amyloid precursor protein in brain cells, increased free radical production, increased expression of superoxide dismutase, consequent to increased microglial response, induction of nitric oxide, and oxidative stress. Now, what are the brain changes that happen in Wernicke's encephalopathy? It has a characteristic appearance in autopsy. In acute cases, there are petechial hemorrhages in mammillary body and around third and fourth ventricle and cerebral aqueduct. In chronic cases, the mammillary body appears a brownish, spongy appearance. In MRI, there is hyperintense signal changes of mammillary bodies in T2 weighted images, and there is additional contrast enhancement in T1 weighted images. In diffusion weighted imaging, it demonstrates a hyperintense signal in paramedian thalamic nuclei. In same DWI, there is decreased apparent diffusion coefficient values in the medial thalamic nuclei and periaqueductal brainstem. So this is the picture how the mammillary body looks in a case of Wernicke's encephalopathy, acute stages, and there is pigmentation of gray matter around third ventricle. The changes that happen at the molecular level is mainly because of glutamate excitotoxicity. Chronic alcohol exposure blocks the NMDA receptor at glutamate site, which causes upregulation of glutamate receptor. With the cessation of alcohol intake, the free receptor accepts more glutamate, and thiamine deficiency increases the glutamine concentration, which in turn causes excitotoxicity. There are biochemical changes as well. HPLC has demonstrated the current alcohol misuse causes low circulating level of all form of thiamine except the monophosphate compounds, and liver cirrhosis is associated with decreased thiamine diphosphate concentration and impaired thiamine phosphorylation. Genetic susceptibility is also there due to polymorphism of the transketolase enzyme, which involved in glucose metabolism, of which thiamine pyrophosphate is an important cofactor. Now, what is the prognosis of such cases? A failure to diagnose Wernicke's encephalopathy and institute adequate parenteral therapy results in death in 20% of the patients. 75% are left with permanent brain damage and progresses to Korsakoff's syndrome. 25% of patients with Korsakoff psychosis in long run require long-term hospitalization, and as I have already said, only 80% of the patient are 20% of the patients are diagnosed before death, and 80% are diagnosed only at autopsy. So, because it is a preventable condition, so prevention is always better than cure. It is better to identify high-risk individuals. They are the people who have delirium tremens or has a past history of delirium tremens. I will focus only on alcohol-dependent subjects who have a presumptive diagnosis of Wernicke's encephalopathy, having severe kind of alcohol dependence, have more concurrent physical and mental illness, history of seizures, and repeated unsuccessful attempts at quitting alcohol. So high index of suspicion is the key factor. A good history taking regarding the temporal correlation between alcohol use and development of encephalopathy, good clinical examination, particularly of CNS, investigations to rule out the other causes of Wernicke's encephalopathy, which includes all the routine examination, which include electrolytes, urea creatinine, full blood count, liver function, coagulation profile, thyroid function, blood sugar level, serum B12 and folate level, and serum gamma glutamyl transferase level, which is an indicator of excess alcohol use. Estimation of thiamine pyrophosphate level and electrolyte transketolase activity, which is low in such cases, are also available, but they are not routinely done. MRI brain is helpful, and neuropsychological tests can be done to document a particular case of Wernicke's encephalopathy for future reference. So pharmacoprophylaxis is all about thiamine. Thiamine, as we all know, is one of the B vitamins. It is an essential cofactor for transketolase, alpha-ketoglutarate dehydrogenase, and pyruvate dehydrogenase, which is important in the pathway of carbohydrate metabolism. The daily dietary requirement of thiamine is 1 to 2 milligram, and the body store is between 30 to 50 milligram. So it can be expected that the body store will be depleted in 4 to 6 weeks. Thiamine has a very short half-life. It is around 96 minutes, so it requires frequent administration. Now, chronic alcohol consumption causes thiamine deficiency by 3 pathways. There is inadequate nutritional intake, there is decreased absorption from the GI tract, and there is impaired utilization. Oral route of administration becomes less and less effective as the patient becomes more involved in alcohol misuse. Low circulating thiamine level has been detected in 30 to 80% of alcohol dependent patients. So almost all the guidelines are unanimous regarding the pharmacoprophylaxis. They advocate use of 100 milligram of thiamine IM TDS thrice daily for 3 to 5 days as the pharmacoprophylaxis of Wernicke's encephalopathy. 2/3 of orally ingested thiamine is not absorbed or processed into its usable form by heavy alcohol users. Thiamine fortification of beer and bread has also been advocated, but those have been largely useless, because during alcohol metabolism, thiamine is neither phosphorylated by the liver or not incorporated in the body enzymes. So these are the few guidelines regarding pharmacoprophylaxis of Wernicke's encephalopathy. They advocate either use of 100 milligram of thiamine intramuscularly either once or thrice daily, and follow up with oral thiamine as an outpatient For healthy low-risk patients, they recommend more than 300 milligram orally daily during detoxification and 100 milligram orally daily for those who have already undergone detoxification. And patients who drink excess alcohol, they recommend the use of 100 to 200 milligram IM daily for 3 days and followed by 100 milligram orally daily. So this was the pharmacoprophylaxis. But what is in the case of definitive patient having a definitive diagnosis of Wernicke's encephalopathy or Wernicke-Korsakoff psychosis? The guidelines say that at least 100 milligram thiamine IV either as a single dose or thrice daily for a duration of 5 days should be administered to the patient. Some guidelines recommend a bit higher dose like 20 milligram IM thrice daily, IM or IV thrice daily. British Association of Pharmacological Guidelines recommends the use of more than 500 milligram IM or IV thiamine for 3 to 5 days, followed by 200 milligram once daily for a further 3 to 5 days, depending on the response. There was a double-blind randomized controlled trial by Ambrose et al. In 2001 in which thiamine hydrochloride was given to 107 patients at a varying dose of 5 milligram, 20 milligram, 50 milligram, 100 milligram and 200 milligram daily for 5 days. An assessment was done by a single neuropsychological test on the 3rd day. And the authors drawn conclusion that 200 milligram dose was superior to the mean result of all other dosages. Cochrane review, which is one of the highest quality of evidence in medical practice, concluded that there is insufficient evidence from randomized controlled trials to guide clinicians regarding the dose, frequency, route and duration of thiamine treatment for prophylaxis against or treatment of Wernicke-Korsakoff syndrome. There are some case report and case series regarding memantine and donepezil. Memantine have been proved effective in treating patients with Wernicke's encephalopathy because it is an NMDA antagonist, and NMDA-mediated cytotoxicity has been implicated as a cause of Wernicke's encephalopathy. Acetylcholinesterase inhibitor donepezil given for 6 to 8 months has treated 3 cases of Wernicke-Korsakoff syndrome. However, further studies are needed in this area. So what is the response to thiamine? It is the oculomotor signs that improve first within hours to days. However, the confusion improves over days to weeks, and some deficits may be permanent. How safe it is? It has been said that thiamine is overall safe regardless of the route of administration. There is level B evidence in favor of it. Adverse effects are generally in the form of generalized pruritus, transient local irritation and sporadic cases of anaphylactic reactions. And these are very rare. Although there are chances of anaphylactic reaction, it is recommended that thiamine should be given without delay in all circumstances, irrespective of whether facilities for resuscitation are available or not. Thank you.
Thank you, Kaustav. It was very, very lucid and brief, but covering all the important issues. Except that I wanted to add, you mentioned about the clinical features, and you know that is one of the discussion points about only the classical triad is present in only about 1/3, isn't it? About 16%, 16%. Yeah, but I think the important feature that you raised about that, even within the oculomotor signs improving, the gaze policies tend to improve first. The vertical nystagmus tends to stay, and ataxia is slow to respond, because ataxia is one of the disturbing symptoms, so it is slow to respond. So even the classical triad of clinical symptoms has some clinical importance in terms of day-to-day. And of course you mentioned about the other clinical features. Incidentally, polyneuropathy is a very important feature. And we tend to segregate Wernicke's and Korsakoff's. With Korsakoff's, we tend to associate memory impairments with Korsakoff. But we have to be mindful that even in an acute stage, even in an acute Wernicke's, there might be memory impairments present. But those are more subtle than in Korsakoff's. So that also needs to be kept in mind. MRI. MRI it's again a point of discussion, whether we do MRI routinely or whether we rely again on clinical features. And if with thiamine there is no improvement, then go for MRI. For research purposes, it is okay. We can see the mammillary bodies and that is a proof enough. So whether we do it in routine practice, because we we often practice in very cost-depleted environments. So whether we routinely do an MRI, I think that is another discussion point. Why is thiamine replacement missed? And this is a phenomenon all over the world. It is such an easy procedure. It is, you have to give IM or IV. And even nowadays it is recommended that hyperactive delirium, when it presents, we are not sure about alcohol history, we are not sure about the other comorbidities. We can routinely, even prophylactically give thiamine. Start with thiamine and then wait for clinical response and then go for other areas. But even then, why is thiamine missed? Most of the clinicians, leave aside psychiatrists, wouldn't even consider thiamine. If you go to see a patient in the ward, they would start a detox program, they would start lorazepam, they would start Librium, but you would see in the prescription, thiamine is not added. Why is this so? So this is one of the criticisms about thiamine use was the scare of anaphylaxis. But I think that is very unfounded. If you can give a test dose and then follow it up with thiamine replacement, it doesn't cause a lot of problem. So I think that is also a very, very important issue which needs to be highlighted. And about Pabrinex, I'll just detail about Pabrinex. Yeah, Pabrinex, it is a combination. It has thiamine 250 milligrams, nicotinamide 100 milligrams, riboflavin 4 milligrams, pyridoxine 50 milligrams, and ascorbic acid 500 milligrams. So it is basically a IV multivitamin injection with a higher bolus dose of thiamine. So this needs to be kept into mind. The Maudsley guidelines, the British psychopharmacology, and they recommend Pabrinex. We don't have to give Pabrinex. There has to be some kind of alternatives available over here. What we have is B1, B6, B12. We don't have a multivitamin injection with a higher dose of thiamine, higher fortification of thiamine. So whether that needs to be introduced or whether we can, sort of influence the pharmaceutical companies to bring a product like Pabrinex. So I think these are the issues which comes across. Thank you. Yeah.
One more point I want to add from the critical care medicine point of view, that lot of patients landed in ICU with CCF or sometimes unexplained GI disturbances. And in that case, as Kaustubh rightly said, that history of alcohol and its withdrawal should be kept in mind, because simply dry very, very and wet very, very, that should be kept in mind, and replacement of thiamine may help in improving the cases. Questions please from the audience.
I have one specific question. Over the last 10-15 years, Indian pharmaceutical market is being flooded with benfotiamine and related combinations, and they are being used even on OTC preparation. Any evidence base for benfotiamine in place of thiamine in prevention of alcohol-related Wernicke and related brain disorders?
I've not gone through literature evidence for benfotiamine in particular that I can say. Hands up.
No, actually, if I can respond, it's in the acute stages we have to always give a IV or IM thiamine. So there is no existence of benfotiamine. It is also recommended that we continue the vitamin B1 supplementation for 3 months even after the acute therapy is over. So in that case, again, I don't have an answer whether benfotiamine.
I also don't have an answer, because all guidelines, and we are talking about alcohol withdrawal and acute Wernicke's encephalopathy, and their thiamine is recommended only as IM or IV dose and in a supernormal dose. And regarding benfotiamine, I don't have any guideline.
Only one thing I can say, that because it is recommended by all the guidelines that thiamine should be given either intramuscularly or intravenously, because in acute stages the gastric absorption is highly impaired, and benfotiamine being available in capsule form, it would not be absorbed, so it would not be beneficial in acute cases. That's a simple argument.
No, I think it is the one of the issues is even with the OD medications, the others, I'm talking about many other OD medications which are given, it's like, you know, we don't have much of literature on that. So maybe one of the advantages of benfotiamine would be an OD dose, because if we have to give thiamine, we have to give TDS. It is 100 milligram TDS which we have to give as even as continuation. So that might be one of the instigators in terms of giving an OD dose. But beyond that, with regards to evidence base, we don't have an answer.
And the other thing is that being a multivitamin and containing vitamin B complexes, all the vitamin B complex, B vitamins, it is mainly promoted for the neuropathy associated with alcohol use disorders. So in that case, probably people are using it rather than in a case of acute case like Wernicke's encephalopathy.
Any more question?
Probably malnutrition. Probably malnutrition if he is from a poor socioeconomic background. Very, very.
And what is the role of liver in protection
So role
of liver?
Liver in producing Wernicke's encephalopathy. Because thiamine phosphorylation is done in liver, so in case of liver failure or liver impairment, the phosphorylation is hampered. So it is not being utilized in the carbohydrate metabolism. So injecting thiamine or giving parenteral thiamine is of limited role in that cases. Anti-seizure drugs, because it is an encephalopathic state, so seizure can occur anytime. So I don't know, as far as I know, for alcohol withdrawal, there is no prophylactic role of anti-epileptic drugs.
Actually, all these prophylaxis for seizure, for example, leave aside alcohol, even in case of head injury, or if there is a infarction, all these prophylactic use of anti-seizure drugs are actually not useful, because till date there is no drug which can stop epileptogenesis. So until and unless there is a seizure, we usually don't use anti-seizure drugs. Probably not.
Not in recent studies, because what they say is that if the pathogenesis of alcohol withdrawal is kind of, you have to give something as a cross-tolerant agent, and a cross-tolerant agent would be benzodiazepines. The choice of benzodiazepine might differ. It might be in few cases, because longer actings would be preferred because it reduces the chance of seizures. So diazepam and chlordiazepoxide is preferred as a seizure prophylaxis, but sometimes because of hepatic encephalopathy, the chance of hepatic encephalopathy, we have to use lorazepam. And if we have to use lorazepam, we have to use as much as a QDS dose, or even 5 times or 6 times a day. So there isn't much role of seizure prophylaxis per se.
Topiramate? Can topiramate protein in
Yes, because benzodiazepines are very potent anti-seizure agents. Benzodiazepines per se are very potent anti-seizure agents. Topiramate is more for maintenance. So topiramate has...
Because we plan as maintenance therapy with topiramate, and if we have a patient with withdrawal seizure or has chances of having seizure. So we can give topiramate, which will give me a long-term agent for this.
But it is not as effective as a detoxification agent. That's the problem. We have to start with go to topiramate. So that is one. And to answer your other question, you have to be also, it's not only malnutrition, dialysis, patients on dialysis, patients having HIV infections, patients cancer, post-cancer patients, post-gastric surgery patients. So they all can have one encephalopathy.
So one more question, because time is going short. Yes, sir.
Alcohol withdrawal is not recommended. If we have to treat alcohol withdrawal with carbohydrate things, that is the only anti-epileptic thing to subside withdrawal symptoms, not epilepsy. Alcohol withdrawal seizures should be investigated with PCD and imaging to find evidence of seizures. Then you can take that withdrawal problem plus seizure. Otherwise, simply withdrawal seizures which occurs in first 24 hours of alcohol withdrawal. Anti-epileptic is not recommended.
Yes.
Yes.
No, I think the another issue is also, as you mentioned about investigations, we have to look at other factors like hyponatremia, hypoglycemia. They can induce seizures as well. So if those other, I mean, if we see that someone has hyponatremia, we have to correct the sodium levels. If there is hypoglycemia, again, after thiamine replacement, we have to use glucose. So these are the other minor nuances which needs to be looked into.
So we are closing this session. Thank you, Kaustam. And
so the next speaker is Dr. Bapaditya Chaudhuri. He will talk on clinical implication of raised CPK. Bapaditya passed from Arjikar Medical College, graduated in 1999. And he has post-graduation in 2009, and his current attachment in Institute of Neuroscience. He happens to be my PGT, so I know him very well, and he is a very bright student, and he has got always some innovative thoughts. I really appreciate that. So Bapaditya, before Bapaditya, I tell Abhi to...
Sorry, just an announcement, please. For delegates who haven't yet cast their ballot votes, please visit the crystal room because voting will close at 2 p.m. Thank you very much.
We are terribly short of time, so I will make a very brief introduction, Bappa, and then you can kind of maybe again the areas like one is that CK levels are. There are loads of false positives. I mean, with CPK we tend to associate neural malignant syndrome or malignant hypothermia, but we have to be mindful that it indicates a lot of other things. There is a lot of other variations in terms of gender, race, physical activity, age. These are some of the physiological variabilities which needs to be looked into when we measure the CPK. Bappa would elucidate, but the normal cutoff which I have gathered is the males is about 171 and in females it is about 145, and it is a very complicated calculation which is done by the International Federation of Clinical Chemistry. So half of the things went above my head, so I wouldn't get into that. And also the other things is that we have to also be mindful that there is CKMB, CKBB, and these are the other variants. So it is not only neuromuscular, it is neuromuscular, cardiac, and various lots of other things. Even when we come to pathology, there are lots of other things. There's the influence of drugs, there's the influence of IM injection. So when we do a measurement, we have to wait for certain time after we do the CPK tests. High fever, for example, systemic infections. So these can all raise CPK. So I hope that you would be able to clarify of the rhabdomyolysis as well. Yeah.
Thank you, sir. My topic is a bit straightforward one, but apparently it looks like so. But I will first start with a case. It is a real case just handled a few weeks back. 18-year-old male presented with restless, roaming aimlessly, agitation, sleepless, irrelevant talk and sometimes fearful. And he was taken to a psychiatrist who gave him risperidone 2 milligram twice daily and lorazepam 2 milligram twice daily. And what happened? After 2 days, he got admitted to intensive care unit in a confused state, at times drowsy, febrile. He was dehydrated, perspirating, mute, motionless, and not accepting any food, and sometimes becoming incontinent. And baseline investigation was a bit of hyponatremia and raised CPK as highlighted. CT scan was normal, and at that night of admission, some event occurs which I am coming late, and on next day I ordered for a repeat of CPK. It came to be around 780. And what could be the diagnosis for a psychiatrist? This case, the only highlighting point is this raised CPK, and with an history of antipsychotic and certain kind of symptom. But the boy actually throwed up a convulsion at the night, and on CSF examination it was found to be a case of TB meningitis. So initial presentation was, for a psychiatrist, was the main focus was on raised CPK level. But this CPK, although as already highlighted by Abhirda, is a form of enzyme for related to energy production, is abundant throughout our body. Mainly this CPK-MM, which is present in muscle, which is of concern of psychiatrist. And raised CPK occur whenever a muscle activity, a vigorous muscle activity is occurs, like strenuous exercise, repeated injection, recent trauma with muscle injury, and after seizure, or even severe dystonia, and high fever accompanied by shivering, and various systemic viral infection or chronic disorder which causes lots of muscle pain, aches, they may give rise to CPK-MB, and a hypothyroid state which delays degradation of CPK-MB eventually give rise to high CPK. And the pathological condition most commonly associated with CPK rise is various inflammatory and degenerative muscle disease, like inflammatory myopathy, polymyositis, dermatomyositis, infectious myopathy, dystrophy, like most common is Duchenne-Becker dystrophies, rhabdomyolysis after muscle injury. Certain drug, particularly statin, very commonly used, give rise to increased CPK, and the area relevant to us is neurolep malignant syndrome mainly, but we have to keep in mind that a host of lot of symptoms, syndrome, diseases give rise to this raised CPK level, and essentially a patient with neurolep malignant syndrome should be kept under intensive care unit in collaboration with other disciplines. This NMS is basically a life-threatening idiosyncratic reaction to say various central dopaminergic activity, and it was only reported after we started use antipsychotic, particularly chlorpromazine, long back in 1960s, and it is essentially due to dopamine depletion, particularly in areas of basal ganglia, brainstem, and spinal cord. This all antipsychotic that blocks this dopamine receptor can give rise to NMS, as including clozapine. And also we have to keep in mind that whenever we increase the doses, it is also the risk period which can give rise to this NMS. And abrupt discontinuation of dopaminergic drugs, levodopa, amantadine, and tolcapone, can give rise to this NMS phenomenon as well. And overall, the incidence is not that much common. Less than 1 to 2% of these patients who are put on antipsychotics, and usually occurs within 2 weeks of exposure, and most cases within few days after starting antipsychotics. And clinically characterized by rigidity, which keeps keeps our first we pick up the diagnosis on this rigidity, and along with hyperthermia and an altered state of mentation, particularly drowsiness, agitation, confusion, delirium, and coma. And the hallmark of this NMS is the autonomic dysfunction along with raised temperature and rigidity. The laboratory finding is most important is this high CPK level along with leukocytosis. It is highly associated with iron deficiency and give rise to renal failure, metabolic acidosis, and certain EEG and CT changes which we need to keep looked upon. And particularly this diagnostic criteria may give some help in picking up the diagnosis, but often the diagnosis is a clinical piece of clinical judgment. This muscular rigidity, raise of temperature, and history of use of neuroleptic medication is the main thing, along with 2 or more signs of increased autonomic instability per se. And we need to be, this is as per put forward by DSM guideline, but the weight of the symptom, how much it could be possible depending upon the presence of symptom, has been weighted by this expert panel consensus. And they put on weight on exposure to dopamine antagonist on the first place, along with hyperthermia, rigidity, and altered mental stress, and this signs of autonomic disturbance. Like I said previously, we have to keep in mind always the differential diagnosis. Most common is this heat stroke, which occurs often along with this flaccid extremities, abrupt onset of nature, along with hypotension and dry skin, and particularly CNS infection at the prodromal stages may present with these features of NMS. Another important thing to us is serotonergic syndrome, which is, although rare, can mimic like NMS, and sometimes lethal catatonia, malignant hypothermia, mainly after exposure to the anesthetic drug, and sometimes alcohol withdrawal state may present like this. And this, regarding this management, is essentially should be done in intensive care unit. First issue is stopping antipsychotic, and if these dopaminergic drugs were discontinued abruptly, they should be restarted. And the most important thing is adequate hydration. Particularly, it will help prevent insult to kidneys, as well as controlling temperature, which help minimize the muscle damage, and along with regular cardiorespiratory support. And regarding drugs, we commonly use this bromocriptine or benzodiazepine, very familiar to any of us, and this amantadine less commonly used. If in severe cases, these cases should be managed by dantrolene, although not available, and we may keep ECT as an option. And certain complications that may arise, like renal failure, disseminated intravascular coagulation, rhabdomyolysis, even myocardial infarction or aspiration, seizure, arrhythmia may happen. And the important decision is when to start neuroleptic and to assess the chance of recurrence of NMS in these cases. Particularly, we need to wait for a few weeks before we starting and new antipsychotic, preferably atypical antipsychotic of lower incidence of NMS. But overall, this prognosis has improved a lot. Almost 10% mortality nowadays, although from most of the cases are from delayed recognizing the onset of symptom and unable to prevent the complication of it. And we have to keep in mind that recurrence of NMS is pretty high. Mainly, we have to keep in mind that NMS as such becomes fatal only with its complication. And before we conclude,
5 minutes more.
We have to keep in mind a more common symptom of serotonin, similar symptom of serotonin syndrome, which is although not that common. And the only difference is that it starts abruptly comes with a lot of hyperreflexia as such. The muscle tone, although not that much increased, but reflexes get more exaggerated, and autonomic dysfunction is not that much prominent. And with that, I conclude. Thank you.
Okay. So we are getting mixed messages. Sometimes we have to finish by 1:55, sometimes 1:40. So anyway, I think we have plenty of time, even if we have to finish by 1:40, 1:45. So, you know, it's a kind of roller coaster ride with regards to when we need to finish. So no, I mean, summarizing what Bappa said, and with one or two additions, it's like there are plethora of pathological causes, plethora of physiological causes, which can cause raised CK levels. But the individual, I think, variants are important, because as you will be able to tell better, with CK-MB, it's also a marker for reinfarction nowadays, isn't it? Like,
yeah. Though the troponins are gradually replacing CK-MB,
no,
drop I and drop T for the myocardial infarction cases, but still it's an important marker for myocardial
for reinfarction, especially?
Reinfarction, CK-MB is an important marker.
Yes.
Yeah. Though it is nowadays usually adjuvant other tests are also there.
Yes.
So there is ample opportunity to, but you have to keep it in mind that there are other biomarkers.
Exactly. And the other thing is, as speaking from the psychiatrist's point of view, wherever there is a raised CPK, immediately we get called, and there will be some prescription from about 1 year ago that the person was on 25 milligrams of quetiapine 1 year ago, and it has been stopped since about a year. And now suddenly the CPK levels are raised. So there, I think our role is to, to speak with the referring consultants from the ICU, saying that, well, this is not possible. Or even, apart from a few causes like Lewy body dementia, where there is extremely sensitivity to neuroleptics, or a very old age person with a lot of malnutrition, with a lot of other factors like sepsis, infection, etc., and combined, sort of added to it, there would be a prescription of a low dose antipsychotic. There, of course, we have to be careful and we have to withdraw. The other thing which happens is that we tend to very quickly go into prescribing bromocriptine, prescribing dantrolene is fortunately not available. So quickly prescribing bromocriptine, or quickly getting into, okay, if it is not NMS, it is serotonin. So getting into cyproheptadine. So I think we have to convince, because the person is in an ICU setting. So it is not as if it's a life-threatening condition. We don't have hyperpyrexia. We can use simple non-pharmacological methods like reducing the temperature by cooling. So the thing is that it is not a knee-jerk reaction which we are looking for. We are looking for, okay, let's look at the other differentials. Let's establish that these differentials are not important. So we are really dealing with something like NMS, and then go for treatment. So this would be, the controversial areas from my side.
Aggressive hydration, you have said, as well as circulation and ventilation support. And along with that, aggressive cooling, even by physiological methods, that goes a long way in treating NMS in early stage. So questions from the audience, please.
In my clinical practice, in case of, say, acute mania, to calm the patient, to treat the patient promptly, I go for haloperidol. And why haloperidol? Because it is a very potent drug, it acts fast, and the patient recovers in a very short time. There are a lot of controversies. These days there are atypical antipsychotics are there. It is a typical antipsychotic, haloperidol. But still, potency-wise, if I disregard the side effects, EPS, etc., potency-wise, to control the excitement, control the agitation, haloperidol is the first choice. At least to me, opinions may differ. But relevant question which I want to ask, in some of my cases, in commonly using haloperidol,
in some of my cases, it happened that the patient went into NMS. And in that case, which I remember, haloperidol was used in a high dose and for a pretty long time. And in that cases, there are newer options these days, like quetiapine and something else, risperidone. But is it a solution to replace haloperidol with quetiapine or risperidone? What is your opinion, and also the treatment of haloperidol-induced NMS?
Well, very relevant question, sir. This NMS is not only due to haloperidol or other high potent antipsychotics. It happens even with clozapine as well. So, with view of preventing NMS in spite of haloperidol, and probably any other antipsychotic still does, if weigh against benefit and risk factor of producing various certain kind, haloperidol still is unparalleled. Regarding other effect like acute dystonia or hypotension, cardiac effect, other options may be safer, but at that time clinical judgment may be the final prevailing thing that guides our decision.
But thing is that what to do in case of haloperidol-induced NMS? What to do that? Because in some of
actually
cases,
that has been told in the presentation that it is not haloperidol induced or any other drug induced. The NMS as per se, he has already told what to do.
Because NMS is a life-threatening condition and the mortality is quite high. So is it not right if you are suspecting NMS to have multi-pronged treatment, and as you said that hydration and cooling and all those methods should be taken. But I believe if you have diagnosed NMS, then you should have multi-pronged approach. And these drugs, bromocriptine and amantadine or benzodiazepine, they are not very dangerous drugs to use. So if you are sure about diagnosis, I think you should use many things together.
Definitely, sir.
I think one thing to add. I think typical antipsychotics cause more NMS in comparison to atypical antipsychotics, and this is one of the advantages of atypical antipsychotics.
No, I think with regards, can I just, one is that Bappa did mention about the treatment being happening in an ICU setting, which is, that answers your question about multi-pronged. The only problem with bromocriptine and the other things that if we are not sure about the diagnosis, one is that if the treatment is happening in the ICU setting, we have time. It is not as if, it's like within the next 1 hour we have to act. Okay, so that's one. And the other thing is that we have to remember that there is a underlying diagnosis of psychosis which can be exacerbated with bromocriptine. So apart from any other physical issues, bromocriptine in itself can potentially exacerbate psychosis. So that is the reason why we have to be even careful about bromocriptine.
Two questions. First is the incidence of this raised CK in patients on antipsychotic. Is there any rule of thumb, like it's 1%, 0.1%? What is the incidence?
Incidence, as per published data, varies from 0.1 to 2% per se. But with two things is very important. Is regulating the dose, not switching dose too much, and early recognition of these symptoms.
Yes, the second part is about early recognition. Which of my patients should I screen for CK? Which of my patients? By like what will be my index of suspicion when because routinely we don't order this investigation.
Definitely.
So which of my patients would I order a CK? If somebody is showing hyperreflexia, what is the criteria for ordering an NMS?
As NMS is an idiosyncratic reaction, it may happen anytime, but most of the cases are happen to occur within the first few days after either starting or increasing the dose. And although cases has been reported after 1 year of use, but most commonly it happens within 2 weeks. And if within 2 weeks we find either muscle rigidity, autonomic dysfunction, or raised temperature, we should suspect that we may become proactive and act accordingly, basically.
I want to ask Bappa one or two questions that are actually, if we know that fever is one of the most important, all criteria fever is rated as 1. Can NMS present without fever? Initial phase without fever, can it present? Number 2, if I re-challenge a person who has developed NMS with a drug, what is the percentage of risk of developing NMS? For example, a person who is very much controlled with risperidone developed NMS, whether whether there is, what is the recommendation that whether we can re-challenge it? And number 3, whether there is any differential incidence of NMS between bipolar, schizophrenia or any other psychiatric disorder and NMS?
For this, sir, NMS is basically due to acute dopamine depletion, and particularly these symptoms occurs due to dopamine depletion in hypothalamus. Hypothalamus temperature regulation thermostat is deranged. Temperature set is set to a higher level. That is the reason for raised temperature, and along with it, same mechanism causes autonomic dysfunction as such. So, to happen to make a presentation of NMS, first hypothalamus has to be depleted with dopamine. It can happen basically with any drug, any time. It may not be so that either one drug, one offending drug, if I change to a second drug, that may also cause some same sort of presentation. And maybe there is some sort of proneness to cause this acute depletion of dopamine, but it is, as it said, with antiemetic drugs particularly. Re-challenge, it can't be said when it could repeat again.
So, I mean, I think there is another issue with regards to re-challenge, because the CPK raised can be due to multiple factors. So in an ICU setting, the person is septicemic, having hyponatremia and all the other factors, and then developing NMS. So in a situation where all these factors have been excluded, like the person has recovered, then we can re-challenge in a more kind of stable setting when the physical ailments are not there. Maybe that might be the answer.
I think one more important issue is also there, that the family physicians or general physicians should also be in the awareness program for NMS, because a patient with antipsychotic under a psychiatrist treatment, when developing a fever, he used to go to a general physician, and the NMS kind of thing should be kept in mind by the general physician. So from an awareness point of view, psychiatrists should also aware the general physicians regarding NMS.
I'll answer it in two, like there are two aspects to it. One is the practical and one is the clinical. With regards to the clinical aspect, if there is significant muscular rigidity which is causing respiratory depression and we need immediate kind of correction of that, then definitely we'll go for dantrolene or bromocriptine or things like that. And even then, since we don't have dantrolene, bromocriptine is not a very fast acting agent, so that will take time. And in an ICCU setting, the conservative management with other with other kind of modalities is much better available. Secondly, in an ICCU setting, if there is an exacerbation of psychosis, it is much more difficult to handle with the ICCU physicians and others. They find it more challenging than handling a physical emergency if at all it arises. Double-pronged answer to the question.
We are concluding the whole session after giving a delightful announcement that Dr. Devjit Dan will have the best question award. So please. Dr. Dan.
Many congratulations. And may I also invite all the speakers, Dr. Kostav Chakraborty, Dr. Bapadita Chaudhary and Dr. Imon Paul to come on stage, and our chairpersons will be handing over the speakers. And our chairpersons handing over the speakers' souvenirs to our three speakers who have delighted us this afternoon post pre-lunch session with three very fantastic and well-informed articulate presentations. Thank you. Kostav, Bapadita and Imon, please. Thank you. In the meantime, may I also call upon Dr. Shikha Mukherjee, Dr. Indrani Chatterjee and Dr. Karim to come on stage to hand over the souvenirs for our chairpersons, please. Dr. Shikha Mukherjee? No. Dr. Indrani Chatterjee? Dr. Karim? So may I request Dr. Sajjan Singh, Dr. Shen Gupta and Dr. Debashish Konar to hand over the souvenirs to our chairpersons, please. Thank you. Thank you. It's now going to be time for lunch. It's 1:45, and we would like you all to convene here at 2:30 p.m. please, okay? So we have, is that all right? 2:30 p.m. back for the third session of CME. Lunch is just outside, and if anyone's still waiting to cast their votes, voting will close at 2 p.m. So you still have a few minutes if you haven't, or you want to check through things. Thank you very much. Do enjoy your lunch, and we'll be back here at 2 p.m. Thank you. Sorry, 2:30. Thank you. I should always stay with you. And on that note, may I invite our chairpersons for this afternoon session, Dr. Dibya Gopal Mukherjee. Dr. Mukherjee. Dr. Dibya Gopal Mukherjee. And Dr. Aurobindo Kumar, please. Opida? Okay. All right, okay. Unfortunately, Dr. Devi Prashad Dey is not able to be with us this afternoon. The CME is going to be from 2:30 till 4 p.m. and we have 3 speakers for this afternoon. On that note, I will hand this session over to Dr. Mukherjee. There will be a best question award for this session that will comprise of all the 3 speakers. This is
abstract details. This is the introduction that we will do. ঠিক আছে? আপনি অ্যাপ্লাই করছেন একটা best question award থাকবে from the audience.
Welcome to the afternoon session. Welcome to the afternoon session of today's CME program. After a sumptuous lunch, I think people are still hovering around outside this hall. I would request them to enter this hall so that we can start the program right away. Our first speaker in this afternoon session is Dr. Bhaskar Mukherjee, a young dynamic aspirant psychiatrist. He is presently working in Malda Medical College. He has a special interest in biological psychiatry and treatment-resistant conditions in psychiatry. So we will call Dr. Bhaskar Mukherjee. His topic is today non-hematological side effects of clozapine. So we are going to listen to him on one of the psychotropic drug named clozapine. So over to Dr. Bhaskar Mukherjee.
Good afternoon. Open হয়েছে? Yeah. Good afternoon, everybody. Hope you are enjoying our divine CMAs. Before starting this topic, I would like to reference a very popular movie, Godfather. Hope you have all seen it. In Godfather, there was a character known as Luca Brasi. Luca Brasi was the enforcer of Godfather. Whenever there was trouble, he used to call for Luca Brasi, and the trouble was gone. Clozapine is our Luca Brasi. We may hate it, we may not like it, but at the end of the day, it is the drug on which we rely, because it always delivers. My topic might seem that it will delineate how bad clozapine is, but really it's not. We all have to know every bad side of that person who are closest to us. Clozapine is our closest antipsychotic. It is a miracle antipsychotic. So we should know what are the problems it can cause and what are the managements of it. With this introduction, I am starting my presentation. Non-hematological adverse effect of clozapine. Now, what are the presentations hidden in this topic? It's actually encyclopedic presentation. First, because there are so many side effects of clozapine and each of them require mentioning. So if I go by the actual presentation, it will take more than 3 to 4 hours, and there are many topics hidden inside this presentation, like cardiac effect of clozapine, a separate CME, metabolic effect of clozapine, separate CME, gastrointestinal effects of clozapine, immune system and clozapine, a very interesting and upcoming topic, re-challenge of clozapine after developing ADR, biomarkers of clozapine, and the others are hematological effects of clozapine. This is my favorite one. Is aglomeracytosis as lethal as it is fatal? It would be a very nice debate. And new and old blood monitoring systems for clozapine-induced aglomeracytosis across the globe. The systems are changing now, but it is beyond the scope of this presentation. So, what are the scopes of this presentation? It would be a brief delineation of different side effects, brief elaboration of important ones, close-up in withdrawal and when to re-challenge in case of side effects, predictability of adverse drug reaction genetically, my favorite topic, biomarkers, and take-home message. The take-home message would be a bit extra. The list. I would not elaborate here because I am just showing the list. Each one merits a CME. The bold ones are the ones which I am going to elaborate. These are CNS effects, pulmonary effect, musculoskeletal effect, ocular effect, gastrointestinal system effect, renal and urinary tract effect, immunological effects, metabolic system effect. Nowadays, psychiatrists all over the world are working on scales to assess clozapine side effects so that it can be delineated before it becomes a problem. This is an example of paper working on that scale. Now, the most important side effect of clozapine, which is sadly not aglomeracytosis. It is clozapine-induced myocarditis and cardiomyopathy. It is possibly much more common and more serious than MASH-type aglomeracytosis, more common in Australia than other parts of the world. Why it's common in Australia, we don't know. There are many reasons. I will delineate them later. But the basic point is Australia is the head of clozapine-related cardiac death of the world. Absolute risk is 0.01% to 0.188%. 1 in every 100% in Australia carries a 30% to 40% death risk. Many drugs increases the risk of myocarditis. Notable among them are our drugs like lithium, valproate, sertraline, imipramine, fluvoxamine. We frequently prescribe them with clozapine. BMI greater than 30 kg per meter square as well as sustained aerobic exercise may be associated with a greater likelihood of death due to myocarditis. It is reported most frequently from 4 days to 22 weeks after initiation of clozapine. Most cases seem to occur early after beginning of the treatment, with more than 80% within first 2 months and up to 75% reported within 3 to 4 weeks. Peak incidence is around 19 to 21 days since the beginning of the treatment. These are the more common and less common side effects. They are non-specific. These are the common tests to diagnose the myocarditis. I am not elaborating because if I elaborate, I will be in time pressure. Some specific tests. Cardiac MRI is emerging as the diagnostic test for clozapine-associated myocarditis. The criteria are increased myocardial signaling intensity in T2 images as well as increased early gadolinium-enhanced T1 weightage images. And there would be at least one focal lesion that shows late non-ischemic regional distribution of gadolinium enhancement. The N-terminal fragment of pro-BNP, that is brain natriuretic peptide, is a proposed biomarker for clozapine-induced myocarditis. And when this topic is we are discussing, that means this middle of August, by late of August, the patent approval in USA would be approved a test where 16 tests which will determine clozapine side effect is being passed. Pro-BNP as biomarker of asymptomatic clozapine-related heart dysfunction. This is another paper. The pathophysiology. It is immunoglobulin E mediated hypersensitivity reaction, one theory. Another theory is there are some unique subpopulation of patients who lack the CYP450 enzymes, that is 1A2 and 1A3, which are responsible for clozapine catabolism. Therefore, in this patient, extreme clozapine concentration can be reached, and that may cause this particular side effect. Probably in Australia, this particular thing is happening. Also, there is manifestation of a clozapine-related hypereosinophilic syndrome with a direct cardiotoxic effect of eosinophils through blockage of cholinergic M2 receptor, and there is also increased non-energetic tone, which may contribute to development of myocarditis. This is an exhaustive list, but actually please try to understand, this list says the proposed protocols for early detection of myocarditis. There are many people who are currently researching on them. I have included some data, but this list is not final yet. And this is proposed clinical algorithm for cardiac monitoring. It will be approved within 2017, late 17 or 2018. Cardiomyopathy. Reported incidence of DCM among clozapine treated patients ranges from 0.02% in the United Kingdom to 10% or more in Australia. And so is approximately 1/4 of the risk of acute myocarditis associated with drug, or about 1 in every 2000. Mortality following clozapine associated DCM has been reported about 12.5% in 24%. The main findings are echocardiographic evidence of a reduction of left ventricular systolic function, ejection fraction below 50% of normal, in the absence of other abnormal condition involving increased cardiac loading, along with clinical symptoms of heart failure. Supportive evidence include a variety of non-specific EEG changes as well as increased serum concentration of BNP and echocardiographic evidence of myocardial dysfunction, specifically of decreased left ventricular efficacy. There is a subclinical cardiotoxicity of clozapine, but I am not elaborating on it. Clozapine induced seizure. Clozapine is not the first antipsychotic to cause seizure, but it is the antipsychotic associated with highest risk of seizure. This is a list which shows propensity of defined antipsychotic to cause seizure. Seizure is estimated to occur in association with clozapine with a cumulative 1 year risk of approximately 5%. This number is debated in a recently published paper by PGI, where they are saying that it is around 6%, at least in Indian subcontinent. A dose-related risk of seizures with clozapine has been described in literature, with reported risk of 6% to 2% for doses of 300% or less, 1.8% to 4% for doses of 300 to 599 mg, and 500 to 14% for patients taking 600 to 900 mg of clozapine. Seizures are GTCS most common, along with myoclonic, simple complex partial, and absence. Absence is very rare. Approximately 2% of patients on clozapine will develop myoclonus, usually first presenting in the orofacial region. EEG changes may serve as predictor of a subsequent seizure, thereby functioning as a warning. Also, EEG changes that develop after clozapine treatment is actually a glued treatment response predictor. The changes in the theta frequency in QEEG, and particularly changes in the mid-low electrodes in the frontocentral scalp area, might be a more sensitive indicator for evaluating clozapine treatment adequacy. Prophylactic AED should be given if plasma level are above 500 milligram per liter, if there are clear epileptiform discharge on EEG, and if patients develop stuttering or speech difficulties, or if seizure occurs. Anti-epileptic therapy should also be considered at the beginning of clozapine therapy in patients using other epileptic medication, patient with pre-existing seizure disorder, and in patient with neurological abnormalities. Most evidence is in the favor of valproate, but that doesn't mean it is the most effective. There is no consensus about what is the most effective anti-epileptic in clozapine-induced seizure. The other drugs can be used are lamotrigine, topiramate, gabapentin, pregabalin. Carbamazepine, phenytoin and phenobarbital, this should be avoided. Clozapine-induced obsessive compulsive symptom, a much debated entity. It fast. Sorry. This is a chart which shows pre-existing OCS, OCS continuing, intermittent OCS, as well as after drug OCS developing. These are the points, these are studies in favor of the point. Therapeutic approaches, these are the therapeutic approaches. Clozapine-induced gastrointestinal hypermotility. Junudi is not there, but she would be happy because she is the one who actually is very much interested in this hypermotility. Clozapine-induced hypermotility is actually at least 3 times more fatal than agrocytosis. Clonic transit time of clozapine-treated patients were 4 times greater than population norms and other than those on other antipsychotics, with 80% of clozapine-treated patients exhibiting clear hypermotility. Constipation is not a reliable guide for clozapine-induced hypermotility because these patients has loss of pain sensation, basically visceral pain sensation, as well as they have sedation. So, their bowel frequency cannot be judged. There is a dictum that less than 4 to 5 per week defecation is a cause for concern, but it is not yet established. All kinds of laxatives can be used with success. Clozapine-induced sialorrhea, it is more, it occurs due to esophageal dysmotility, not due to increased saliva secretion. Best can be treated by central acting anticholinergic, but there is risk. There is another option, atropine mouthwash. And the popular practice of adding amisulpiride is actually a bit debated because amisulpiride itself can cause sialorrhea. Clozapine metabolic effects. Clozapine is amongst the most weight increasing antipsychotic drug. Almost 50% of the patients experience up to 20% of weight gain. Histaminergic action and serotonergic action, as well as lifestyle changes, they account for the weight gain. Others are the same, but I would like to mention that glucagon-like peptide 1 receptor agonists are a new drug group which is showing much promise in clozapine's metabolic effect. These are different treatment strategies so far employed. Among them there are atomoxetine, metformin, sabitramine, topiramate, modafinil, all have met with some success, but none has been approved till date. These are 2 papers which shows that glucagon-like peptide 1 agonist do combat clozapine-associated obesity and diabetes. Clozapine-induced interstitial nephritis, ARF and enuresis. Clozapine-induced acute renal failure is a less known entity, but nonetheless very severe because it carries a mortality rate of more than 80%. I have not written here. Okay. It is also probably due to IG mediated hypersensitivity reaction. And clozapine-induced urinary incontinence often occurs in nocturnal enuresis. Pseudoephedrine, if tolerated, is the only drug which can reverse the clozapine-induced urinary incontinence in doses up to 150 milligram. Other drugs has been tried, but with less success. Clozapine withdrawal and rechallenge absence. In case of cardiac adverse effect, QTC prolongation, if QTC is more than 500 milliseconds, if the heart rate is more than 100, then use Phydrexia formulation. And if heart rate is less than 100, then use Bechet formula. Myocarditis, troponin level 2 times above the upper limit. Rechallenge is not indicated. Cardiomyopathy, rechallenge is not indicated. Orthostatic hypertension actually should be continued unless there is continuous syncope despite all the controlling measures. Drug-induced sinus tachycardia should be continued as well as non-specific changes. In case of atrial flutter, drug should be withdrawn and then slow rechallenge should be done. In case of cardiometabolic side effect, weight gain, drug should be continued. At hypertension and dyslipidemia, drug should be continued. Diabetes mellitus, if fasting glucose level is more than 350 milligram per dl, then drug should be discontinued and should be rechallenged after adequate measures. Metabolic syndrome, never. Diabetic ketoacidosis should be stopped for the acute episode, and once the acute episode subsides, slow rechallenge. Hematological adverse effect, though my topic is non-hematological, I have included this for benefit. For eosinophilia, no discontinuation. For neutropenia, ANC less than 1500. For patient with benign ethnic neutropenia, ANC less than 1000. Once the episode is over, slow rechallenge can be given. If problem, associated lithium augmentation can be done. Aglomeracytosis, rechallenge is not recommended. Drug should be stopped when ANC less than 500. Thrombocytopenia, if thrombocyte count less than 500, then it has to be stopped, and it is transient, so can be rechallenged. Same goes for thrombocytosis and leukocytosis. In case of leukocytosis, drugs should be continued. Other adverse effect for NMS, slower titration rechallenge. For venous thromboembolism, rechallenge should be slow and should be well judgmented. In case of constipation, ileus or subileus, drug should be withdrawn and later can be slowly introduced. Hepatic impairment, withdrawal followed by rechallenge. Seizures, drugs should be continued. Genetic predictability of ADR. Clozapine-induced agranulocytosis is genetically determined. The strongest association exists with HLA DQB1 and HLA B38. HLA DR4 is also found to be associated with specifically the late onset variety. Late onset clozapine-induced agranulocytosis is associated with HLA DR4, not others. The myeloperoxidase gene and NOX gene has also been suggested to be associated with CIA. One genomoid association study has suggested a role of myoid family inhibitor, MDA-FIC gene, and PG4 loci in desk of CIA. RS4640 mate allele was significantly associated with increased triglyceride level among female patients. CYP1A2 polymorphism 154C replaced by T RS2470890 is associated with the occurrence of more severe clozapine side effect, including seizures. Gene polymorphism that has been found to be associated with clozapine plasma concentration and response was ABCB1 gene, which codes for transmembrane transporter expressed in bowel mucosa, blood-brain barrier, kidney and liver. These are the all genetic evidences. My last slide, how much time? Huh? 1 minute. This is a unique paper published recently. It associated schizophrenia risk and antipsychotic response of genes, and curiously it has been found that those genes which causes antipsychotic response, they are also responsible for antipsychotic side effect risk. I end here.
Thank you, Dr.
Sorry for the encyclopedia and sorry for the hurried presentation, but cannot be helped.
Thank you, Dr. Mukherjee. Any questions, any clarifications?
Questions from the audience, please.
Why don't you come over to the microphone and... Yeah, of course. Why don't you take your seat? Yeah, introduce yourself.
I am Dr. Devashish Sharma. Firstly, I must thank Dr. Bhaskar Mukherjee for this presentation, quite an encyclopedic presentation nonetheless. Well, the questions would be, you have talked about atropine products as a mouthwash and other things, whether they are at all available in our commercial circuit so that one can use it. That is number one. Number two is the vexed problem pertaining to constipation related to clozapine. Certain medicines are advocated. We have very little experience with those medicines. Certain medicines has been there, tablets are available, we know, but we have very little knowledge about those, whether those medicines are helpful in clozapine-induced constipation, because Stephen Stahl's book nowadays talks about those medicines as well.
Yeah.
So, I would like your comments on that.
Number one, atropine mouthwash. Atropine mouthwash can be prepared in the home. Actually, the commercially available atropine drop, it should be dissolved in, the measurement was given that 1 commercially available atropine drop bottle in 1 liter water. Then that water can be used as a mouthwash. The problem is this approach has no evidence base, so I cannot advocate it. I can just mention it that yes, there is a measurement, it can be converted, but I have no experience in using it, and as well as there is no evidence base, and which has no evidence base, I cannot recommend. Now, regarding the second question of clozapine associated constipation, or let's say clozapine associated decreased bowel movement. I am going to the slide, just a minute. Almost every type of laxative used by human being are working in clozapine induced constipation. Just a minute, let me go to the slide. Yeah, this one. Look at the last one. Bulk forming laxative, emollients, lubricants, osmotic agents, stimulants, laxatives, other agents like lubiprostone. There are 5 papers on lubiprostone, misoprostol 2 papers, testosterone 1 paper, colchicine 2 papers, cisapride 1 paper, and I can give all the paper because I have Galaxy tab if you want. Rinapride, I have not found the paper, but there are evidences that there is a paper, but I have not been able to find it yet. Fluclopramide 1 paper, metoclopramide 10 papers. Orlistat probably has the strongest evidence because Orlistat has been mentioned in about 20 papers, and there are trials of Orlistat, presently ongoing trials in clinical trials or gov, and also there are published papers in the numbers of 15 to 20.
Okay, thank you, Dr. Mukherjee. I think we are running short of time. Yeah, fast, if we can have one more question. Not more than that, one more.
Achha,
fast.
Hello.
If you give a brief.
In clozapine, they have gastric hypermotility and also in diabetes mellitus hypermotility. What is the difference between these?
Pardon?
How? In diabetes mellitus, also hypermotility of the gastric hypermotility and clozapine also.
So you are telling about diabetes mellitus induced gastroparesis, right? And what is the difference between diabetes mellitus induced gastroparesis and clozapine induced gastrointestinal hypermotility, right? Okay, the thing is...
Just briefly give you the answer.
Clozapine induced gastrointestinal hypermotility occurs pan-gastrointestinal tract. There is chronic hypermotility, there is iliac hypermotility, there is every segment which is affected. But in case of diabetic gastroparesis, mostly stomach is involved, number one. Number two, the causative mechanism is completely different. In case of clozapine, it's number one, direct muscarinic action. Number two, direct antiserotonergic action. Number three, clozapine induced and autoantibodies which block neuromuscular junction in gastrointestinal tract and causes hypermotility. In case of diabetes induced gastroparesis, it is just sympathetic pulse induced by diabetes. The sympathetic nervous system of supplying gastrointestinal tract is affected and there is autonomic failure that causes gastroparesis.
Thank you very much, Dr. Mukherjee. I think we have to end this session. Next speaker is Dr. Shoubik Chakraborty. He has done post-graduation from the West Bengal University of Health Sciences. He is presently working in Burdwan Medical College. He is a local representative and he will speak on monitoring nephrotoxicity in lithium use. Monitoring nephrotoxicity in lithium use. Over to Dr. Chakraborty.
Thank you, Chairperson, sir, and good afternoon, everyone. My topic today is monitoring nephrotoxicity in lithium use. So the presentation overview will be like this. First, I will recapitulate briefly about the chemistry and pharmacokinetics of lithium. Then I will discuss in details about the effects of lithium on kidney in particular. Then the manifestations, the clinical manifestations of lithium-induced nephrotoxicity. Finally, the main core part of my presentation is monitoring of lithium-induced nephrotoxicity. And finally, if time permits, then I will go on to discuss the management of lithium-induced nephrotoxicity. So, the chemistry first. As you all know, that lithium is the third atom in the periodic table, situated in the most left-hand side. It shares its properties with molecules like sodium and potassium. Is the first solid metal. Its pharmacokinetics, an oral dose of lithium is rapidly and completely absorbed from the gastrointestinal tract. Peak reaches within 1.5 hours in case of a standard preparation, and for a sustained release preparation, peak reaches within 4 to 4.5 hours. There is very insignificant protein binding, in fact less than 10%. There is no metabolite and excreted almost exclusively through kidney, though some amount also excretes through sweat or saliva. Elimination T-half, as we all know, is in 18 to 24 hours, but in elderly, due to age-related decrease in glomerular filtration rate, there is lengthening of the elimination T-half in elderly, and the same thing happens if the duration of lithium therapy is prolonged. Now let us trace the movement of lithium through kidney. Lithium, as it's not protein bound, is completely filtered out in the glomerulus. but 90% of the filtered out lithium is reabsorbed back. 2/3 of that occurs in proximal tubules, and the remaining part occurs in the connecting tubules and the cortical part of the collecting duct. Now, mainly 3 sodium channels are involved in lithium reabsorption. One is sodium hydrogen exchanger in the proximal tubule, sodium potassium 2 chloride transporters in the thick ascending limb of the loop of Henle, and epithelial sodium channels in the collecting duct. The last one is the most important, as lithium causes impaired regulation of the expression of this channel on the cell membrane. We will come to it later. Now, I will show you 2 pictures where I will briefly describe the effect of lithium on water absorption. There are 2 hypotheses. The first hypothesis is ADH dependent, lithium's effects on ADH dependent water absorption. Now, ADH, the red square here, it acts on the V2 receptor, and as a result of that, there is a stimulation of G protein cascade that finally results in stimulation of adenylate cyclase enzyme, which raises cyclic AMP concentration within the cell. This in turn stimulates protein kinase A, and finally it causes insertion of the aquaporin 2 channels on the luminal side of the collecting duct cells. As a result of that, a portal is established for water to enter from the tubular fluid into the cells. Now, what does lithium do? It just blocks the adenylate cyclase. As a result of that, there is no aquaporin insertion. Please ignore this AG490 thing, it's not important. Another more promising hypothesis nowadays is ADH independent effect on aquaporin 2. Here we have what I have said about epithelial sodium channels is important. Now, epithelial sodium channels, what they do, they take in sodium from the tubular fluid onto the collecting duct cells. From there, sodium is transported back into the circulation with the help of sodium potassium ATPase pump. When lithium is there, the situation is rather little bit difficult, because these epithelial sodium channels transport lithium more effectively than sodium. But this Na plus sodium potassium ATPase pump's ability to transport lithium back to circulation is lower in comparison to sodium. So what happens? In presence of lithium, it's taken into the collecting duct cells more effectively, but transported out of the collecting duct cells less effectively. As a result of that, there is increase in lithium concentration within the collecting duct cells. This has 2 effects. This in fact inhibits the glycogen synthase kinase 3 enzyme, and it has 2 effects. One, it inhibits the aquaporin expression. Another, it blocks expression. It also inhibits expression of epithelial sodium channels. So overall, there is less chance of sodium reabsorption as well as water reabsorption. So to summarize, there is problem in urine's concentration ability of the kidney, and over prolonged time, it also blocks the expression, mRNA expression of these channels. So in fact, synthesis of this aquaporin channel is also decreased. So to summarize, there is decrease in the renal concentration ability. In fact, that is the most common renal side effect. It usually is of no clinical importance, but it is found as high as 50% of patients taking lithium, and it occurs within 8 weeks of starting lithium therapy. And unfortunately, many of these cases may not be reversible. But since patient is clinically not very significant, patient doesn't bother about it, so we don't have to bother about it either. But what we have to be cautious about, 20 to 40% of these cases progress on to develop nephrogenic diabetes insipidus, characterized by the characteristic symptoms of nephrogenic diabetes insipidus, that is polyuria, polydipsia, persistently low urine-specific gravity less than 1.010, and not responding to desmopressin. This is one of the major lithium-induced side effects. There is also chance of hypochloremic metabolic acidosis. The condition is believed to result from the increased excretion of decreased proton excretion in the proximal tubule and increased reabsorption of the acid equivalents distally. The next thing, the more important thing, is the chronic tubulointerstitial nephropathy. There is characteristic tubular fibrosis and interstitial tubular atrophy and interstitial fibrosis in patients receiving lithium for a long time. And histopathologically, there are some characteristic microcystic cyst development in the collecting duct cells. Although rare, but there are innumerable case reports about lithium-induced nephrotic syndrome, which is mostly minimal change disease, but some cases of focal segmental glomerulosclerosis is also reported. Now, the pathological mechanism by which lithium causes this toxicity, lithium-induced nephrotoxicity, is not precisely known. It most probably involves the inositol monophosphate second messenger system and inhibition of cell cycle. The risk factors for lithium-induced nephrotoxicity, most importantly, is the duration of treatment. Apart from that, advancing age is another very important risk factor. Concomitant use of nephrotoxic drugs, comorbidities that can also hamper kidney, like diabetes or hypertension, will also be very important risk factors. Another thing, though controversial, multiple daily regimen is suggested to be more nephrotoxic than single daily regimen. And finally, lithium-induced hyperparathyroidism. It's an under-recognized side effect, but it occurs in more than 10% of patients receiving lithium for more than 10 years. I mention it here because it may cause hypercalciuria, resulting in nephrocalcinosis and nephrolithiasis. So on this basis, we will come to the main part as what to monitor in patients receiving lithium. As the main problem is problem in concentrating ability of the kidney, urine osmolality is the most accurate measurement of concentrating ability, and that should be monitored if possible. But since it's very cumbersome, we have a quite cheap and easily available surrogate marker, that is urine specific gravity. And 24-hour urine volume is another parameter that also measures renal function, but it's cumbersome because the patients of polyuria might have passed more than 10 liters of urine per day, and you know the problem of carrying that to lab. Another thing is serum creatinine. It's also very easily available, but the problem is that about the creatinine molecule itself, because its concentration is dependent on the total muscle mass. Arnold Schwarzenegger will definitely have much more serum creatinine than I have. Diet with meat also affects the creatinine concentration in the body. Dehydration, another problem, especially in lithium groups, alters serum creatinine concentration, and it's insensitive to mild degrees of renal insufficiency. Glomerular filtration rate, this is also another good marker for chronic nephrotoxicity. Inulin clearance for glomerular filtration rate is the gold standard, but it's so cumbersome, it's practiced only in laboratories. So another alternative is 24-hour creatinine clearance. I'll come to that later. But for keeping everything in mind, the KDOCI recommends estimated glomerular filtration rate is the best effective marker for glomerular function. For estimated glomerular filtration rate, usually two formulas are used, Cockcroft-Gault formula and MDRD formula. But there is one problem. As you can see, there is serum creatinine concentration in one of the parameters. It's also less sensitive in early stages of kidney disease, but overall, this is one of the best markers, the estimated GFR for the nephrotoxicity. And when there is doubt, 24-hour creatinine clearance should be another marker for, is better marker than estimated glomerular filtration rate for nephrotoxicity. It's preferred in extremes of diet, people who are taking creatine-rich diet, rich in meat, or those extreme vegetarians, or those muscle mass extremes like amputation, malnutrition, and highly developed bodies like Schwarzenegger, as I have said. Urine protein, essential in lithium-induced nephrotic syndrome. Its routine analysis is using dipstick method is usually sufficient, but if necessary, it can be quantitated with the gold standard 24-hour urine collection. Now, these are the tests that we have to do now. Let's come to the recommendations. FDA, US FDA in its guideline recommends that patients who are receiving lithium should be monitored using urine-specific gravity, urine osmolality, following a period of water deprivation of around 12 hours, 24-hour urine volume, and urine protein, and for glomerular functions, serum creatinine and creatinine clearance. These tests, according to FDA, should be done at baseline and every half year to yearly interval, and during lithium therapy, progressive or sudden change, even within the normal range, should be cautiously monitored. APA guideline, almost similar, they states that lithium renal function should be monitored in patients receiving lithium every 2 to 3 months in first 6 months, and thereafter stabilization, it should be monitored every 6 months to 1 year. NICE guidelines also recommends renal monitoring every 6 months. The same thing also there in ISPD guidelines as well as Canadian guidelines. Now, as I think I have got time, so I will spend just 2 slides on the management. There's, if there is nephrogenic diabetes insipidus is suspected, adequate fluid replacement and using minimum effective dose of lithium is necessary. If drugs needs to be given, then amiloride, thiazide can be given. Single daily dose might be beneficial, and there are some controversial strategies like potassium supplementation, inositol, desmopressin, etc. And if lithium-induced nephropathy is suspected, then substitution is the only option, but it must be done after risk-benefit analysis, because the incidence of lithium-induced chronic kidney disease in lithium-treated patients is pretty low. It's just marginally higher than that of general population. So, if we have to substitute lithium, we must analyze the risk of stopping lithium. And one more thing, if the creatinine level goes above 2.5 or creatinine concentration falls below 40 ml per minute, then substitution won't help because the disease has already passed on to the irreversible stages. In this case, probably renal replacement therapy will be necessary eventually. So my take-home message would be this: kidney function should be assessed with reasonable regularity. Pros and cons of individual indices should be kept in mind. Choice of test may vary but must include at least serum creatinine and urine analysis for specific gravity and protein, and abnormality in screening tests must lead to comprehensive evaluation. And one more thing that I have not mentioned, the fear of nephrotoxicity should not deter us from prescribing lithium, because as I have said, the incidence of chronic kidney disease in lithium treated patients is just marginally higher than that in general population. Lithium saved much more lives than it took. So these are my references, and finally thank you for keeping awake.
Thank you, Dr. Chakraborty. I'll ask
it's only creatinine, so not albumin ratio.
Yes. Any other questions? Any other clarifications?
I don't know how I'll frame this question. It is to do with EGFR to begin with. Suppose there's a scenario, we do a creatinine test which comes to normal. According to the Cockcroft-Gault formula, specifically if an old elderly lady, a clinical scenario, an elderly lady...
Excuse me, let me go back to the slide.
I more or less, I remember the Cockcroft-Gault formula.
Okay.
So what happens if it's kind of a lady age 65 with a lean body weight of around 42 kgs. So both the numerators are much lower. So what will happen is that the EGFR will invariably come down, even if the level of creatinine is normal. Say for example, if the creatinine is 0.9 or 0.8.
Yes.
but an elderly lady of less body weight, okay, they will have kind of, the less. And because why I'm mentioning lady, because into 0.85, you have to make a correction that into 0.85. So there is every chance of that elderly lady slipping into an EGFR which is lower. So what do we do then? What is the cutoff with regards to doing a creatinine clearance? Because a 24-hour creatinine clearance is not an easy job. I mean, we can't subject everyone, and none of the recommendations mentions about that. We have to start with creatinine level, isn't it?
Actually, I'm sorry, there is no data about it, so I cannot say for sure. But if the creatinine clearance is below 60, I'm sorry, the EGFR is below 60, then we should be cautious and it should be monitored further.
What do we mean by cautious? Say, in a clinical scenario, we have someone with an EGFR of less than 60.
Then we have to do creatinine clearance. That was prescribed.
So we shouldn't stop the lithium altogether. We do a creatinine clearance.
No. Yes.
And then with the creatinine clearance, if we get that value, then
we have to consider stopping. In fact, if it goes below 40, then there is no benefit by stopping lithium.
Yes. So where? So where do we say that, okay, I mean, if it has become irreversible, like below 40, then obviously we have to stop.
Yes.
But if it is...
Actually, there is no benefit in stopping lithium in those cases also. Because eventually the patient will need renal replacement therapy even if you substitute lithium.
No, I mean...
I think we can go on discussing about it.
I think it is pertinent. What I'm saying is that where should we draw the line? We shouldn't wait till it goes into the irreversible stage.
I found no particular guidelines for that, to be precise.
God formula is not very precise, but the MDRD formula, that is very precise, and that gives you the actual EGFR. It is very easy to obtain in your mobile. App is there. Okay, you have to just put these things anywhere. So MDRD, first thing, MDRD formula, you should go always. And MDRD formula is more precise, more accurate than Cockcroft-Gault, first of all. So from an EGFR is always puts much more important than simple serum creatinine. That is.
Would you introduce yourself?
I am Dr. Arnab Banerjee.
From?
From Burdwan. I am a practicing physician here.
Okay. Thank you very much. I think we end up this session because we can take only 2 questions. Okay.
That was not a question.
You want to comment?
It was not a question.
He replied, he gave a comment. Okay, you could give fast if you have any questions.
What is the role of immunomodulatory action of lithium on kidney? Specifically, chronic tubular disease, whether there is any role of immunological activation or masks?
Sorry, I don't know. And I think it's out of purview of this discussion.
So, I want to know, was there any reference for it?
No, he has not. As he mentioned, that he has not gone through any such reports. Thank you. We move on to the next speaker. Thank you, Dr. Chakraborty. We move on to the next speaker, Dr. Paramita Roy. She did her post-graduation in psychiatry from Central Institute of Psychiatry, Ranchi in 2005. He started working in Burdwan Medical College as a senior resident and has been now promoted as an assistant professor. He is currently posted in Institute of Psychiatry as associate professor, and she has published around 12 papers in national and international journals, and she will talk about
lithium and thyroid.
Lithium and thyroid disequilibrium. Over to Dr. Paramita Roy.
Thank you, sir. Good afternoon. My topic is yes, sir. Lithium and thyroid disequilibrium. Lithium is still a fundamental and widely used drug in psychiatry. Thyroid abnormalities associated with lithium treatment is widely reported in medical literature over the past 5 decades. And it is the commonest endocrine side effect of lithium therapy. Coming to historical background, in 1967, occurrence of goiter in patients receiving lithium was mentioned at a conference in Denmark, and data were reported in 1968. Since then, the physiological and clinical effect of lithium on thyroid function in animals and humans have been extensively investigated. Now, what are the effect of lithium on thyroid physiology? Lithium entered the thyrocyte via the sodium iodine symporter, concentrated at thyroid at the level 3 to 4 times that in plasma. It increases the intra-thyroiodine content, inhibit the coupling of iodotyrosine, inhibit microtubule formation, and mechanism of inhibition involve an alteration in the tubulin polymerization as well as inhibition of action of TSH on cyclic adenosine monophosphate. This is in a nutshell the influence of lithium on peripheral thyroid physiology. From this picture, it is very clear that lithium may block the every stage, that is from active iodine uptake to T4 synthesis and T3, T4 bound to thyroglobulin. Every steps is blocked by lithium. Then coming to thyroid abnormalities, these includes goiter, hypothyroidism, unmasking or induction of autoimmune thyroiditis, hyperthyroidism or thyrotoxicosis can also be observed, but it is rare with a prevalence of 0.7% only. But the prevalence of hypothyroidism and subclinical hypothyroidism is quite high with or without concomitant goiter. It is very prevalent among the patient on lithium therapy and varying frequency ranging from 0 to 52%. And prevalence is higher in patient from iodine deficient area and patient receiving long-term lithium therapy. And as we know that lithium is a drug which we give for long-term, so it is very common. Disparity in the prevalence can be explained by different study definition, iodine intake, and baseline thyroid autoimmunity among the study subjects. Then age and sex prevalence. Lithium-induced hypothyroidism is more common in women as the other hypothyroidism. In normal female, thyroid volume increases significantly after 28 days of lithium treatment, although no change is noted in male, suggesting a difference in susceptibility of male and female with hypothyroidism. Age, it has been shown that the older patients are more prone to development of goiter, and it increases with the age. That is, if its patient is more than 50, the chance of goiter formation is more. Coming to other factors affecting hypothyroidism and goiter formation, this is the variation in iodine status, dietary goitrogens, immunogenic makeup. Their interaction in the setting of chronic lithium therapy contribute to variable pattern of expression of hypothyroidism in different ethnic group and areas. And also family history is also important here. Goiter is the most common clinical finding of lithium-induced thyroid abnormality. It occurs as a diffuse, symmetrical and non-tender neck swelling. It may develop within weeks of starting lithium or take months to years before lithium, after lithium treatment, before the goiter is evident. But if there is enlargement of a nodule or the finding of an irregular shaped thyroid gland is there, then it is not likely due to lithium. So appropriate investigation must be performed as the other cause may be there. Coming to pathogenesis, the initial inhibition of thyroid hormone synthesis and release by lithium result into increased TSH concentration leading to thyroid enlargement. Other mechanism proposed to explain thyrocyte proliferation are activation of pro-proliferative tyrosine kinase and beta-catenin signaling pathway. Then how would we investigate for the lithium-induced hypothyroidism? Laboratory studies are indicated to exclude concomitant hypothyroidism and existence of a thyroid-specific autoimmune process. Serum thyrotropin level is a first level test. Level higher than normal indicate concomitant hypothyroidism. Circulating antithyroid, peroxidase and anti-globulin antibodies. These antibodies indicate presence of a thyroid-specific autoimmune process and a higher future cases when the patient has normal thyroid function test finding. The frequency of positivity of antithyroidal antibody is higher in lithium-treated patient with either overt or subclinical hypothyroidism than in control subject with comparable thyrotropin level. Serum free thyroxine and total triiodothyronine test are second level test. Low level indicate hypothyroidism, although T3 or even free T3 testing alone is usually insensitive for a diagnosis of hypothyroidism. Furthermore, serum thyrotropin testing is more sensitive for a diagnosis of hypothyroidism than free T4 testing. Exaggerated response to thyrotropin releasing hormone stimulation test is a third level test. So these are mostly reserved for the research purpose, and because TRHs can be manufactured in pharmacies of certain academic centers engaged in clinical endocrinology research. Coming to imaging study, thyroid ultrasonography is a very useful and easily available test which can be used to quantitate the thyroid size and show a small volumetric increase in persons with lithium-induced goiter. Other investigations are 123 iodine uptake test. This is also a second level test. 123 iodine uptake may be slightly increased in patient with euthyroid goiter because of compensation of gland for decreased coupling and or iodination despite normal serum thyrotropin level. 123 iodine uptake is definitely increased in small percentage of patients who develop lithium-induced thyrotoxicosis. Iodine percolate, I am coming to this thyrotoxicosis later on. Iodine percolate discharge is a third level test. This is seldom indicated and results are positive in almost all patients on long-term lithium therapy. This is the histological finding. Histological changes have been studied in research setting. Effects of lithium administration on normal thyroid gland histology in rodents suggest hyperplasia and colloid depletion in early course of therapy. Eventually, there is cellular hyperplasia and accumulation of colloid and thyroglobulin in supranormal amount as the lithium inhibit the colloid endocytosis and iodine efflux from thyroid. The nodule associated with the colloid goiter observed in patient on lithium therapy tend to be rich in thyroglobulin. And in patient with underlying thyroid pathology like multinodular goiter, post-thyroiditis changes, histologic features of underlying pathology are evident from the histologic slides. So the question is how to manage these patients. Management of goiter is comparable to that of among the healthy population. However, levothyroxine replacement therapy is preferred more among the patient with significant thyroid enlargement and accompanying compressive symptoms are there, but it is a rare condition. Levothyroxine should be given in a dose such that TSH is not totally suppressed and serum T4 and serum T3 are within normal limit. Serum T4 may be occasionally be allowed to exceed normal range, but T3 should never be allowed to be high up. Thyroxine therapy is often not effective in patient with goiter of long duration because of fibrotic changes. This is a chart for treatment. When we have raised thyroid stimulating hormone level more than 10 milliunit per liter with or without low free serum thyroxine, then we have to treat with thyroxine for lifelong. But if the level is 5 to 10 milliunit per liter with low free serum thyroxine, then also we have to go for treatment. But if it is level is 5 to 10 minutes with normal free serum thyroxine level, then if the symptom of hypothyroidism present, then we will go for treatment. But if the symptoms are not present, then we have to check the status for thyroid peroxidase antibody. If the results are positive, we have to recheck the thyroid stimulating hormone level annually, but if it is negative, then recheck thyroid stimulating hormone level every 3 years. Another condition is subclinical hypothyroidism, where the elevated TSH with normal circulating thyroid hormone concentration is found. This should be considered in patient who is not showing good response to lithium. And symptoms of the condition may appear within weeks of starting lithium treatment, but may not occur for many or even months or even years, and may include unusual or atypical features like myxedema coma. The male-female ratio is again 5:1, showing the female preponderance. For management, a recent consensus recommended that patient with subclinical hypothyroidism with a TSH value less than 10 should not be treated, and drug that altered the bioavailability of thyroxine like iron, Shoa and some indigestion remedy, it should be avoided if possible. And if these substances should be given, then it should be given as far apart in time from the thyroxine as possible. Hyperthyroidism or thyrotoxicosis is very rare. It is characterized by a transient and painless thyroiditis. Reports have also shown lithium is associated with granulomatous thyroiditis, lymphocyte thyroiditis and non-specific thyroiditis. Transient and painless thyroiditis is due to a possible direct toxic effect of lithium on the thyroid gland. And another mechanism proposed in pathogenesis of lithium-induced hyperthyroidism is related to the autoimmunity and autoantibody formation. For management, patients with lithium-induced hyperthyroidism are best treated with antithyroid drug like carbimazole with or without steroid. And radioiodine or thyroidectomy should be reserved for patients with lithium-induced Graves' disease, especially in case of poor compliance with antithyroid drug. And if the patient have toxic nodular goiter with or without compressive symptom, thyroidectomy is the only solution. So what as we can do for pre-lithium thyroid function test? Measurement of serum concentration of TSH, free FT3, FT4, antibody, TPO and ultrasonic scanning can be done. It should be repeated at 1 year. Then annual measurement of TSH may be sufficient to prevent the overt hypothyroidism. But if there is presence of subclinical hypothyroidism, that is raised TSH is there, shorter interval between the assessment are advisable, that is 4 to 6 months. And measurement of TPO antibody and ultrasonic scanning may be repeated 2 to 3 years interval. Now when should we refer the patients to endocrinologist? The patient must be referred to endocrinologist if the TSH concentration are repeatedly abnormal and or goiter or nodules are detected. And in case of lithium-induced thyrotoxicosis, consultation with a cardiologist may be necessary, especially in elderly patients who have a high prevalence of coronary artery disease, arrhythmia and congestive heart failure. Now, what is the take-home message? What should we do if the lithium causes thyroid abnormality? In our opinion, due to availability of frequent therapeutic means, thyroid abnormality should not be an outright contraindication to lithium treatment. Lithium should not be stopped if a patient develops thyroid abnormality, and any decision should be made taking into account that lithium treatment, despite its potential toxicity and side effect, is perhaps the only efficient means of reducing the excessive morbidity associated with affective disorder. To conclude, lithium is an effective and pivotal drug in the management of affective disorder and also the prophylaxis of bipolar affective disorder. Significant proportion of the patient treated with lithium develop clinically or radiologically confirmed goiter and hypothyroidism. It increases the risk of thyroid autoimmunity in susceptible individual. Baseline and regular assessment of thyroid function test, that is TSH and free T4, thyroid size using thyroid ultrasonography, and measurement of titer of autoantibody against thyroid peroxidase is recommended among the patient prior to and during the lithium therapy. Thank you.
Thank you, Dr. Paramita Rai.
I am Dr. Subrata Kundu, consulting physician practicing in Burdwan. My question is that if the patient is on thyroid replacement therapy, do you want to start lithium in that patient? Number one. And number two is that what is the absolute indication for stopping lithium in case of thyroid abnormalities? I mean, the patient is getting lithium, the patient has got some thyroid abnormality either in the form of hypothyroid or hyperthyroidism. Now, what is the absolute indication that we want to stop the
Sir, actually, sir, there is no absolute contraindication has been found for stopping lithium. And if there is other alternative, if the patient is having hypothyroidism and for starting lithium, we will first look for other alternatives. But if the lithium is the best choice for the patient, then we can go for lithium along with the hypothyroid management.
Actually, subclinical hypothyroidism is a not a clinical diagnosis. In subclinical hyperthyroidism, if the less than 10
yes, sir.
TSH level, then if the patient is want to conceive, then we given treatment, or anti-2PA antibody positive, then we give, or if there is any sign symptom, then we treat with levothyroxine. And in elderly, in less than 60, an elderly patient, if there is less than 10 TSH, we should not giving
go
any levothyroxine. We wait and repeat after 3 months. After 3 months, if another laboratory, or if there is more than 10 or not. And most common cause of autoimmune, dietary and other cause.
One more question, please.
You said that ultrasound and TPO should also be done. We usually routinely do TSH and free T4 to see the progress of thyroid in case of lithium therapy. But you suggested that these two also should be done.
Yes,
so
sir.
how frequently should that be done?
No, first before starting lithium, then after yearly.
Once in a year.
So yearly we should do 3 tests: TSH, ultrasound,
TSH and ultrasonography. Said,
and you said
TPO also.
TPO also.
The
So
guidelines
all 3
said.
should be
Yes,
guidelines
sir.
says that.
Yes, sir.
Okay, thanks.
Sorry, it's an extension of the same question.
Okay.
With regards to I mean, afterwards it's okay, because your chart mentioned about, and that is what I have read as well, in terms of between 5 to 10, like subclinical hypothyroidism, if the value is between 5 to 10, there is a rationale of doing anti-TPO antibody. But what is the rationale of doing an anti-TPO antibody? Because we also have the cost implications.
Yes, sir.
And ultrasonography of the thyroid gland and the anti-TPO antibody. So unless there is a robust evidence that it helps, what is the clinical utility? If we do a free T4 and a TSH, and if the levels are less than 5, then we should be, I mean, there's no need of doing an ultrasonography or an anti-TPO antibody. But if it is between 5 to 10, then also we do only an anti-TPO antibody. The ultrasonography only comes into existence if we find that there is an evidence of
palpable goiter. Yes,
there is a palpable goiter. So I don't think it is a routine test. Both the anti-TPO antibody as well as the ultrasonography is not a routine test. It will be determined on
by the TSH level.
On the pre-treatment TSH levels, and on the basis of that we can take a decision. That is, I think, what the guidelines mentions.
Okay.
Okay, thank you, Abir. I think we wind up this session. We had 3 extremely informative presentations today on long-term side effect of psychotropic medication. First is on clozapine and second on lithium carbonate. Clozapine, I think Dr. Bhaskar Mukherjee did fairly exhaustive work, but what I felt is he should have mentioned about the relative frequencies of these side effects and as they have been reported in the various parts of the world. That would have enlightened us regarding safety, precaution and identifying risks for administering clozapine. There is a study presently, I didn't ask you to stand up and say something. There is a study right now going on in PGI Chandigarh on clozapine, and they have found that metabolic side effects are more compared to hematological side effects and cardiac side effects, as he has pointed out. Shobhik Chakraborty did a fairly good job on nephrotoxicity, what are the risk factors which are involved, and how to identify them, what precautions we should take, what kind of investigations we should do. But one thing he should also he should have mentioned that, you see, nephrotoxicity is primarily dose dependent for lithium carbonate. So at one side you have to monitor renal functions. On the other side you also have to monitor the dosage of lithium which you are giving, because that has been found to be of significant implication over a period of time, which produces interstitial fibrosis and these kind of tubular necrosis, these kind of long-term side effects. Lastly, Dr. Paramita Roy gave an excellent presentation on thyroid and lithium, and we have learned many things from her, especially on thyroid autoimmunity, which need to be looked into seriously, long-term effects on the thyroid. So we had a fairly good session, and the best question prize goes to Tushar Kanti Mondol, Dr. Tushar Kanti Mondol. He is an associate professor of community medicine in IPGMR, SSKM Hospital. So I request to hand over the...
Thank you very much, sir. Oh, you want to, sorry, ask a question? Oh, thank you, sir.
This is the best question award.
Sir,
which one is the best?
This one. Thank you, sir. May I also invite all the three speakers to come on stage, please, for the speakers' souvenirs to be received, to be accepted from the chairperson this afternoon. And it was a really fantastic session, and thank you to the audience for being such an active listener and a participant, especially being the post-lunch session. Dr. Bhaskar Mukherjee, Dr. Shovik Chakraborty, and Dr. Paramita Roy, please come on stage. Thank you. May I also request Dr. Shikha Mukherjee to come on stage to give away the chairperson's souvenir from the organizing committee to Dr. Divyagopal Mukherjee, please. Thank you, everyone. A big round of applause once again. Great. This brings us now to the fourth and the final CME session on the 20th of August at the Psychiatric Conference 2016 at Sinclairs Resort, Burdwan. We have a slightly shorter session of about 50 minutes to be chaired by Dr. Debashish Sanyal, along with Dr. Shujan Sharkar, please. Sir, please, if you would come on stage to chair the next session. And we've got two speakers for this particular session. Thank you.
On আছে? অন ছিল তো। Well, after another grueling and interesting session, now we have another round of academic feast coming up. We have two speakers. I have the honor and privilege to introduce someone who doesn't need any introduction. Everyone knows him. And so far as people of Burdwan is concerned, he is a very well known. I welcome Dr. Devashish Konar, who is a distinguished psychiatrist, known academician. He needs no introduction, but still I have the honor of inviting him as a speaker.
Thank you, sir. Prescribing psychotropics to children and adolescents. That's all right. Right. Thanks. High resource is where there are many child psychiatrists and a team working with children. And the burning issue of high resource countries is, are we prescribing more? Now coming to low resource, where there are few child psychiatrists and there is hardly any team working with children. And the burning issue is, are we able to reach children who need treatment? We all talk that we need teamwork to do child psychiatry. So, what is teamwork in low resource countries? Do we really need teamwork in low resource countries? Is it the same team we are talking about as in high resource countries? If we really need team, who are the members of this team? Whom to educate? What to educate? How to make a team? That is the theme of this presentation. I start with a case Vignay. A child of 13 years, you may say adolescent, sleeping excessively, yawning when awake, nagging, clinging, irritable, demanding, and destructive. Illness started following a brief febrile illness. Earlier had a similar episode 8 months back. So this is, as you can see, is not an uncommon case that we rarely see. We see it very commonly. This presentation is a common presentation of children. What would you specifically want to know about this case? The most important, as I feel, is history of bipolarity in the family, which is positive in this case. The second is thyroid status, which is negative in this case. Psychosocial stressor. You don't have any psychosocial stressor, obvious one. So, how this case can help you to educate people whom you want to educate about dealing with children. So, as you can see, taking history, proper history is important. Psychoeducation about bipolarity is important. There may be many methods of treating, there may be difference of opinion, but how I approach, if I find that there is a history of bipolarity, I'll start treating with quetiapine. If it doesn't work, I'll add lithium. If depression persists, can think of adding SSRI. Means I will not straightway jump to antidepressant, because that gives me some time. I buy time by prescribing quetiapine and lithium and don't precipitate a manic episode. Then all medicines are to be built slow. So whomever you want to educate, you have to educate this thing that medicine have to be built up slow in children. Frequent follow-up visits. Compared to adults, you need to have more frequent follow-up visits. Support yourself with investigation related to treatment like metabolic profile, renal profile, and lithium level. And plan prolonged follow-up. Few drugs are licensed. Historically, pediatric pharmacology in general and pediatric psychopharmacology in particular have received much less research interest and funding than their adult counterparts. As a consequence, relatively few drugs are licensed for use in child and adolescent population. There is growing evidence base of increasingly widespread practice of using psychopharmacological treatment in children and adolescents. Earlier, we were very scared because we didn't have much data, but now the use of psychotropics is increasing. Childhood psychiatric illnesses are not trivial ones. Childhood and adolescent is a period of extraordinary biological, psychological, and social growth. However, at such times, individuals are also vulnerable to disruptions of healthy development. In fact, a staggering 50% of all adult psychiatric disorders have manifested by the age of 14, with 75% manifesting by age of 24. Moreover, 2/3 of pediatric onset psychiatric disorders are moderate or severe, and most continue into adulthood. Such patterns clearly indicate that importance of identifying and appropriately treating psychiatric disorders as early as possible to preserve healthy development and to reduce individual suffering and societal burden. You need to shift to collaborative approach. Mental health issues are being recognized more and more at earlier age. Issues are alarming, at the same time recognizing them early is good for the child. The shortage of clinicians with specialized training is always the main constraint in the case of low-resource countries. Medication may become an important part of treatment as a result. Judicious evidence-based prescribing, slow titration, and never ever over-prescribing should be the mantra to succeed in treating children. Medication is only one piece of treatment plan, but relying on it may be in need if other trained personnel are not available. Consultation should be early, treatment judicious. One of the most important needs in case of child mental health is facilitation of earlier psychiatric consultation. Too often, referral for psychiatric evaluation is only considered in context of a significant worsening of clinical status, such as onset of suicidal ideation, or when a patient or family is beginning to lose hope and turn to medications as last resort. It is important for providers to inform patients and families that waiting for symptoms to become more severe and more severe may decrease the probability of response or remission of symptoms. So, on the one hand, they need to be educated to come early for assessment, and on the other, you need to restrict yourself in prescribing medication unnecessarily or at the drop of hat. Reaching the unreached is the real challenge. Children and adolescents with psychiatric illness in low-resource country is grossly undercared section of population. By rough estimates, 10% of children and adolescents have a diagnosable mental health disorder. Very few have access to specialist service. The treatment gap is huge. Service delivery model has to be indigenous, with limited trained child psychiatrists training other general psychiatrists, and even pediatricians and family physicians may be more important than in developed economies. Sensitization about diagnostic clarity, proper drug counseling and psychoeducation skills, and identifying adverse effects are the minimum targets that we need to foray into. Selective and useful knowledge. This I'll consider the most central slide of my presentation. Transmitting information in this collaborative model has to be specifically very restricted and simple. Generalists and other specialists have to be acquainted with restricted number of medicines. In case of antipsychotics, possible drugs are risperidone, aripiprazole, and quetiapine. In case of antidepressants, fluoxetine, sertraline, and escitalopram. In mood stabilizers, lithium, divalproex, and among drugs for ADHD, methylphenidate and atomoxetine. I feel beyond these drugs, any general psychiatrist or pediatrician should not venture. There is no need to, in fact. Chronology of progress. In 1997, US Congress authorized FDA to grant additional 6 months of drug exclusivity in return for conducting specific studies in children. More recently, introduced legislation have given FDA the authority to require industry to conduct specific pediatric investigations when off-label use in children can be anticipated. Best Pharmaceuticals for Children Act mandates the final study report of industry-sponsored trial to be posted on the FDA website. Research units on pediatric psychopharmacology, RUP, under the leadership of NIMH have formed. Research relevant to child psychopharmacology increased remarkably since then. General principles of prescribing for children. Formulating principles of prescribing psychotropic medicine in childhood and adolescence is not very simple. Many a time, illness does not fully evolve and diagnosis may be difficult. Diagnosis can be difficult also because comorbidity is very common. Begin with less, go slow, and be prepared to end with more. I mean, sometimes children may need as much dose as adults, so that you have to tailor. And then best way to decide the dose is milligram per kg per day. This ideally should be child-specific data and not the one extrapolated from adults. Off-label use has to have a scientific basis. You must have consent, and the rationale for use has to be documented. Regular monitoring of treatment in childhood and adolescence is very important. Allow time for an adequate trial of treatment. Where possible, change one drug at a time. Monitor outcome in more than one setting like home, school, playground. Education of patient and family, at times even teachers, about medication is essential. Children need to be studied separately for their own data. Children are not half, quarter, or 1/10 adults. Simple body weight basis of dose fixation is not adequate. Pharmacodynamics and pharmacokinetic considerations are important. Long-term deleterious effects are to be kept in mind. Avoid extrapolating. There are risks inherent in extrapolating from adult data. I wanted to highlight it, so I reiterated it. Knowledge of essential difference between child and adult psychopharmacology should always guide a prescribing physician. I'd have loved to cover those areas, but time doesn't allow. Clinical guidelines. At the starting point, when recommending psychotropic drugs, complexities of pharmacokinetic and pharmacodynamic factors have to be considered. Later, in every case, it's necessary to titrate the dose against the desired clinical response. Whenever possible, blood levels should be done. Some of them are very useful in monitoring the optimum dose of drug, example, lithium and anticonvulsants. You know all these, lithium 0.6 to 1.2 milliequivalent, carbamazepine 8 to 12 nanogram, and valproic acid is 50 to 125 microgram per ml. These are more important in case of children because they are very vulnerable from side effect point of view. Preventive measures to avoid drug interaction. Obtain a detailed medication history including OTC drug and compounds from alternative approaches than modern medicine. Young patients constitute high-risk group, so use drugs with minimum interaction potential. Avoid polypharmacy whenever possible. Educate patient and family. Include written instruction when appropriate. Keep detailed updated references and important potential drug interactions for your own reference. Then specific issues are more like, let us first discuss diagnosis versus target symptom approach. At times, categorical diagnosis is easy to use. At other times, functionally impairing symptom control may be better approach to deal with clinical situation. Effective pharmacotherapists should be mindful of both target symptom and the context and setting in which they occur. Therapeutic alliance is slightly more complicated in children than adults. In pediatric psychopharmacology, specifically, there is always at least dual alliance, if not more, that must be acknowledged and nurtured. Prescribing clinicians should strive to include both patient, parents, grandparents, guardian into the working alliance paradigm of goal identification, task consolidation, and therapeutic bond establishment. Children's concept about medication is to be acknowledged and respected. They may be concerned about the physical properties of medication itself, like form, size. Then there could be wrong kind of notions about medicine. The patient may believe that only children who are sick or bad have to take medicine. This is a very common notion that parents will say, badmasi karoge to leke chale jayenge tumko chamber leke doctor ke paas leke sui dilwa denge tumko. That kind of thing is very common. So then coming to timing of the, and one thing I do, I give chocolate to children. All children that come to my, say they get the notion that it is not only the place to get injections, it is also a place to get chocolates. Timing of the dose and frequency, like morning, evening, during school doses have to be kept in mind. Special caution must be taken in using injectable medications for children and adolescents with history of trauma. Comorbidity is more a rule than exception in children. Example, intellectual developmental disorder, autism, ADHD, ODD, epilepsy, conduct disorder, anxiety disorder, depression, they all come in different combinations. Over the last decade, pharmacotherapy in pediatric psychiatry has shown similar trends towards polypharmacy. Here you have to be more cautious because children have more propensity for seizure and EPS. Adverse events are more likely when multiple drugs are used and interactions can be unpredictable. Combining drugs for the same pharmacological class is rarely indicated except when cross-tapering while switching drugs. Combining drugs can be rational when their pharmacological actions are complementary, although the side effect burden is usually higher even in that case. Polypharmacy requires pharmacological expertise and should usually be supervised by a specialist. When advising investigations, it is possible to have an adequate, it's not possible to have an adequate battery done, be at least optimum. Adequate investigation may not be feasible due to financial constraints in low resource countries, but important ones cannot be omitted and safety concerns may never be downplayed. So taking hints from clinical presentation regarding adverse effects may be more important in context of low resource countries when advising battery of investigation. Some special precautions. First, we should be committed to try to diagnose the condition to best of our understanding and ability before we prescribe. We must remember pharmacotherapy is only a part of treatment plan. Consideration must be given to all aspects of child's life like psychosocial, educational and family intervention. Obtain an informed consent and after discussing possible side effects and need for monitoring. Discuss black box warning. Use the lowest possible dose. There should be frequent contact with patient and family. After a period of stabilization, 6 to 12 months, evaluate the need for continued medication because guardian will want to know how long to continue. Coming to conclusion, there is a great concern today that children are being overtreated with medication, especially in US. By contrast, many countries make so little use of medication that it seems probable that children who could benefit do not receive it. Undertreatment is perhaps a bigger problem globally than over-medication. With limited availability of professionals, the low-resource countries should focus on service delivery to reach to the widest population. Thank you. Give us a happy world for children with good treatment. Thank you.
Thank you, sir. Well, now the session is open for questioning. There is time for, 2 or 3 questions.
Mike. Okay.
Devashish, your first question.
अच्छा ठीक है सर के बोले नहीं था तार पर तुम्हें बोले
हाँ. First question was who should be members of the team? For some years I am trying to propagate this. Every MBBS doctor, every graduate doctor should be taught something about psychiatry and especially about children and those who will practice in pediatrics. Other are school teachers and parents. These are the most important members of the team. Psychologists and the sociologists and all. Of course, that we talk all the time. But this thing is very important, that every doctor should know some basic things about children and their mental states and functioning. And so also the teacher and parents. Thank you.
Yes, I agree, sir. Anton, please.
The case vignette you presented at the onset.
Yes, I know many people will differ. Yes, please.
Actually, we also tend to see a lot of such patients who, following a febrile illness.
Yes.
Develops actually a similar behavioral problems like clinging, excessive sleepiness, and like other behavioral problems, somewhat increased sexuality like fondling of genitals. My question is that, and many times we do not get a history of bipolarity in those cases. So, is it a low-grade infection of the brain, like encephalitis, that results in a slight disinhibition and disorganized behavior for the time being? That is, as you told, can be treated with quetiapine or sodium valproate and other things. That is my first question. And the second question is that you, at the onset, you started with that question, which was not answered. Actually, do we need team in our country, in a low-resource country? Do you need a team to deal with a patient who is having a psychiatric disorder, means child who is having a psychiatric disorder? I have a friend like who did not come back from UK to India because his second child was having autism, and he felt that there the social support and one-to-one help that the child will receive, the probability of that and the child getting better was much more. Yeah. If we take any of the cases of child psychiatry, like mental retardation, we need psychologists to measure and subsequently to follow up and teach different techniques so that the child gets like integrated in the society and the family and in the mainstream. If we take like autism, again we need me book to implement for his improvement in day-to-day behavior.
Yeah.
For conduct disorder, oppositional defiant disorder, we require parent management training, PMT, so that other than the drugs, we can use behavioral controls that the family can implement. So I feel that for psychiatry to be practiced, child psychiatry to be practiced, a teamwork has to be very essential. And I also differ on your telling that the low resource country, we may be low in terms of like financial resource, but so far as manpower is concerned, it is a gap actually. We have a lot of manpower, but we have less training. If the training can be imparted, I think many people are interested in working with child health, and they can be usually incorporated in the team without much like degree or qualification. Yes. And they can be used for helping the children.
Yes, actually whatever you were telling, exactly the same kind of feeling, with same kind of feeling I also presented this, but maybe I was not so clear or could not reach you. The first question was that after febrile illness there are autoimmune theories, there could be biological elements in it, and they have a stereotypal presentation which speaks of some biology of it. That's true. But my highlight was not there. My highlight was on that even for any reason, if you are getting a child psychiatric patient who is presenting with depression, and if you don't take the history of bipolarity, you may be instrumental in inducing a mania which is not desirable, because this is a patient who is of biological origin of some due to febrile illness, 2 episodes of febrile illness giving similar condition. So you have very high index of suspicion that fever must be the cause. But when there is history of bipolarity, you will have to be extra cautious. And I was talking only about being extra cautious. Means when I have seen these days that antidepressant is written by any physician, any pediatrician, any quack, anyone. In fact, writing escitalopram and clonazepam combination is maximum from the rural side. So my point is that when we want to educate them, we need to educate the dangers of prescribing these drugs, that you need to be cautious. Not that we don't stop them from prescribing, but they should be also cautious. So that was one thing that I wanted to highlight by the case beginning. The other thing is, the whole aim of the presentation was that in this globalized world, in this world of wide use of internet, we all know that the facilities could be many. But when it comes to hard truth, the truth is that we don't have any facility. Means in West Bengal you don't have a child psychiatric hospital, you don't have a child psychiatric, proper child psychiatric unit, you don't have a properly trained child psychiatrist, the whole of the state doesn't have one. So that kind of situation we are existing, but we cannot stop working. The problems do exist, that 10% of our children suffer from child psychiatric problems. So you will have to find solution. So here we will have to forget the classical that you need to have a social worker, you need to have a child psychiatrist, you need to have a child psychologist, you need to have teachers working with you. This team concept is basically a Western concept, and which evolved over 70 years. That they have been working with this concept, and we have not started working. So my proposition was that whoever is interested and has little understanding, like a general practitioner, like a pediatrician, like any teacher, any graduate, anyone who is interested in the matters, so educate them as much as they can take. not that you need to educate the whole child psychiatry to them, but they should have some awareness that they learn to identify problems, they learn to bring the child to the facilities, that kind of, with that kind of notion it was presented. Actually, this is a part of presentation. I'm doing a workshop in Calgary, Child Psychiatric International Conference on the same topic. So that's 1.5 hours presentation, and here it is just 20 minutes. So I did part of it, and so it's might have seemed to you that it is incomplete and I didn't give the full message, but that is all.
The only issue is that, like, I don't agree that it is a Western concept. What is important is helping the child. That is most important, and it has to be practical and like client oriented.
No, this is, I also don't mean Western. This is an ideal. This is an ideal that they have achieved over time, and we are nowhere near them. So we should not think from there that we want to achieve that. First, let us achieve some basic place, and then only we can think of going further. If you don't start, I have seen that people are scared of prescribing children medication. People will always say that no, child psychiatry is not possible because we don't have the setup. But that is not going to help the children. Ultimately, I have heard in Burdwan, DAB used to be used for giving intravenous by earlier doctors. That is how the science emerges and science reaches a place.
Thank you, sir.
So our next speaker is Dr. Swagata Sinha. She did her MBBS from Calcutta National Medical College. She got her training in psychiatry from Nimhans, Bangalore and Calcutta University. She is working at Monovikas Kendra Research and Rehabilitation Institute for the Handicapped since 1994. Her areas of interest and research are genetic aspects of ADHD and autism. She has got over 30 publications in international journals.
Sir, with your kind permission, the organizers just need to make one announcement, please. Just for a brief second. Thank you.
I have a small announcement. Like we have from the organizing committee, we have arranged a small memento. It's called Mishti Mukh. It's there. A coupon is given in your batch of coupons. It's Shita Bhog Mihidana from Burdwan. So for few of you who are leaving today, so please collect it from the registration stall before you go home. It's from us for you to take home. Thank you.
Thank you, sir.
Good afternoon, everybody. I'm the last speaker, and I think everybody's saturated with a lot of academic things, so I'll just keep to the time. But I just want to tell something to Dr. Devashish Kona that you said that we don't have any facilities in Calcutta. We do have. I mean, there are lots. There are lots. We have in Manovikas Kendra, we have in the Peerless, there are other hospitals who are having a multidisciplinary team. And let me tell you, the government is also aware, because we have this Sharbushikka Abhijan where, you know, children who have problems, they are identified by the school, and you know, they have this little place where they can go for help, you know, autistic, ADHD and all. So it's not that we are so bad, okay? We are doing some work. And yeah, but I mean, there are a lot of people, and schools, all schools have, most schools have psychologists, and the teachers are also being made aware of different problems of children. So I don't think we are all that bad. Anyway, okay. So today my topic is sensory processing disorders in autism, and so why do we need to look into sensory processing disorders in autism? It's because there's a high prevalence of sensory symptoms ranging from 60 to 96% in children with autism spectrum. And we think that the sensory processing differences likely contribute to many of the higher order cognitive and social deficits of ASD. And it also has been seen that white matter pathways which are involved in processing sensation show decreased connectivity in multiple parieto-occipital tracts, the areas that handle basic sensory information in the posterior part of the brain, and also the inferior fronto-occipital fasciculi, the inferior longitudinal fasciculi, and the fusiform amygdala and fusiform hippocampus. All these tracts are critical for socio-emotional functioning, and these are the things that we see problematic in children and people on the spectrum. So now, what is sensory processing? Now, this concept was first brought on by Dr. Jane Ayers. She was an occupational therapist and an educational psychologist who worked with children, and she felt way back in the late 1960s and 70s that there was something wrong which contributed to the problem. So she came up with this concept of sensory processing. So what is it? So in sensory processing, we take in information from our surroundings, we interpret the information and develop a response to it. So we can also say that the sensory processing or sensory integration is a neurological process that occurs in all of us, and we constantly take in sensory information through our bodies from the world around us, and as our brains organize or integrate this sensory information, it becomes meaningful to us. So normal sensory integration allows us to respond to the specific sensory input we receive automatically, efficiently, and comfortably. So how do we, so what are the agents to which we take in the information? We have the familiar senses, the 5 familiar senses, which all of us know we studied in school. The auditory sense, the perception of what one hears, information from your ears. The gustatory, perception of taste, texture, temperature, and flavors, information through the mouth. Olfactory, perception of what one smells, information received through the nose. Vision, perception of what you see, information through the eyes. The tactile, the touch sense, information received through the hands and the skin. And then we have the 2 hidden senses that respond to sensory input that is inside the body. So what they are also called the power senses. It is the proprioceptive system. So muscles, joints, and tendons provide the person with a subconscious awareness of the body position via the feedback from receptors in the muscles, tendons, and joints. And what do we use the proprioceptive system for? We use it for motor planning, and we use it for awareness of the body in time and space without constantly visually monitoring. And then we have the power sense also, the other one, that is the vestibular system. The vestibular system refers to the structures within the inner ear, the semicircular canals, and these structures detect movements and changes in the position of the head. And the brain needs the vestibular input in order to function. So what are the impact of the hidden senses? We are not consciously aware of the hidden senses. We cannot control them and we cannot see them. But along with the tactile system, these 2 hidden senses are fundamental in laying the groundwork for a child's healthy development. When the hidden senses operate automatically and efficiently, a child is able to focus his eyes, ears, and attention to the task at hand. So now, we'll briefly look at the 4 levels of sensory integration because these are the levels which are affected in people who belong to the spectrum. So the first is level 1, where the primary sensory systems, by the age of 2 months, the tactile sense, the vestibular sense, the proprioceptive sense are all developed. By the age of 1 year, that is the perceptual motor foundations are laid down. So the body awareness comes into being, the bilateral coordination and lateralization, hand preferences, and motor planning or praxis. Level 3, by the age of 3 years, auditory perception, visual perception, eye-hand coordination, the pencil skills, visual, motor integration, purposeful activity. Now, these are the areas which are often, many of these areas are often affected in children who belong to the spectrum. And usually when they come to school in the kindergarten, that is when all the complaints start coming, that the child is not holding the pencil, he's not writing, he's moving, moving out of the classroom, he's not sitting. And in level 4 is the academic readiness by 6 years. So you attain the academic skills, complex motor skills, regulation of attention, organized behavior, specialization of body and brain visualizing, and self-esteem and self-control. So this is just the 3 parts of the sensory processing. There's the input from our senses, the integration in the central nervous system, and the output. The result is the adaptive response, the learning process. So what is sensory integration dysfunction or sensory processing dysfunction? It is the inability to take in, organize, and respond to sensory information in a meaningful and appropriate way. So the sensory processing disorder can be visualized in these kind of 3 domains: sensory modulation